current treasurer of RSSDI National, and he will talk about the controversies and confusions in obesity diagnosis and management, which is the most important topic of today's talk. And Dr. Pratap Jethwani does not require any introduction. Dr. Pratap, please start.
Thank you, Dr. J.K. Sharma, sir, for kind introduction. Thank you, Supratik, Meenal, Arvind, Gaurav, and the entire team of AMOCE for inviting me to be part of this symposium. So I will be speaking on controversies and confusions in obesity diagnosis and management. So I will just touch upon the few aspects where there is a lot of confusion and controversy, either related to diagnosis or management of obesity. So this is the definition as per the WHO web page, that obesity and overweight, that means abnormal or excessive fat accumulation that poses risk to health, and body mass index of 25, over 25 is considered overweight, and over 30 it is considered obese. And we all know that the prevalence is rising very much. Since 2000, there is explosion of obesity epidemic across the globe. And if you see, currently in 21st century, 2/3 of these individuals, they are lying in lower middle income countries as compared to the 1/3 we are there in the high income countries. So in high income countries, it is getting plateaued, but it is still rising rapidly in low and middle income countries. But we all know that only BMI is not sufficient. This is the classical picture which you must have seen in number of conferences, Professor Yadnik with Professor Yudnik. Both of them, they are having same BMI, but on DEXA, if you see, then the Professor Yadnik is having 2.5 times body fat as compared to Professor Yudnik. And this Professor Yadnik got interested in this phenomenon, and he worked upon to find out what is the comparison between Indian babies and the white Caucasian babies. And they proved that the Indian babies, they are smaller at birth. In spite of having less birth weight, they were having more amount of fat as compared to the Western counterparts, less amount of muscle and viscera. And probably this is the reason we call that thin fat Indians. So our BMI is not high, but still for same BMI we carry lot of body fat, and that is the reason we are at risk of developing number of cardiometabolic disorders. And that's why BMI alone will not do justice as far as obesity diagnosis in our country is concerned. And that's why we have come out with this to remove this confusion or controversy. We have come out with this classification of obesity for South Asians, where overweight means when the BMI is more than 23 up to 25, and obesity means when the BMI is 25 or more. And also waist circumference cutoffs are there, waist hip ratio and body fat percentage cutoffs are also there if you want to diagnose obesity by those means. But still the BMI holds true, and the cutoff is 23 for South Asians. To add to the confusion, now there are various phenotypes of obesity. So there are people who are actually having high BMI, but they are not having any metabolic abnormality, and that's being termed as metabolically healthy obesity. And those who are having obesity associated with number of metabolic disorders, that is being termed as metabolically unhealthy obesity, and that depends on the individual's body fat percentage, overall insulin sensitivity and other things. Also, in normal weight, now we, particularly in our country, there are people who are having normal BMI, even BMI is less than 23, but still they are having lot of visceral fat, which contributes to the low insulin sensitivity, there is low muscle mass, and this contributes to the higher risk of metabolic disorders. They are having metabolic abnormalities, and that is being termed as metabolically unhealthy normal weight and metabolically healthy normal weight. So, in spite of having same BMI, a person may be metabolically healthy or may be metabolically unhealthy, and this also adds confusion. Which person to treat and how to treat, because it becomes difficult that depending on one parameter, how can we treat that person. To add further to the confusion, this is the paper which was published in Lancet, where they have come out with this concept of clinical obesity. That is definition and diagnostic criteria of clinical obesity. And they say that if there is an excess body fat, and if there is no other signs or symptoms attributable to obesity or comorbid conditions, then we can consider it as a preclinical obesity. And if it is associated with signs and symptoms or organ dysfunction or limitation of daily activity, then we can consider it as clinical obesity. So this is further confusion. There is obesity, there is clinical obesity, and they say that the clinical obesity, this fulfills an important conceptual gap in the notion of obesity because it provides clinical identity to the characteristic alterations of organ function which are directly caused by excess adiposopathy independent of other obesity related diseases. And the same has been replicated in our country by Professor Anup Misra and the team of India Obesity Commission members. And they again define that in our context, if BMI is 23 or more, and if there is no signs or symptoms suggestive of limitation of daily activity due to obesity or no other comorbid disease, then we can consider it as stage 1 obesity. And if it is associated with either limitation of activity or comorbid conditions, then we can consider it as a stage 2 obesity. So as per this definition, most of the people, they will be either having stage 1 obesity or stage 2 obesity. Normal individuals, the number of people who are having normal body fat percentage, normal body weight as per the Indian standards without any problem will be much less. So this is about the controversies and confusions as far as diagnosis of obesity is concerned. Let's come to the pathophysiology. So till date we are believing that the energy balance model, it works for the development of obesity for excess body fat gain. So primary dietary drivers as per this hypothesis is energy dense ultra processed foods which are high in portion size, high in fat, sugar, less in protein and fiber. And because of that, there will be a modulation through endocrine, metabolic and nervous system signals, and that will result in impact on brain in the form of food reward, increased appetite, sensory processing which is affecting energy intake. Ultimately, energy intake will go up, positive energy balance will develop, and all these fuels, they will be in the circulation. So here, the circulating fuels will be very high, and that will result in the development of fat storage inside the adipose tissue, and that will result in excess body fat and the development of obesity. So this is the general concept which we all believe in. But there is another group which proposes that the obesity is mainly driven not by energy balance, but it is being driven by carbohydrate insulin model. What they suggest? They suggest that when you take high glycemic load and high sugary or fructose containing diet, that results in alteration in insulin to glucagon ratio and GIP to GLP-1 ratio. And because of that, what happens, whatever amount of fat is there in the circulation, that will get stored inside the adipose tissue. And that adipose tissue fat storage, because of that, the circulating fuels, they will go down, and the brain will sense that the body is not having enough fuels. So that will result in energy intake, and that will ultimately transfer to the positive energy balance, and that will result in the development of excess body fat, excess weight gain, and that is termed as obesity. So this model, it focuses on specific food subgroups, and they say that if you reduce the glycemic load, if you reduce the carbohydrate load, the sugary and fructose containing foods in the diet, that will help you in losing weight. But these are two schools of thought, and both of them, they feel that their concept is right. So this is another controversy which is related to as far as pathophysiology of obesity is concerned. Let's come to the impact of obesity. We all know that obesity is linked with excess mortality. This is preliminary data over a period of 24 years. If somebody has gained weight, which was normal at the beginning, then that is associated with excess risk, mortality, all-cause mortality, CV mortality, everything goes up. And that we all agree upon, and there is a lot of concepts, a lot of evidence to support this. But there is obesity paradox. There are certain groups of people where overweight and obesity, it translates into better outcomes as compared to the normal weight subjects. And this holds true, particularly for chronic heart failure, for chronic kidney disease, for critically ill patients, as well as for certain kinds of cancers. So this is first data from the diabetes, although this study has many flaws, but the people who were overweight, they were having better outcomes as compared to the people who were having normal weight at the beginning of diagnosis of diabetes. And the findings were consistent across various categories, and they have adjusted for smoking and other CV risk factors. If we see this all-cause mortality with overweight and obesity using BMI, this is 97 studies, more than 2.88 million individuals and more than 270,000 deaths. Relative to normal weight, both obesity, grade 2 and 3, they are associated with significantly higher all-cause mortality, but grade 1 obesity is not associated with higher mortality, and overweight was associated with significantly lower all-cause mortality. And the same holds true, this is for chronic heart failure. CV mortality, total mortality is much higher in underweight individuals as compared to the obese individuals. And the same holds true. This is the CKD data and this is the heart failure data. In both these graphs, if you see those who are underweight, they are at much higher risk of mortality as compared to those who are either overweight or obese. They are faring better as far as survival is concerned. And this is again the same data from heart failure, very large study, and they concluded that who were underweight, they were at the greatest risk, but only where body mass index was recorded within 3 years of death or end of follow-up. Now, whether it has got direct relation or it is because of the severity of heart failure that they are having cachexia and they are underweight, that is difficult to understand. Still, in spite of this paradox, we can say that obesity is a chronic disease. It is associated with a lot of complications and therefore it requires comprehensive prevention and management. There is much more evidence to support the management of obesity as compared to dwelling into this obesity paradox. This is related to cancer. Some oral cancers, they behave better if the patient is overweight. In same way, the mortality with lung cancer goes down when the patient is overweight or obese. I will not dwell into the dietary controversies because there are a variety of diets which are available for weight loss, and we all know that each diet has got pros and cons, so I will not go in details of that. I will just touch upon the management aspect, the GLP-1 based therapies. We all know that these are the molecules which have changed the way we practice obesity management. Previously, we were not having any molecule which provided even 5% weight loss. Now we are having molecules which can give even up to 20% weight loss, and molecules which are in pipeline, they can give even up to 30% weight loss with once a week injectable therapies. And all these molecules, this is the systemic review and meta-analysis of GLP-1 based therapies, and if you see, they provide mortality, 3-component MACE, and renal benefits, and the GI side effects are always there. And that is the reason why these molecules, they are not tolerated, and there is lot of withdrawal. This is one of the data from the Western countries published in 2025. The people who were on GLP-1 therapies, half of all patients that discontinued within first 6 months because of side effects in 36% and medication cost also in 23%. If you see that most of the people, they were not able to tolerate and they were not able to continue it for a longer period. Now what happens if we give them GLP-1 and either they don't tolerate or they stop after a few months? There is rebound. There is going to be a rebound. This is step 1 trial extension, where 1 year after withdrawal of once weekly semaglutide and lifestyle intervention, 2/3 of weight was regained, and so the systolic blood pressure and all the CV risk factors, went up. So there will be yo-yo. If you give them GLP-1, they take it for 6 months, 1 year, and then they stop. There will be a regain, not only in body weight, but also in body fat, in blood pressure, in lipids, everything will go up. And the same has been proven. This is one of the systemic review and meta-analysis of 18 randomized controlled trials. Again, they have proven that if you stop it, there will be a clinically significant reversal of all therapeutic benefits, not only body weight, BMI, systolic blood pressure, fasting, HbA1c, lipids, everything will go up once the patient will regain weight. So it is of prime importance that you tell patients that this is a chronic therapy and they need to continue it lifelong. And we still don't know how to continue for a maintenance. Still, we are in gray area that how long we have to continue and how the
Dr. Pratap,
maintenance
please
therapy will
wind up.
continue. Yes, last slides. So this is about pre-pregnancy use. Again, if you stop before pregnancy, there will be a more weight gain, higher risk of preterm delivery, GDM, and hypertensive disorders of pregnancy. There is sarcopenia risk. There are some cancer risks also. They are very trivial, not much of concern. So to conclude, I will say there are many controversies in the field of obesity, both related to diagnosis and management. But recent advances in basic understanding of pathophysiology and development of better anti-obesity molecules, they promise a better future as far as obesity diagnosis and management are concerned. Thank you.
Thank you, Dr. Pratap. May I now invite you to please come on this side, because the topic is very complex and the heading is Chai Pe Charcha. So we'll listen to the other speakers, and after that we'll get the tea also. And now I invite Dr. Rajesh Kesri. Dr. Rajesh Kesri is the Executive Council member of RSSDI, and he will speak on reimaging the global diabetes agenda, progress, failure, and road ahead. Please go ahead, Dr. Rajesh, and please stick to the time. Thank you.
Thank you, sir. And I would like to thank the organizers, in particular Dr. Supratik Bhattacharya, Dr. Gaurav Bhaduri, Dr. Anchan Kalia, and the whole organizing team for these wonderful arrangements and for the invitation. Thank you so much. We know that the problem of diabetes that we are facing here is enormous. It's an enormous burden that we are facing. There are almost 830 million individuals, adults living with diabetes globally, of which 101 million are Indians. And the pre-diabetes burden, it's a bomb which is going to soon explode, is also 136 million in India. So it is projected by 2050 that there would be 1.3 billion adults living with diabetes globally. If we look back into the history, from the data that we could find from 1920 onwards, if you look at the epidemiological transitions of disease while comparing non-communicable and communicable diseases, we can see that mortality because of the infectious disease has significantly gone down, both globally and in India. Whereas the morbidity and mortality due to non-communicable disease has increased and is still increasing both globally and in India, even though globally we see some stabilizing trends, especially what concerns ischemic heart disease. And this is also a very interesting slide in which I have put up, superimposed the global trends in consumption, production of edible oils, sugar production, diabetes prevalence, and life expectancy. As we can see here that since the data is available since from 1950 onwards, the life expectancy has been increasing. And we can see together with that, that the global GDP is increasing. We are having, the GDP is increasing. And we can see other metrics also, that the production of the global sugar production and edible oil production is increasing. Together with that, we see a very sharp rise in incidence of diabetes. This is the global picture. The regional burdens are varied. In Africa and low middle income countries, Africa faces the steepest projected growth from almost 1.5 times by 2050. The Western Pacific carries the highest absolute death toll, that is 1.2 million in 24 alone. Southeast Asia and Eastern Mediterranean have fewer than 4 in 10 adults who receive glucose lowering medication despite almost 20% prevalence. But is that all? Have we made any progress or not since the evolution of diabetes? Now, diabetes has been known to us since thousands and thousands of years. But significant progress in understanding of diabetes has been made beginning 19th century. You can see the timeline here when in 1869 pancreas and islets were identified. It took us some time to discover insulin, which was discovered in 1921-22. In 1936 and 70s, we had the major classification of diabetes, type 1 and type 2 diabetes, juvenile and adult diabetes. And in the 90s, this understanding expanded to the genetics, autoimmunity, insulin resistance, environment, lifestyle, inflammation. And today we have a better understanding of diabetes, the pathophysiology of diabetes. We have understanding of the epidemics of diabetes, and we are in a better position to treat and manage diabetes. And similarly has been the evolution in treatment of diabetes from 1921 with the discovery of insulin, in 50s and 60s, the discovery of sulfonylurea, in 57, metformin, bigonides, and in 90s onwards, we had multiple different medications like DPP-4s and AGIs, thiazolidinediones. And now we live in the era of GLP-1 agonists, SGLT2 inhibitors, and we know dual and triple agonist drugs, which have profound impact on treatment and management of diabetes. Similarly, there has been a significant progress in the evolution of insulin and insulin delivery devices from isolation of insulin to production of bovine and porcine insulin and NPH insulin, Lente and other insulins, and now we have reached a stage where we have once weekly insulin for the management of our diabetes patients. Together with different devices, the progress, significant progress which has been made in insulin delivery devices, now reaching to fully automated hybrid closed loop insulin pumps. And on the pharmacological front also, there has been progress which we can defend with evidence. The DPP-4 trial has shown that lifestyle interventions can reduce diabetes incidence by 58%. There has been cardiorenal protection and benefit, which we have seen in EMPIRIC trial, LEADER trial, and there are many trials which have conclusively proven that these agents are beneficial in improving the life and the lifespan of our patients. And there has been a significant fall in the complications rate, especially in US. Now talking about failures, where have we failed? Now this is a curve that we can no longer outrun with 830 million diabetics worldwide, 14% global prevalence, and 59% untreated as of 2022. Now this is somehow an unsurmountable barrier, the HbA1c of 8 to 8.3, 8.4. I've been trying to find out in literature what has been the HbA1c trend since the HbA1c itself was discovered. That was in, I think, 1968-69, and it has been widely in use and standardized by 1990s. Somehow the HbA1c, even in developed countries like US, has also not changed significantly. there had been a minor change, a decrease in their average HbA1c levels of diabetics, both those on insulin and on OHAs, which had been from 7.6 to 7.2, which again climbed back to almost 8%. And as we know that in our country also, the average HbA1c is around 8.3. So somehow, even with the availability of so many drugs, so many agents, which we have especially seen in the past 2 decades, we have not been able to bring down the average HbA1cs. We have not been able to do justice to our patients and to the diabetes community as such. This is an important understanding in the diabetes care cascade, that is awareness, treatment, and control. So this serves as a critical framework for evaluating how effectively public health system manages chronic disease populations, and in this case, diabetes. So diabetes is a hidden epidemic. It is an epidemic now, it is not hidden. We are aware uh, that only 27.5% individuals may be aware of the condition, 21.5% might be receiving the treatment, and only 7% the disease is controlled. Among adults aged 15% and over in India with diabetes, only 27.5 were aware of their condition. This is the National Family Health Survey data from 2019 to 21. This translates to 1 in every 4 individuals with diabetes between ages 15 and 49 being completely undiagnosed. And globally, type 2 diabetes remains largely preventable and potentially reversible if identified early. There are socio-economic disparities which deepen the gap. Individuals in India's lowest wealth index group face significantly higher risk of re-imaging undiagnosed, remaining undiagnosed, and age-sex adjusted awareness rates are substantially lower among poorer and less educated. There are 5 system failures defining the crisis. The scale, the prevalence has doubled. It has not only doubled, if you look at the numbers in India from 1970 to now, it has almost increased 10 times. Missed targets, only 8 of 100 countries met their diagnosis or statin targets in 21. Insulin access, 1 in 2 needing insulin for type 2 diabetes doesn't get it. Analogs cost more than 1.5 times the human insulin, and 3 companies control 90% of the market. And financing, NCDs receive approximately 1.6% of development assistance for health, grossly misaligned with the disease burden. The care cascade, where do we stand globally in that? Only 63% diagnosed, BP controlled in only 71%, and glycemic control achieved in 63%. At the control stage, we are reaching the final frontiers. Control represents achieving simultaneous clinical targets for HbA1c, blood pressure, and lipids, the ABC criteria. So, 7% diabetics with disease under control, 7.7% combined ABC targets achievement, and 9% poor glycemic control threshold. So, socio-economic concentration of control, diabetes control outcomes, fasting, blood glucose, and triple targets are consistently more concentrated among higher socioeconomic strata individuals. Diagnosis is delayed, more than half remain undiagnosed, and there are structural barriers to detection. Treatment rates remain critically low, we have talked about this. Now, how about the road ahead? This is the WHO Global Diabetes Compact. It was issued in 2021, which states that there are 800 million plus diabetic adults living with diabetes. There has been a more than 4 times increase in prevalence of diabetes since 1990s. The global targets set by this compact and committee of WHO are 80% should be diagnosed, 80% should achieve glycemic control, 80% should at least achieve blood pressure control, and 60% of those who are above the age of 40 should be on statin therapy, and 100% of type 1 diabetics should have access to insulin. The core pillars of action here are research and innovation, medicines and technology, and prevention and health literacy, and country support. So what works? Evidence-based interventions demonstrate that health equity in diabetes is achievable with comprehensive targeted strategies addressing financial, clinical, community, and environment factors. It is very important to address all the factors responsible for the explosion of diabetes. Diabetes care equity. Achieving diabetes equity requires immediate coordinated action across health systems. These four priorities must guide implementation strategies at every level. It is important to track the socio-economic status, disaggregated data, improve affordability and access, strengthen primary care, recognize equity as quality. Technology can also be very helpful in bridging the gap. I think what we should address now is primordial prevention, and since this is an RSSDI forum, I would like to inform the audience that we have taken up this as a big step. We are organizing school education programs for children's, and soon there's going to be a program in Kolkata also. Dr. Supratik Bhattacharya would be conducting, and I invite all of you to engage in such activities of educating school children about diabetes and the metabolic challenges, because primordial prevention is the only way forward.
Thank you,
There have
Dr.
been
Rajesh. Please wind up.
diabetes care initiatives, just two more slides, sir. The village adoption program by RSSDI, a number of villages across the countries have been adopted, which provide treatment, monitoring, and support to the village population. We did a mass screening camp at Mahakumbh last year in which we screened more than 40,000 individuals free of cost. This data has been published. There are many government initiatives also in this direction. So, thank you.
Thank you very much. Since it is an RSSDI program, of particularly this session and all people have been involved, please join us here. And we will have the discussion at the end. So, my one appeal to everyone who is not a member of RSSDI, please take membership of RSSDI. And now I invite Dr. Faraz Farishta from Hyderabad. Dr. Faraz will tell us about the GLP-1 diet. What is the myth and what is the reality? Dr. Faraz, are you here? Please. I think all our speakers are well known to the audience, to all of us. So I will not introduce Dr. Faraz much, but he is director of Faraz FS Endocrine and Diabetes Center. Please go ahead. Please stick to the time. GLP-1 diet, what are the myths and what is the reality?
Slide changer. Slide changer. नहीं, ठीक है, मैं इसे कर. So, good morning, sir. Thank you, and then thank you, Supratik, again for, I think, organizing such a wonderful conference at this lovely city. In this era of GLP-1, I think now we all know that we are going through this very interesting times where we have moved from this diabetic care to metabolism, and then now we are talking so much about the GLP-1s. So when we talk about GLP-1, I think we've spoken, I'm sure yesterday also there will be so many talks which have been done on it's not changing. So yeah. Yeah, thank you. So I've been going to talk on what is the diet which you have to give to your patients. I think it has become now very easy where you have to give therapy, how do you have to start the therapy. So just going on a little basic of GLP-1, I think we all know, but GLP-1 is a naturally occurring incretin hormone secreted by the gut, we know, in response to the food. So I will again not go more into that, but I think these are certain times where some drugs have come out, and then it was primarily for diabetes, and then later we realized that it has a lot in metabolism, obesity, and weight loss as well. So you will see there is a shift in the GLP-1 therapies. I think when we started way back, it was diabetes, and now we're talking more about weight loss and metabolism. And then this era of, I would say, digitalization, the world has become a very small place. Today, if there is something which has come out in Europe or US, it will take minimum seconds for it to reach to India, because any good paper, anything which is done, it is all influence. So you will see the celebrity and social media influence. We have seen that what has happened with the GLP-1 therapies, and then we have science as well to back that up. So if you want to give the diet, you just have to understand few basics. What does it do? So it slows the gastric mechanism. It delays the gastric mechanism. The beauty of GLP-1 is it acts on the homeostatic and your anhedonic pattern. So it not only reduces your appetite, it reduces your cravings. It will reduces your cravings for your foods which you enjoy. There is the brain-gut axis connection, which we all know, and then definitely there is the insulin regulation benefits also. Approved label, you will see in India now, we have right now 2 approved indications. Yes, in diabetes and diabetes with CVD for primary reduction, and in obesity as well. But now I think there are so many other pleiotropic benefits, probably some indications which we are knowing, MAFLD, obstructive sleep apneas, PCOD. I think there is many round the corner. There is dementia. So there is a paper which got published last week on Alzheimer's dementia, the role of GLP-1 in that. So let's see the common myths which happen. So myth 1, it is a magic shot with no effort. So sometimes what happens is people now feel that you take the injection and within a week or within 2 weeks, you will start changing the way you look, you will start changing the way you present. This is absolutely what I think we have to tell our patients, that this is not a magical shot. So it is, we are not just talking about numbers, we are talking about real change in metabolism. Role of nutrition quality is very important, because we all know what GLP-1s can do. There is protein loss, there is muscle loss which can happen with these therapies. So definitely in this era or in this journey of weight loss, when your patient is having weight loss, muscle loss is also a part of the journey. Long-term sustainability. I think this is again a big time debate, that how long do you want to continue and what happens if you stop. I think we have seen that in the step-up trials, we've seen that in pioneers, we've seen that in n number of trials, that once you have stopped the therapy, within 5 years, 35 to 40% of the patients have again gained back the weight. So myth 2, weight loss is fat loss. So again, we all feel that if I am losing weight, it is, if I am losing fat, that is the total loss which I am having. But here you will have to understand that the lean muscle mass is also being lost. So it is very important to preserve that lean muscle mass. And then importance of protein and resistance training. I think this is again a myth which we have to seriously tell our patients, that the protein intake and resistance training has to be inculcated in your patients. Myth 3, the side effects are just tummy trouble. So now when we talk about GLP-1, I think most of the time patients or most of us believe that it is either diarrheas, constipations. This is what it is causing, but we all know that there are certain serious side effects also, specifically in patients who had history of pancreatitis, patients who had past history of gallbladder, potential thyroid carcinoma. So these are the few things where if you are starting this therapy, always do ask your patients about these underlying problems or complications. And then we have seen this, I think Ozempic phase is now most of us have seen that it is one of the common entity, and then Ozempic butt phenomenon as well. Again, myth, it's safe for everyone. Now it has become more of a commercial and a cosmetic product where you will see in parlors, in beautification, during marriages now, this is a part of a therapy. The patients take this, within 2-3 months they lose some weight and then the entire thing goes off. So you have to remember it is not safe for everyone. It has its own strict contraindications. As I said, history of medullary thyroid carcinoma, history of MEN, pregnancy and breastfeeding, drug-drug interaction. So there are certain clear-cut no's that you do not have to give for your patient. So it is safe for everyone is again a bigger myth. Managing the common side effects. So how do you tell your patients? Again, diet, which we have to tell, the dietary strategies for nausea. They have to have small meals, frequent meals, and more of protein meals. Divide your meals in 4 to 5 times a day. Take more of proteins. Hydrate yourself very, I think it is very important. And the titration also has to be very specific. You just cannot jump, say, from 0.25 directly to 1 or 2.4. It has to be systematic so your patient gets that benefit. And then you have to tell your patient, most important, if you develop abdominal pain and vomiting, do not just think that it could be only a GE. It could be a pancreatitis, which is very rare, or it could be an underlying gallbladder stone, cholelithiasis, which was missed when starting this therapy, which got aggravated. So any pain, abdomen and vomiting, you need to tell your patients that if you develop this, you need to come back and show to your physician. Lifetime, I think there is a long debate which is happening now. How long do you continue it? The rebound effect. So if you stop the therapy, it's just that weight gain, you are getting it back, or the pleiotropic benefits which your patient had, also they are losing that as well. So that is again a big debate, that how long, how fast are they gaining it back? And then the cost of stopping therapy, because we're not just talking about numbers. When we are talking about management, it is not just we're looking at the waist reduction. We are looking at it as a complete metabolic profile, where we are looking at the inflammatory parameters, we're looking at central obesity, we are looking at the other comorbidities, reduction in the CVD. So you'll be surprised that within 3 to 4 weeks, the CVD reduction happens as early as that when you start a GLP-1 therapy. So social and economical ripples, yes, economic disruption, but I am glad that now we have the generic versions. Again, that opens the Pandora's box. We have to see which ones are the good ones and which are more beneficial to your patients. Addressing the stigma of obesity, it is very important that we talk to our patients when we are talking about this. And then supply chain and access challenge. I think when we are talking about the generic therapy, the cold chain is going to be a very, very important key leader in all these supply, because that is one of the most important parameter. So a future of weight management, I think yes, now we have 2 Gs, we have 3 Gs, we will get 4 Gs, more Gs will keep on adding, we are going to get more good new molecules. But there has to be an important note which we have to give to a patient, that lifestyle management is still holds very, very important. That if I put you on drug, that doesn't mean that you leave your lifestyle. Lifestyle still remains the goal therapy. And then these therapies have to be started by a physician. It is not unqualified doctors, unregistered practitioners who are doing it just for some cosmetic reason. So it is a complex therapy which has to be done by a specialized doctor. So the key takeaways would be, we know established GLP-1 therapy. It is very good, it is very comprehensive, but it is not magic. It has its own side effects. So you need to remember that and tell your patients that what I am giving is not magic. It will have its own benefit, but at the same time, it may have its own risk as well. And empowerment is very important when we are giving it to our patients. We need to empower them with the entire process of the therapy, and then it has to be under a strict medical professional guidance for management of obesity. So thank you so much for your patient listening.
Thank you, Dr. Faraj. Wonderful presentation. Please join us here and listen to Dr. Manoj Chawla about the diabetes-specific nutrition. What are the pulse? Dr. Manoj Chawla is the Joint Secretary of RSSDI National, and he hails from Mumbai, and he's a man of technology, CGM. We can equalize Dr. Manoj Chawla with CGM. Please go ahead with the nutrition.
Thank you, Chairperson Dr. Sharma sir, and thank you all of you who found your way here this morning. Can I have my slides, please? It will eventually happen. So we heard 3 wonderful conversations today, and I'm going to move ahead on that, speaking specifically on diabetes-specific nutrition. You heard aspects of GLP therapies, retention, and what's happening there. Let me speak on the diabetes-specific nutrition part. I am contracted for this talk, is my disclaimer. Can somebody come here from the events team? Yeah, I need the expansion. Okay. So recent guidelines consistently recommend medical nutrition therapy for people with diabetes-specific nutrition. So MSN or MNT is an important component through the diabetes care continuum and can actually reduce A1C as much as 2% if done rightly. The recommendation has been revised to clarify that weight loss of 5 to 7% of baseline body weight can reduce progression from even pre-diabetes to diabetes. Substantial weight loss recognized as a primary facilitator of diabetes remission. Today we understand that, and meal replacements can improve glycemic control, facilitate weight reduction, and improve metabolic health even in times of effective GLPs and dual peptides that we are using. Formulations which contain slow-releasing carbohydrates such as isomaltulose stabilize the blood glucose levels and reduce glycemic variability. What are the clinical benefits of DSN formula over standard formula? So that's the question we ask ourselves and the patients ask us as well. So diabetes-specific nutrition formula, if you look at it, it has lower glycemic index. The complex carbohydrates with high fiber, protein, and presence of MUFA add more value to the same. Clinically studied to provide better glycemic control and weight management. Can be used as partial or total meal replacement. So depending on what is the conversation you're having with your patient, very often you can start with partial meal replacements and move to at least one meal completely replaced and lactose and gluten free. Diabetes-specific formula is superior to standard formulas, which are many such, so-called just protein shakes or supplements available in the market. It offers superior prandial glucose control, improved glycemic variability, increase in the GLP, improved mean blood glucose, reduced hyperglycemia, but also reduction in hypoglycemia, reduced insulin requirement, reduced healthcare resources and cost, and decreased mortality. And when I'm making these claims, I will show some data to substantiate why these labels are there with the diabetes-specific nutrition formulas. There are more than one DSNs available. So are all diabetes-specific nutritions out there which have the name in their protein shakes or powders with diabetes coming in? Are they all the same? Well, let's have a look. So advances in diabetes-specific nutrition have focused on evidence with innovation in key nutrient composition. So what exactly is used in your diabetes-specific nutrition is going to be important, and that's why they are not all the same. A use of unique blend of advanced carbohydrate like isomaltulose, presence of right fiber, both soluble and insoluble, and myo-inositol is adding this value to the specific diabetes-specific nutrient formula we are talking about. Leads to slowly digested carbohydrates, myo-inositol, isomaltulose, insoluble and soluble fibers being present. Then the protein and fat blend also has to be right in these formulas. Dual protein blend with use of casein and soy protein, and fat coming in from the right blend of MUFA and PUFA. Micronutrients are important when you use and choose your DSNs with the right composition of vitamin Ds, B complex, selenium, zinc, chromium, iron, and so on. All of them also in certain ways linked to insulin sensitivity. So unique blend of advanced carbohydrate, fiber, and myo-inositol. What exactly it's offering? So when you look at the advanced carbohydrate system, it is blunting the postprandial glucose response. It is improving glycemic control, improving insulin sensitivity, and reducing A1C in patients with type 2 diabetes. What does this myo-inositol offer further? So myo-inositol supplementation is an important insulin second messenger that enhances glucose utilization into the cell and can improve insulin sensitivity. And then the right aspect of fiber, both soluble and insoluble, with their shared benefits, land up with reduced energy intake, increased bulking effect, increased satiety and reduced weight gain, and balancing out the gut hormones with reduction of your inflammatory cytokines. Now this becomes important, and that's why you use these DSNs and at a specific time. Somebody who's going to complain to you, I feel very hungry by late evenings, doctor. Now your patient with diabetes taking the diabetes specific nutrient formula in the evening is not only providing them good amount of protein and nutrition, but also the fiber in there is ensuring some amount of bulking up and reduction in your appetite. So the excess hunger that you may have there is brought down by the use of this perfect blend. Benefits of a high quality protein and heart healthy lipid blend in advanced DSN formula. So the proteins present there improve glycemic control, help in weight management, preserve muscle mass. So today your concern and for us showed that when you're using GLPs today, one of the important aspects and question is how do we retain the muscle mass? And that's where the right DSN or protein formulas are extremely important. Well, lipids, again, the right amount of MUFA, PUFA there improves fasting insulin and glucose level, improve the HOMA, IR, and beta cell function, and also have an impact on the lipid profile. So maintaining an optimal balance of various micronutrients is essential in diabetes management. Your patients with diabetes are often micronutrient deficient. Having this right blend of the various micronutrient mentioned will help in reduction in blood insulin levels, improve glycemic control, again improving insulin sensitivity, possibility insulin and dose drug reduction, reduction of A1C and reduction in overall sugars. So which patient profiles need a DSN formula? Who are we talking about? Is it for a specific group? Well, not really. Most of them would probably benefit from the DSNs, those who have long-standing diabetes with comorbidities, even somebody who's newly diagnosed with diabetes. I would say somebody with pre-diabetes wanting to prevent progression to diabetes, it's going to be a huge area where this can benefit your individuals. Patients with diabetes on GLP-1s. So today, of course, the renewed interest in DSNs is because of our increased use of the GLP-1 RAs and the dual peptides. And of course, it can be offered to your patients with GDM. How does DSN formula aid in managing the blood sugar level? So let's look at the evidence. DSN helps in significant reduction for both A1C and fasting, up to 0.9% reduction in A1C at the end of 3-month period with the intervention group using DSN as compared to your control group. 120 subjects used it for 3 months. You're seeing a reduction in fasting sugar of 19 milligram percent with A1C down by 0.9. This is Dr. Mohan's study showing significant reduction in MAGE, which is your mean amplitude of glycemic excursions, by 17% by using DSN in type 2 diabetes. So one of the, again, important aspects of right DSN is reduction in glycemic variability, and there's the evidence for the same. Do they help in weight management? Yes. The DSN formula significantly improves weight and thereby reduce the BMI. 5 times greater decrease in weight with DSN as compared to a group where DSN was not used, and similarly significant improvement in BMI as well. Impact of duration use on the weight and A1C, and you're seeing different studies, a 3-month study by Mohan et al. Which showed some improvement. You are looking at a study by Chi et al. At 6 months, which is showing significant reduction in A1C, and then you're seeing Shashank's study at the end of 12 months showing much prolonged reduction in A1C by the use of DSN formulas. What is the role in reducing cardiometabolic risk? So you start looking at the cardiometabolic risk factors. Evidence today that there is reduction in waist circumference by using DSN in your patients with diabetes, reduction in blood pressure, triglycerides coming down, and improvement in HDL. So all the favorable cardiometabolic points that you're looking at, DSN in its various studies has shown evidence there. Is there any clinical evidence that this myo-inositol has an impact on insulin sensitivity, the claim we had? So this is looking at an insulin secretion sensitivity index. It was the highest with DSN formula. What they did was use different food items to see what is the impact on insulin secretion. So you're using rice porridge, it will stimulate and push out insulin. You're using bread with jam, it will push out, but still the diabetes specific formula had the maximum impact on increasing insulin secretion. DSN formula with myo-inositol, up to 2 grams of myo-inositol significantly increased your HOMA beta, talking about its impact on insulin sensitivity and secretory capacity. How does this complement the GLP-1 therapy? Well, today is the time, as we said, for GLP. So DSN formula has shown 2 times reduction in fat mass and 2 times increase in the fat-free mass, and that's something that all of us are now tracking by either using your DEXA scans or using your bioimpedance assays. You have a machine outside for in-body, and any of you hasn't done that, please go and get your body composition analyzed. It's extremely helpful. So the decrease in percentage body fat and increase in fat-free mass is another benefit which was seen in this 90-day study by use of diabetes-specific nutrient formulas. They further significantly reduce visceral adipose tissue. So again, you're looking at the 90-day study where it is showing gradual but continuous reduction at day 45 and day 90 of the visceral adipose tissue. Significantly reducing waist circumference and hip circumference as well. Again, aspects which are going to help in reduction of overall cardiometabolic risk and become today's strong aids when you're using effective GLPs and dual peptides. The drug is doing its job. A lot of your patients are going to be looking at when can I get off it, used it for weight management. Using aspects of these meal replacements allow them to take a break if required. So finally, let me conclude, Chairperson, sir. DSN formula as part of medical nutrition therapy is considered an integral component of management of diabetes. Advanced diabetes-specific nutrient formulas contain complex carbohydrates with fiber and myo-inositol, and that's what all of you should be looking at, that what exactly is the content overall, not just that my protein supplement has 20 grams or 25 grams or 30 grams per portion. It goes way beyond just the protein content. In patients with long-standing diabetes with comorbidities, DSN use improves glycemic control, promotes weight loss, improves compliance, and reduces risk of cardiometabolic complications. Approach to prescribing DSN formula using 1 to 2 servings optimized to BMI and patient preference. So that again, and of course the palatability of the same. In patients with diabetes on GLP-1 RA therapies today, diabetes-specific nutrient formula reduces the risk of nutritional deficiencies and preserves muscle mass. And I think that is the biggest strength of this aspect in today's time. And patients who are newly diagnosed or with pre-diabetes or minimize the introduction of medications or let patients prevent from progressing from pre-diabetes to diabetes. With that, thank you once again for being here.
Thank you, Dr. Manoj, for very timely. Please join us here. I know you are getting late for your breakfast. Okay, thank you. So, dear friends, before I take the questions from the floor, let us take the advantage of Dr. B. M. Makkar, who is a master in obesity research, obesity management, and he represents the Obesity Task Force as the chairman in the International Diabetes Federation. He is president of the All India Obesity Research. So, Dr. Makkar, please your comments on all these four, one comment each. Please give mic to Dr. Makkar.
So, thank you, Dr. Sharma, for very kind words. I think the first thing is, first presentation by Pratap was wonderful. He very nicely highlighted the nitty-gritty of understanding of obesity and the recent confusion caused by Lancet Commission definition and the newer definition, which are constantly changing over last 2 years. Also, he highlighted very important point of obesity paradox, which is seen in people who have heart failure or who have undergone angioplasty. This is a specific group, and certain more groups where, you know, usually these groups have people who have terminal illness. So they are already emaciated and their higher weight is considered to be productive. But it doesn't undermine the importance or relevance of obesity as a very important chronic relapsing disease, which he highlighted very nicely. Then Rajesh Kesri very nicely highlighted the, what should I say, the socio-cultural, geopolitical aspects of how nutrition is changing over time, how the trajectory of, all these parameters is changing. This is not my area of expertise, so I can't comment on this. Faraz nicely highlighted the usage of GLP-1 and the nitty-gritty of GLP-1 and dual agonists and how they are important. But he also highlighted the importance of, intermittent, the discontinuation of therapy, which is again very important challenge we are facing. And of course, Manoj highlighted the use of supplements. I think we cannot go on with the diabetes or obesity management without use of supplements in the current era. They are very important part of, you know, what happens is people think just cutting down the diet will take care. But once you are just cutting down the diet, you are cutting down the nutritional component and protein also. So you have to supplement protein, minerals, vitamins while you are reducing the calories. So nutrition supplementation is also very important.
Thank you, Dr. Bridge. Now it is open for any questions, any comments from the audience. Quick two questions only. So I think the topics have been made very simple and understandable to all. With that, I thank every speaker for the wonderful presentation. Thank you very much. And we close the session.
হ্যালো Good morning, the respected delegates and the speakers. So we shall move to next session, that is clinical parts in bone metabolism. And for this, we have renowned speakers, and may I call upon the stage Dr. Lakshmi Nagendra from Mysore, whose talk is Beyond BMD, using DEXA to decode bone health, body composition, and metabolic risk. So Dr. Lakshmi Nagendra is a very well-known speaker, and I invite him.
Thank you, sir, for that kind introduction. So good morning, everybody. The first session in the clinical pearls on bone metabolism will be how we use DEXA to decode bone health, body composition, and metabolic risk. So we'll be talking about two aspects of bone health, that is trabecular bone score and vertebral fracture analysis, and also talk a little bit about body composition using DEXA. So we know the WHO diagnostic thresholds to diagnose osteoporosis and bone mineral density by DEXA is most commonly used to diagnose this, but beyond this, what can we use DEXA for? So majority of the individuals who fracture actually are not in the osteoporosis range, they have osteopenia. So DEXA, which does the bone mineral density, does not capture the quality of the bone. So how can we go beyond that? Because we have non-BMD determinants of fracture. BMD is a very major determinant of fracture, but it's not the only determinant of fracture. So this is where TBS comes in. Trabecular bone score is a textural index. It does not directly assess bone microarchitecture, but it evaluates pixel gray level variations in the lumbar spine DEXA image, providing an indirect parameter of the trabecular architecture. So when you do DEXA, you can do TBS as well in the same scan and get information about the microarchitecture of the bone. So for example, you have two patients, patient 1 and patient 2. Both of have lumbar BMDs mentioned here. But if you look at the TBS, they have different TBS. The first patient has TBS of 1.3 T2 and the second patient has a TBS of 1.226. So the microarchitecture, if you see, is degraded in the second patient. That's why the second patient has a worse bone microarchitecture as compared to one, even though they have a similar, almost similar BMD. And there are many cutoffs for the use of TBS, but largely this is what we follow. TBS more than 1.35 is normal bone. Between 1.2 to 1.35 will be partially degraded bone, and less than 1.2 would be degraded bone. So these are examples of some TBS reports at our institute. As you can see, this patient has a BMD T-score of minus 1.9, but when you look at the TBS, it's very low. It's 1.031. So in spite of having a BMD in the osteopenia range, patient has very low TBS, suggesting low microarchitecture. And when your patients, suppose you have 10 patients with similar BMD, the fracture risk increases when TBS decreases. So that's the importance. And we have done several reviews which show that trabecular bone score may be low in conditions such as type 2 diabetes or type 1 diabetes, even when BMD is normal, even in endocrinological conditions like pheochromocytoma or paraganglioma. When your BMD is normal, TBS can give you good information about the bone microarchitecture. So many clinical circumstances where you can use TBS for clinical decision making. I would say when your T-score is close to treatment thresholds. For example, your patient has a T-score of minus 2.3, minus 2.4 is not reaching the threshold of minus 2.5, but your TBS is low, then you can actually begin this patient on treatment for osteoporosis. So going on to the second aspect, it's vertebral fracture analysis. So we know vertebral fractures are the most common sites of fragility fractures. But about 1/3 are clinically apparent. 2/3 are asymptomatic. You don't even know if your patient has these vertebral fractures. So it's important to recognize asymptomatic vertebral fractures because that can change the treatment paradigm in your patient. So it changes your patient's diagnostic classification to osteoporosis because presence of fracture itself is enough for a diagnosis of osteoporosis. So again, vertebral fractures are associated with significant morbidity and mortality. And if your patient has an asymptomatic vertebral fracture, they're at very high risk of having a symptomatic fracture from then on. So these are the indications. ICD 2023 lists out certain indications for VFA. So if women aged more than 70 years, historical height loss more than 4 centimeter, undocumented prior vertebral fracture, glucocorticoid therapy, more than 5 milligram of prednisolone or equivalent for 3 months. All of this is an indication to do VFA. So how do you order VFA? With your DEXA scan, you can ask for VFA and you'll get this information. So what exactly is VFA? So we do semi-quantitative visual grading of vertebral fractures. You can have mild, moderate, and severe, 3 grades of fractures, and you can have different types of fractures, wedge, biconcave, and flush. So this is an example of a scan that we did at our institute. So this shows a T12 severe compression fracture in a patient who was actually asymptomatic. So this will give you extra information from DEXA on vertebral fractures as well, and it has very good sensitivity and specificity for grade 2 and 3 fractures, not so much for grade 1 or mild fractures. So it has several advantages as compared to the radiographs. For one, the radiation is very, very low when you compare to a spine X-ray. So you can ask me, why go for a VFA? You can as well send the patient for an X-ray. But the advantages, you do this with the same scan as DEXA. You have information on bone mineral density. You also get information on VFA. So that saves an extra scan and also saves radiation exposure to your patient. And of course, lower cost because it gets done in the same scan as DEXA. Going on to the last agenda for the session, body composition by DEXA. So this is an example of a body composition report by DEXA. Most of you might have seen it. So what are the components? You have the pictorial representation, yellow, orange representing fat, red representing muscle, and blue representing bones in this report. You have the standard region of interest. You have the demographics mentioned there. You have percentage body fat mentioned here. You have the BMI classification, the WHO classification mentioned. And how do you actually interpret it? Then you have the box on the left, which looks at regional fat distribution. Then we have adipose indices on the right. It gives you total body fat percentage and VAT area. And also you have muscle mass indices. So when we look at the diagnosis of obesity, this is the Endocrine Society of India guidelines to diagnose obesity. So by BMI, we know this criteria: more than 25 kg per meter square, waist circumference more than 90 centimeter in men and more than 80 centimeter. If you look at body fat percentage, this is where DEXA comes in. It's more than 25% in men and more than 30% in women. So how do we interpret this? So when you look at adipose indices onto your right, you have the total body fat percentage from your DEXA report. If it is more than 30% in women and more than 25% in men, that puts them in the diagnosis of obesity regardless of their BMI. And also the VAT area. So when you look at the VAT area, if it's more than 100 centimeters square, they have an increased risk for metabolic disorders. And if it's more than 160, it's at a very high risk for metabolic disorders. And of course, this also gives us information on appendicular lean mass index, the ALMI, which is a sarcopenia index. So again, how do we interpret this? Less than 7 kg per meter square in men or less than 5.4 kg per meter square in women is a diagnosis of sarcopenia. So let's quickly go through a couple of cases. So this is case 1. You have all the indices here. So when you look at the fat mass by height square, that is the fat mass index, and the lean mass by height square, the lean mass index, the first thing that you have to see is it adds up to the BMI. Otherwise, your report is wrong. So here it's 12.2 plus 11.1. It's adding up to 23.1. So that's the first thing to see. After that, you look at total body fat percentage. So here it's a male, 40.4 is high, of course higher than 25%. So this patient has obesity by increased body fat percentage, even though the patient has a BMI of 23.1. So this would be a thin fat phenotype, the typical phenotype that we see in Asians. Metabolically obese but normal weight by BMI but high fat percentage. Going on to the next case, so here you have total body fat percentage of 23.5, FMI and LMI adds on to BMI, that is normal. But if you look at the VAT area, that's less than 100, and at a BMI of 25.9. So this I would place in the category of metabolically healthy obese. So body fat percentage is low, VAT is low, even though the BMI is relatively high. So going on to the last case, so this is another patient with BMI of 23. You can see the appendicular lean mass by height square there, which is 4.6. So we looked at sarcopenia diagnosis. So again, with DEXA, we use the muscle strength, the hand grip strength less than 28 kg for men and less than 18 kg per meter square for women, gives us a diagnosis of sarcopenic obesity. So the third case is where you would diagnose sarcopenic obesity based on ALMI, hand grip strength, and other strengths which look at muscle performance. So thank you for your patient listening. With the permission of the chairpersons and Dr. Supratik, if we could take questions now because I'm late for my flight. Thank you.
Sir, wonderful, talk. And as a cardiologist, I would like to know who are the patients we should be sending for screening with, and what's the clinical kind of relevance for us as, if we're treating heart failure patients or maybe ischemic heart disease patients. So for whom this screening is mandatory.
So you mean the body composition by DEXA? Yeah. So if you look at the guidelines, everybody should be screened because we have a phenotype of thin fat obesity where we have normal BMI but high fat percentages, like I said. But I know it's not very feasible because DEXA is not very easily available and accessible to everybody. So I would, in my practice, I kind of triage them. So when their BMI is high, we know that fat percentage also is likely to be high. Therefore, they don't need the scan as much as patients who have, you might have seen them in your practice as well, their BMI is normal, but their waist circumference is high. And they also have uncontrolled diabetes, high risk of cardiovascular. If you look at the metabolic risk, that's very high. So if in them, if you do a DEXA, that will tell you about the fat percentage. And of course, when we have now in the GLP-1 era, when we start on GLP-1 receptor agonists, we want to monitor these patients that they lose fat and not muscle. So in this context, it would be very important to, more than diagnosis, to monitor while on treatment.
Madam, I have one question. From the physician perspectives, what are the indication where we will advise the DEXA scan?
So for osteoporosis, so we have the Indian Society for Bone and Mineral Research guidelines. In women more than 60 and men more than 65, all men and women, regardless of their clinical risk factors, they should be screened with DEXA for bone mineral density. And at a lower age, if they have risk factors for fractures like a prior fracture or long-term glucocorticoid use, then it's even lower, say 50 years.
Thank you, madam. Thank you for excellent deliberations.
Thank you. Thank you.
Sir, next. The next topic is the normocalcemic dilemma, managing primary hyperparathyroidism in 2026. The speaker is Dr. Sattik Siddhanto. Dr. Sattik Siddhanto have actively participated as faculty, speaker, chairperson, moderator of the various national and state conference, and have co-authored chapters in the various textbooks, recipients of the honored certificates and awards in the undergraduate, postgraduates, and associate editor of the Bengal Journal of Physicians. I will request Dr. Siddhanto to start.
Thank you, Chairperson, sir, for the nice introduction. At the very outset, I must thank the entire organizing team of EMOCON for bestowing on, especially Dr. Supratik Bhattacharya, for bestowing on me the opportunity to speak in front of such an august gathering on a relatively rare topic. Well, I've been asked to speak on the normocalcemic dilemma, managing primary hyperparathyroidism as in 2026. As we all know that primary hyperparathyroidism, though relatively rare, however, it accounts for a considerable amount of endocrine referrals, hence probably the pertinence of today's talk. It is the leading cause of hypercalcemia encountered in outpatient department, and it accounts for a major proportion of endocrine disorders globally. early detections definitely prevents the skeletal and renal complications. There has been a changing disease in the paradigm change in the disease spectrum, where earlier days, severe symptomatic disease predominated, presenting with this classical skeletal and renal complications. The current trend has been increased towards relatively milder and an asymptomatic form of primary hyperparathyroidism, hence an I index of suspicion is necessary, and the driving factor has been improved biochemical screening. If you see in the Western counter, majority of patients are asymptomatic or an early presentation courtesy an early diagnosis and prompt treatment, as they're more amenable to screening. They are detected early via incidental hypercalcemia on routine blood examination, and there has been a lower risk of renal and skeletal complications. However, on the contrary, in the Indian, 90% patients with symptoms at the time of diagnosis, and there is a higher prevalence of severe bone disease and complications, and vitamin D deficiency or insufficiency remains a confounding factor in this part of the globe. So definitely a late diagnosis contributes to a higher disease in this part of subcontinent and a higher incidence of mortality and morbidity. Now coming to a topic proper, there is normocalcemic primary hyperparathyroidism, where what is it? Whether the serum calcium levels, be it the albumin adjusted or ionized calcium levels, remains normal with an elevated parathyroid hormone levels. Of course, after excluding the secondary causes like vitamin D deficiency, CKD, and medical history, which I am coming later on. So secondary hyperparathyroidism, normocalcemic hyperparathyroidism, and hypercalcemic primary parathyroidism remains the part of the same spectrum. Who knows, today's normocalcemic primary hyperparathyroidism may be tomorrow's hypercalcemic primary hyperparathyroidism, hence the role of early diagnosis and prompt treatment. So the key challenge, as I have already said, this normocalcemic hyperpara is predominantly a diagnosis of exclusion. Hence, one must always rule out the secondary causes. A thorough examination, a meticulous history taking, supplemented by biochemical testing definitely helps in confirmation of diagnosis. So one must always rule out the causes of secondary hyperpara first, and the commonest cause in our country is vitamin D deficiency, followed by chronic kidney disease. A thorough drug history, particularly diuretics, bisphosphonates and denosumab, the anti-resorptive agents, anticonvulsants like phenytoin, phenobarbital, and lithium. The relatively rare causes are hypercalcemia, hypophosphatemia, of course bariatric surgery, celiac disease, and pancreatic disease are the other miscellaneous conclusion. Now the main thing is why this dilemma in India? Because in the normocalcemic fog, there is widespread vitamin D deficiency, which creates a massive overlap with normocalcemic variant, resulting in high misclassification risk to secondary hyperpara. The diagnostic recessity remains important, and the lab variability, where assay variability of parathormone and vitamin D measurements is another layer of uncertainty to interpretation. I will not go into the details of the pathophysiology, just the trigger, the chronic vitamin D deficiency causes decreased intestinal calcium absorption, leading to compensatory secondary hyperpara. Cellular adaptation, that is continuous parathyroid demand, drives the parathyroid gland hyperplasia, and prolonged stimulation alter the set point of calcium sensing receptor. Eventually, monoclonal expansion may occur, leading to autonomous parathyroid secretion that persists even after vitamin D correction, manifesting as normocalcemic hyperpara. So vitamin D correction often, because increased absorption, may unmask the underlying primary hyperpara. And the symptoms, we all know of classical, the bones, the stones, the groans, and the moans. I will not go into the details, but primary normocalcemic hyperpara often, despite normal calcium, may present with osteoporosis, osteopenia, fragility fractures, and nephrolithiasis and neurocognitive symptoms. Many NHPT patients progress to hypercalcemic primary hyperpara, hence an I index of suspicion and early diagnosis and prompt treatment. And the main thing is premature preoperative localization is often difficult, resulting in higher incidence of multiglandular disease, and often the patient may require redo surgery. Probably that's why the organizing team has selected this topic. The clinical manifestations more or less mimics a primary hyperpara with the neurocognitive symptoms. The symptoms on the bone like osteoporosis, osteopenia, and vertebral fractures, the renal system, nephrolithiasis and nephrocalcinoma, calcinosis, and of course the cardiovascular system also gets involved. So modern presentation is a dominant symptom. So 80 to 90% prevalence of vitamin D deficiency may cause a major diagnostic overlap, and vitamin D repletion often reveals true hypercalcemia in patients with previously normocalcemic variant. So diagnosis, as I've already discussed, elevated parathormone, serum calcium normal, after excluding all the predominant secondary cause like vitamin D deficiency, a normal renal function, a thorough medical history where all the culprit drugs has been excluded, and malabsorption, be it celiac disease, pancreatic pathology, or bariatric surgery, then only you can stamp the patient as normocalcemic variant. Vitamin D again remains a key confounder in this case. Low calcium intake is a nutritional driver, so dietary deficiency, however, one must remain the target intake of 1 to 1.2 gram per day, and normalization of calcium intake and ruling out secondary hyperpara remains of paramount importance before stamping the case as normocalcemic hyperpara. So ruling out secondary causes like vitamin D deficiency, CKD, medications, malabsorption syndrome remains one of the best approach. So diagnostic algorithm of normocalcemic hyperpara, one must, if the patient presents with normal calcium with elevated parathormone levels, it warrants an evaluation, followed by ruling out vitamin D deficiency, CKD, low calcium intake, and drug-induced effects. If the patient has vitamin D deficiency or insufficiency, you correct your vitamin D and reassess after 8 to 12 weeks. One must re-evaluate and confirm, because persistence of normocalcemia despite increased parathormone over at least on 2 separate occasions, at least 6 months apart, then only you can stamp your case as normocalcemic variant of hyperpara. The diagnostic gaps is low screening rate, hence a late presentation, already bone involvement and renal involvement occurs, and limited access to ionized calcium, which is the gold standard for assessing calcium status, is often unavailable in this part except the tertiary healthcare centers. The diagnostic approach remains the same, USG supplemented with a SESTA-MAVI scan for gland localization. However, in normocalcemic variant, often we fail to localize, and the patient may require a 4D CT or MRI if the initial imaging is negative, and particularly in the reoperative cases where the patient requires a redo surgery. The complications, the normocalcemic variant also has this grunt on the bone showing evidence of osteopenia, osteoporosis, and increased risk of fractures and progressive bone loss. It involves the renal system resulting in nephrolithiasis and nephrocalcinosis, and post-operative incidence of hypocalcemia, hungry bone syndrome, and increased vitamin risk is increased with concomitant vitamin D deficiency. Surgical management remains the gold standard, and we should always recommend surgery in symptomatic hyperpara if the patient presents with organ dysfunction, be it on the bone, be it on the kidney, and in high-risk patients, in asymptomatic patients, particularly if your age is less than 50 years. Surgery is the definitive and gold standard therapy. Cure rate is approximately 99%, and it prevents further complications and organ damage. Non-surgical management for normocalcemic variant, the approach is risk-based, a thorough observation for low-risk individuals, and a close monitoring for high risk, and those that require surgery, go for a surgical management. And lifestyle adjustment, close regular monitoring. The role of pharmacotherapy is currently limited. A mandatory follow-up schedule include annual serum calcium measurements, bone BMD scans, and renal imaging to track for your disease progression. The key challenges is a high prevalence of vitamin D deficiency, which needs to be corrected first, a late presentation of the disease, so one must go for an early diagnosis and prompt treatment through regular screening, limited awareness not only among the patients but also the healthcare practitioners. Proactive calcium and vitamin D remains the only solution which will help in early diagnosis and timely intervention, thereby preventing the risk of mortality and morbidity. So a tailored clinical approach remains the key, adopting the global guidelines to local realities is crucial. One must correct the vitamin D first and consider surgery for high-risk patients, those with complications, or those individuals with potentially poor long-term follow-up. So the India-specific management should be once elevated parathormone is identified, check for the serum calcium. If it's high, it's a classical primary hyperthyroid. If it's low, one must go for a vitamin D estimation. If it's low, correct your vitamin D. And if normocalcemic and hyper post-correction diagnosis, if normocalcemia and hyperparathyroid persists, you can stamp your case as normocalcemic variant of hyperpara. And if hypercalcemia develops, then it's primary hyperparathyroid and go for surgery. For normocalcemic variant, go for risk estimation for the bone and renal disease. High-risk patient, go for surgery. Low-risk observation and serial annual follow-up. To conclude, normocalcemic variant of hyperpara is strictly a diagnosis of exclusion. One must always rule out the secondary causes, predominantly vitamin D deficiency first. Vitamin D correction remains central to the diagnosis, particularly in this part of the globe. Early detection remains and prompt treatment definitely significantly improves the health-related outcome. At the end of the day, surgery remains the definitive curative therapy for normocalcemic variant of hyperpara. Thank you all for your patient hearing.
Thank you. Thank you for your wonderful talk, and I think it is a very, very important topic. Do we have any questions from the floor?
Before we move on the floor, thank you, Satik, for eye-opener presentation for us. In case you feel the index patient is not at all fit for surgery because of other comorbidities, and at the same time having high PTH, what will be your strategy?
Then we can go for a bit of medical management which can help Sinacalcet or something.
What medical management?
Sinacalcet.
Yeah, that was I was discussing with Satroji just a couple of minutes ago. So his talk is open for discussion from the floor.
So I would just like to ask one question to you, because vitamin D deficiency is so common and almost every second patient comes with vitamin D deficiency. So when do you suspect and PTH is a test which is not normally done as a part of the routine. So for a primary care physician, what is your takeaway message, and how do you
I think time has come for routine vitamin D screening as well as calcium. So if the calcium is normal and vitamin D is low, correct your vitamin D first. And parathormone probably is not a routine test. So incidental detection, then only we think. But today's normocalcemic variant, maybe tomorrow's hypercalcemia. So our early diagnosis and prompt treatment remains the key. And these being asymptomatic disease requires a high index of suspicion, and routine screening is mandatory.
You know, in India, in spite of your best efforts, vitamin D level cannot be geared up to the desert level, because the Genitang and all these things affects the Indians.
Absolutely.
So that's really a point to ponder.
Absolutely.
Okay. So in the US there was a fortified milk preparation. So they get vitamin D from in that way. In our country, is there any program or what we can do?
There are about fortification, as you have said, there are some programs, but that should be more generalized, I think. More awareness is necessary as far as vitamin D is concerned.
It should be a part of the awareness
national
programs, because
absolutely.
Osteoporosis is also an epidemic.
Absolutely, sir. Silent epidemic.
It's a serious epidemic. You know, a fracture in the hip joint.
Absolutely.
Very costly and comorbid.
Absolutely.
So thank you, Siddhant. Next, I will call one of my brilliant students and young star in the endocrine brigade, Dr. Arindam Ray. He will take us through chronic hypoparathyroidism, transitioning from calcitrol to replacement therapy. Over to Arindam. He is an exceptionally good student, has all these feather in his cap.
So I need not read out everything. I straightforward invite Dr. Odindam for his talk.
Thank you, sir, and it's my great pleasure that I'm just speaking in front of my mentor, Professor Ashish Vasu. And thanks the organizer, AMOCE-EMOCON, and special thanks to Dr. Subhadeep Bhattacharya and Gaurav, definitely for making this possible to present here in the platform. So my topic, just the other side of the coin, as Dr. Siddhant told about the hyperparathyroidism, just I'm going to the reverse side of the page is the hypoparathyroidism. And definitely we all know that hypoparathyroidism is not a very common problem, so it's a very rare disease, rather I say, and definitely in our general practice, we should be, very much suspect the disease in the very strict way so that we can detect this kind of problem. But problem is not here in during the diagnosis, but we should concentrate here what is the treatment options we have and what is the transition from the regular treatment of this calcium and calcitriol. We're moving to the different, the form of the plan, this treatment in this era of 2026. So this is the content I will discuss in the next 10 minutes in my presentation. And definitely, as I have already told you that the hypoparathyroidism is a very rare endocrine disorder. It's a deficiency of either the parathyroid hormone or its action leading to hypocalcemia and hyperphosphatemia. So when you say the chronic hyperparathyroidism, it's more than a duration of 6 months, that is by definition, and it's most of the times that happens after the next surgery that is related to thyroidectomy. So these are the different the causes, if I elaborate, but just to make it brief, most of the times the 75% or the 2/3 of the cases actually because of the post-surgical, that is the hypoparathyroidism, but in the other, the 25% have different causes, including the idiopathic one, the immune one, with the autoimmune disease, and some of the drug induced at the same time, the genetic components, which can be a rare possibility of the hypoparathyroidism. So the incidence, if you say about, definitely it's a very low, it's almost 6 to 38 people in 1 lakh population, and as already told you, majority of the cases are post-surgical. Now coming to the just a small discussion about the parathyroid physiology. We all know that the parathyroid hormone is very important for the calcium homeostasis. It actually leads to the decrease of the parathyroid leads to decreased production of the calcitriol, which is the active part of the vitamin D, and that leads to the decreased intestinal calcium absorption. At the same time, it leads to the hyperphosphatemia, which also the further suppresses calcitriol synthesis. So at the same time, the patient have the hypocalcemia and hyperphosphatemia, and that leads to the hypercalciuria, which makes the problem of the renal issue in hypoparathyroidism. So definitely, if you think about the PTH is a major regulator of calcium homeostasis. It acts directly on the bone and kidney, indirectly regulates the intestinal calcium absorption through the calcitriol, and definitely it maintains the serum calcium within a narrow range. And there is also a regulator which is called CASR, calcium sensing receptor, and via this calcium sensing receptor, calcium PTH feedback loop that happens in the human individuals. So what is the conventional way of treating this hypoparathyroidism? The goals of the therapy for the conventional treatment is definitely we have to ameliorate the symptoms of hypocalcemia. We have to maintain a serum calcium level to that of the low normal range or slightly below to the low normal range. If you think about the serum phosphate, that's the opposite. We have to maintain within a high normal range or slightly elevated. We have to avoid or minimize the hypercalciuria, and we have to maintain the calcium phosphate product at the level below the upper limit of the normal. So ectopic calcification that we have to avoid, that happens mostly in the basal ganglia of brain or the kidney. Now this is a conventional way of management, giving a high dose of calcium. So what is the normal recommendation is to give the 800 to 1200. In majority of the times we see in calcium hypoparathyroidism patient requires a calcium of more than 2 to 3 grams per day. And definitely the calcitriol, which is the active component of vitamin D, because there's no conversion of the vitamin D2 to D3 in this hypoparathyroid. So here we have to at least give the calcitriol, at least a dose of 0.25 to 2. In majority of the patients require 1 microgram per day. So when we give the calcitriol of more than 0.75, definitely we have to split the dose, and which is the regular brand available of 0.25, we have to give the 0.25 either twice or thrice daily. At the same time, the thiazide diuretics, this can do an adjunct here. So hydrochlorothiazide we can give in a very high dose, or the chlorthalidone, but definitely we have to think about the volume depletion at the same time, the dyselectrolytemia in this category, the patients who are receiving these thiazide diuretics. So the biochemical changes that happens, the calcium level actually fluctuates with this high dose of calcium and the active vitamin D. So there can be chance of both hypocalcemia and hypercalcemia. Patient actually have this kind of problems and require recurrent hospitalization sometimes. At the same time, we have to monitor, and the dose adjustment is very frequently to be done, at least once or twice monthly. We have to measure at the same time the high urine calcium that actually makes the more problem in the long run with the nephrolithiasis, nephrocalcinosis, and definitely leading to the CKD. Again, the reduced phosphate excretion that happens because of the hypopara, that leads to the hyperphosphatemia, and active vitamin D may further increase the phosphate absorption. So the quality of life, that is a very important part of any treatment of the disease that get hampered. The patient have a recurrent fatigue, muscle cramp, paresthesia, impaired concentration, neuromuscular instability, the bone muscle pain, the difficulty in focusing, and definitely memory, and same time some of the neuropsychiatric problems at the same time, the anxiety, the mood disorders, especially the bipolar disorder, that's very common in hypoparathyroidism and sleep disturbance. Again, some of the limitations are there, like the high fluctuation level of the calcium with this high pill burden. Patient has to take 3 times this, the calcitriol and the calcium dose. At the same time, patient have the consistent hyperphosphatemia, hypercalciuria, leading to a chronic kidney disease, and definitely these are the issues that leads to the poor quality of life of patient of hypoparathyroidism with the conventional therapy of high dose of calcium and calcitriol. So this is the new era of the PTH. We have at least some molecules with the PTH, the regular PTH we have with 134. We have a PTH of 184 amino acid. At the same time, some of the new PTH molecules, the analogs, that's also available. So why we are moving to PTH instead of using this calcium calcitriol in this the therapy of hypoparathyroid? Because the PTH replacement therapy is an option for persistent chronic hypoparathyroidism. The replacement of the deficiency of the endogenous PTH. So always either think about the diabetes, either think about the hypothyroid. So always we try to replace the hormone that is deficient inside the body. So definitely in hypoparathyroid, if you can replace the original hormones, so that will be definitely is a good choice in any of the endocrine disease. Now coming to shift from the symptomatic management to physiologic hormone replacement, and definitely we have these recombinant PTH analogs that act on the PTH receptor to mimic the endogenous the PTH activity. So definitely our aim of the treatment of hypoparathyroid is to restore the normalize the calcium, the phosphate homeostasis, to reduce the dependence on the calcium and vitamin D, and definitely improvement of biochemical stability and overall well-being with a good quality of life. So these are the options we have. The teriparatide, the widely available parathormone, there is a 134. It's a biologically active in terminal part of the PTH. It maintains the serum calcium, normals the urinary calcium better than the conventional therapy, and definitely because of its short half-life of around 1 hour, we have to give either a continuous infusion or we have to give twice daily injection of the parathyroid. So that makes the sense in the patient, but definitely in India it is not approved at least for treatment of hypoparathyroid, because we are using this teriparatide molecule particularly for osteoporosis. Coming to the NAT para, there is a 184 parathormone. It's an intact native hormone replacing the full physiological PTH. It allows the reduction in the calcium and active vitamin D requirements, and definitely once daily is effective. It improves the biochemical control and long-term outcomes. The long-acting, the PTH analogs, that is a palopic teriparatide, is a very recent molecule that has been approved after the pathway trial and path forward trial in 2024 by the US FDA for marketing in America and Europe for the hypoparathyroid the treatment. And because of its long half-life, around 60 hours, so definitely, once a day injection is quite sufficient, and definitely we have this, the data on this, the palopic teriparatide in hypoparathyroid. So the mechanism definitely tracks on the parathyroid 1 receptor, and the activation leads to the downstream signaling similar to endogenous PTH. And the renal effects, definitely we have this increased calcium reabsorption, decreased urinary calcium excretion, and increased phosphate excretion, reducing the toxicity over the kidneys. So the systematic biochemical effects, we reach the eucalcemia, and it improves the serum, reduces the serum phosphate, improves the calcium phosphate balance. In skeletal effect, it's intermittent PTH, definitely we know it's an anabolic effect, whereas a continuous exposure by the pump, it can cause a catabolic effect and improvement of the bone turnover markers. So definitely the improvement of the, lowers the urinary calcium, improves the calcium phosphate homeostasis, reduces the pill burden, reduces the phosphate level, improves the quality of life, and it reduces the calcium level fluctuations. So definitely as the maintained serum calcium in normal range in all the studies that have been proved, at the same time it independence from the calcium and vitamin D by almost 93% of the patients of the hypoparathyroid. It maintains the serum phosphate and calcium phosphate product and restores the endogenous calcitriol level proven in majority of the studies. So definitely reduced hypercalciuria, that gives the renal benefit, significant reduction in the 24-hour urinary calcium excretion, normalization of the urinary calcium, to the tune of almost 178 milligram per 24 hours starting from 415 in baseline data, and suggests that improved renal tubular calcium reabsorption. Quality of life have been improved, and majority of the studies it's observed about 10 weeks that the HRQL scores were improved and significant improvement in physical functioning and well-being. The patient selection is very important, so definitely the patients who are poor control on the conventional therapy, we can't reach the normal calcium level. At the same time, persistent hypercalciuria, there is deterioration of renal function, particularly in patients, the young patients, and the patients who are requiring very high dose of calcium calcitriol replacement with a high phosphate and unable to maintain the serum calcium is important patients in this category. So definitely well-established permanent hypoparathyroidism adults, they are the candidates with a poor control despite of optimized calcium vitamin D, hypercalciuria persistent with renal complication, and patient requiring very high dose of calcium vitamin D are the candidates for the parathyroid treatment. Now coming to the contraindication, definitely advanced renal disease, one of the contraindication. The pregnancy, because we don't have the data. The concomitant bisphosphonate denosumab use, so we have to be very cautious about the hypercalcemia, the bone malignancy, Paget's disease, definitely the children, adolescents, because of, again, I'm just taking 2-3 minutes extra. Okay. And the children, adolescents with open this epiphysis because they have a high risk for the osteosarcoma, and the patients with unconfirmed permanent hypopara or the baseline hypercalcemia can be one of the contraindications. So the pre-transition assessment, we have to assess the serum calcium, phosphate, also the magnesium. Magnesium is very important because hypomagnesemia can cause this hypoparathyroid, and definitely we have to check and control the magnesium level from the very beginning. Again, we have to evaluate this hypercalciuria by 24-hour urinary calcium excretion. We can also go for this urine spot, the calcium creatinine ratio. At the same time, the ultrasound imaging and non-contrast CT for the patients to assess the renal status of the nephrolithiasis or nephrocalcinosis. The vitamin D assessment is very important because the patient who have a baseline vitamin D deficiency, we have to correctify it first. At the same time, DEXA at the beginning and in the follow-up, in both cases, it's very important. Now, parathyroid hormone is given as the subcutaneous injection, so there can be a lot of local reactions with that, and definitely we have to improve the calcium and the phosphate level, and we have to monitor accordingly. So this is the transition. We have to first individualize the patient. We have to the gradual transition from the conventional to PTH therapy. We have to start the PTH at recommended dose, to gradually, slowly taper the calcium and vitamin D level, and we have to monitor at least weekly or twice weekly, and we have to titrate the PTH to maintain the calcium and low normal range and minimize the urinary calcium renal risk. So this is the protocol. We have to at least reduce the 50% of the dose of the calcium vitamin D when we start the PTH level, and gradually we have to taper the calcium vitamin D, and we have to increase the PTH dose. So I'm just skipping these things. So the long-term outcome data with this regular monitoring is very important. Renal function and urinary calcium excretion we have to assess. And with the trabecular bone density that will improve with this form of therapy, and DEXA interpretation requires caution due to altered bone dynamics. The PTH therapy increases the bone turnover followed to normal. So the renal outcomes, again, there is a reduction in the urinary calcium excretion, lower the risk of both nephrocalcinosis and nephrolithiasis, and improvement of long-term safety. The quality of life, again, improved with this form of therapy. So considering the pregnancy, again, the calcium and vitamin D is true in the pregnancy. There is no data of the PTH therapy in pregnancy, so better to avoid. And there is some recent, the update about this treatment. So we have the eneboparatide, which is a long-acting agent for this PTH1 agonist that also improves the serum calcium, reduces urinary calcium. The calcilytics, that's encalcerate, is also there. There is studies that goes on with this endogenous PTH secretion, normalizes calcium. The transcon PTH with a sustained release, we have a good amount of data on the benefit of this form of therapy in hypopara, and insulin pump therapy with 134 amino acid. Again, the lower risk of at least 65% less requirement of the parathyroid in the pump therapy. So to summarize my today's talk, the conventional therapy that manages the symptoms but does not restore the PTH physiology, persistent biochemical instability and quality of life impairment remains the key challenge. Parathyroid replacement therapy enables the physiology of the calcium phosphate regulation, demonstrate the improved biochemical control, reduced treatment burden. Careful patient selection, transition monitoring is very important to get a better outcome. Individualized patient-centric approach is critical in long-term management, and definitely emerging therapies that promise the sustained, convenient, and physiological treatment options. Thank you for your patience hearing.
Thank you, Arindam, for exhaustive, informative, illuminating presentation. What we gathered, some very practical points that in all these cases of chronic hypoparathyroidism, sometimes magnesium deficiency is overlooked. So it is a take-home message that in all cases, not only calcium, phosphate, ionized calcium, all these things, vitamin D, but also the magnesium measurement is a must. That is number one. And number two, the treatment should be monitored so that we stick to the will adapt to the more ectopic calcification. And regarding these, your PTH treatment, everything you have alluded very nicely, but these are pretty costly. So I think it is
the cost, and there is some gray zones area like the duration of therapy. So there are the largest data that shows at least a 3-year duration, not more than that. So and also there is long duration treatment with PTH. There is increased chance of the osteosarcoma. Though it's animal studies they have mentioned in the rat models, but still the long-term data we don't have about the safety of the
because in also osteoporosis we don't recommend for long term.
So that's why some of the gray zones are definitely there, but we need long-term data to make it more comfortable.
Thank you,
Thank you, sir.
Because time constant, we cannot take up any question. So
Thank you, sir. Thank you, organizers.
Next speaker. So our next speaker is another very brilliant endocrinologist in the endocrine brigade. Dr. Omita Bosur happens to be our student. He will take us to the treatment of osteoporosis, hierarchy after biphosphonate failure. The osteoporosis is a silent epidemic particularly sweeping in India. We are talking of diabetes, but osteoporosis is also a knotty issue for us. So over to Dr. Amitabh Sur to take us through the osteoporosis treatment hierarchy.
Thank you, sir. Thank you for the kind introduction, and thank you, EMOCON, for giving me this platform. So in next 12 minutes, I'll try to speak on osteoporosis treatment hierarchy after bisphosphonate failure. So some basic points about osteoporosis which we have discussed. Osteoporosis is characterized by low bone mass and reduced bone quality, microarchitectural changes, which actually leads to fragility fracture, which in turn impairs mobility, adds to morbidity as well as mortality. So it is important to talk about osteoporosis. Also because osteoporosis is way commoner than we usually expect. Osteoporosis can be primary, which we see in men as well as women. Most menopausal osteoporosis, osteoporosis in older men, as well as secondary causes of osteoporosis can be there. So osteoporosis has to be diagnosed by doing a BMD DEXA scan, a FRAC score at the minimum. And after confirming osteoporosis, secondary causes of osteoporosis has to be ruled out, like diabetes, hyperthyroidism, hyperparathyroidism, hypogonadism, and so on and so forth. Autoimmune diseases can also contribute to osteoporosis, like rheumatoid arthritis, SLE, drugs like glucocorticoid, Cushing syndrome. These are the secondary causes of osteoporosis. Coming to a very important point, risk stratification in osteoporosis, because this will have therapeutic implications. We divide it into low, moderate risk, low risk, high risk, and very high risk. So for moderate risk, we define it as persons who do not have any prior history of hip or spine fracture, and their 10-year risk of hip and spine fracture is less than 10-year risk of hip fracture less than 3%, and major osteoporotic fracture less than 20%. BMD T-score is above -2.5 but below -1, that is in the osteopenia range. Usually treatment is not required for people who are in low and moderate risk. Now treatment is usually required in people who are at high risk and of course at very high risk. So who are the people who are at very high, who are the people who are at high risk of osteoporosis or fragility fractures? Those who have a prior spine or hip fracture or a BMD T-score at hip or spine of -2.5 or below, or a 10-year risk of hip fracture of more than 3% and major osteoporotic fracture of more than 20%. Now when we are using this criteria to define high risk, we must keep in mind the limitation of FRAX, which is often unable to capture the dose and the duration of steroid exposure, risk of fall, etc. Now who are at very high risk of fragility fracture? Those who have multiple spine fracture and a BMD T-score of less than 2.5, or a recent fragility fracture or fragility fracture on any approved osteoporosis treatment, or fractures on patients who are taking glucocorticoid or those who have very low T-score of less than -3 or below that, or those who have very high fracture probability by FRAX, that is risk of hip fracture of more than 4.5%, 10-year risk, and major osteoporosis fracture 10-year risk more than 30%. So why this differentiation is important? As I said you, the differentiation is important because it will have therapeutic implications. Adequate calcium and vitamin D intake, smoking cessation, etc. is important for all. Pharmacotherapy of osteoporosis is mainly divided into two parts: anti-resorptives and anabolics. Anti-resorptives which we use commonly are bisphosphonate and denosumab, and some others can be estrogen receptor modulators, calcitonin, etc. In anabolics, we use commonly teriparatide, and a very upcoming promising anabolic or a combination of anabolic and anti-resorptive, you can say, is romosozumab. Then there are other anti-resorptives like odanacatinib and saracatinib, which are also coming up, but they have not yet come. Now, general principles of pharmacotherapy remains the same. We have to characterize osteoporosis, and also risk strategization is very important. And whatever treatment we use, we have to ensure adherence, and so that there is no failure of, we have to keep monitoring the patient for any possible failure of therapy. In general, in patients who are at high risk of fracture, which I have already stated the category, we start treatment with bisphosphonates. Now, I will not discuss bisphosphonate, as the topic itself is what comes after bisphosphonate failure. So I am skipping this. Now, how do we say that the patient is failing on bisphosphonate? Now, bisphosphonate failure is basically inadequate therapeutic response to treatment, which is defined as 2 or more new fragility fracture, especially vertebral, while on effective therapy in a compliant patient, or change of bone mineral density less than the least significant change while on therapy. What is least significant change? That is in terms of BMD done on the same machine, usually preferably by the same observer, but that's difficult. It is 5% for the lumbar spine, 4% for the femur neck, and 5% for the total hip. So if the BMD change is less than least significant change, then also it means that it is therapeutic failure. And also failure to see significant decrease in bone turnover markers. Any of these is fulfilled, we say that it is bisphosphonate failure. Usual reasons are non-compliance, absorption issue, and inadequate calcium and vitamin D intake. Sometimes if you miss secondary osteoporosis, then that can also be a reason for bisphosphonate failure. Now, when we look beyond bisphosphonate, that's important point. We look beyond bisphosphonate in patients who have high risk of fragility fracture when a patient is showing either bisphosphonate failure, which I have already told what it is, or if the patient is having some problem taking bisphosphonate. It can be related to compliance, particularly for oral bisphosphonate. It can be because of SSBT, that is severe suppression of bone turnover, leading to maybe osteonecrosis of jaw or atypical femoral fractures. Or it can be some inhibiting reason like CKD, where bisphosphonates cannot be used. So either bisphosphonate failure is not the only reason when we start looking beyond bisphosphonate. Apart from that, those patients who are at a very high risk of fragility fracture, which again I have stated the criteria previously, I am not repeating, for them, we try to look beyond bisphosphonate. Right at the beginning, we try to start with anabolics. Then we switch over to bisphosphonate or denosumab for that matter. Now, denosumab is a fully human monoclonal antibody to rank ligand, which is an essential osteoclast differentiation factor. It is an alternative to bisphosphonate given 60 milligram subcutaneously every 6 months. Denosumab should not be delayed, and it should always be accompanied if you stop denosumab, it must be accompanied with bisphosphonate to lock the gain. The advantage with denosumab, which we saw in freedom trial also, that the BMD gain is usually higher compared to what we expect with bisphosphonates, number one. Number two, there is fracture risk reduction definitely at hip, at vertebral fracture, non-vertebral fracture, clinical fracture, all fracture risk comes down. And the good point is, the BMD gain continues, unlike bisphosphonate where the BMD gain, it stops after 3 to 5 years. But for denosumab, the BMD gain continues even as long as 10 years. We have data to suggest that BMD gain continues for as long as 10 years. Denosumab can also be used in osteoporosis in men, and as well as glucocorticoid-induced osteoporosis, also osteoporosis or the fragility fractures in patients who are having malignancy. There also it can be used. The greatest advantage of using denosumab is it can be used in CKD also till CKD stage 4, although the fracture prevention data is less promising in CKD compared to those who do not have CKD. Then there are some agents which we do not use very regularly for the management of osteoporosis, but can be used, is like selective estrogen receptor modulators like raloxifene in patients who are having low risk of DVT and high risk of CA breast. HRT and tibolone can be used in patients who are having low risk of DVT but are having bothersome vasomotor or climacteric symptom and who are less than 60 years of age, less than 10 years post-menopause. Calcitonin, which we do not use nowadays often, but can also be used 200 IU per day as a nasal spray. This is as an alternative to bisphosphonate. Now, coming to post-menopausal women who are at very high risk of fragility fractures, teriparatide, abaloparatide can be used. Teriparatide offers superior BMD gains in patients who are having osteoporosis, very high risk of fractures compared to bisphosphonate. So teriparatide should be used ideally at upfront, and it should be followed by bisphosphonate or denosumab to lock the BMD gain. Teriparatide has an anabolic window. If you use it early, there is early bone BMD gain. which can be locked by subsequent use of bisphosphonate or denosumab. Now, one question comes that whether we should use sequential bisphosphonate denosumab or combination. So it has been seen that if you use sequentially, it is better. Data is more suggestive of sequential use of teriparatide followed by denosumab. But if you use combination, then teriparatide has to be used with IV zoledronic acid. You cannot use combination of them in as a both of them together with oral bisphosphonate, otherwise the BMD gain will be less. Romosozumab is an anti-sclerostin inhibitor. It is a combined anabolic and anti-resorptive agent. It is used as 210 milligram subcutaneous injection for 12 months. It also has to be followed by bisphosphonate and denosumab to prevent the BMD loss, which will happen after, if you do not use it. Romosozumab has been seen to be superior compared to alendronate in the ARCH trial so far as fracture prevention, vertebral, non-vertebral, as well as clinical fracture, as well as BMD gain. Romosozumab has also proven superior to placebo in post-menopausal women in the FRAME trial, where superior bone BMD gain and much better fracture reduction has been seen with romosozumab compared to placebo. Romosozumab has also been seen to be better compared to teriparatide in the structured trial, where it lead to less incidences of vertebral and non-vertebral fractures, as well as higher BMD gains compared to teriparatide in patients who were earlier treated with bisphosphonate. So structured trial also proves that in case of bisphosphonate failure, when you are planning to use an anabolic agent, you can better consider romosozumab than teriparatide. Odanacatab and saracatinib. Odanacatab is a cathepsin K inhibitor, 50 milligram weekly. It has to be used. It is not yet available in India. Odanacatab has been seen in LOFT and LOFT extension trial to be better and very, very efficacious in reducing vertebral, non-vertebral fracture as well as clinical fractures. The limitation is it can slightly increase the risk of ischemic stroke, just like romosozumab has been slightly shown to increase the risk of cardiovascular events. Therefore, it is not to be used in patients who are having cardiovascular diseases, romosozumab. So osteoporosis drugs in pipeline, Alvotech is a biosimilar to denosumab. And then there are drugs like EB613, which is an oral teriparatide, HLX14, which is again a denosumab biosimilar, and this PKB L2201. These are all candidate drugs, which is again a biosimilar to teriparatide. So to summarize, low and moderate risk, we do not treat for people who are having low and moderate risk of fragility fractures. We reassure them and see fracture risk after 2 to 4 years. For patients who are having high risk, we tend to initiate with bisphosphonate unless there is a compliance issue or SSBT or CKD. If patient shows good result, we continue with bisphosphonate. If patient do not show adequate good result or there is bisphosphonate failure, we can switch over to denosumab or teriparatide or romosozumab depending on what we discussed. If the patient is having very high risk of fracture, we start upfront with teriparatide. Currently that is only available, but alternatives are abaloparatide, romosozumab, and then we switch over to denosumab or bisphosphonate. So with this I stop here. The session is open for discussion. Time was less, so I was a little quick.
Thank you, Amitabh, for exhaustive presentation. You have made us knowledgeable about very upcoming drugs. Again, I harp on the same string that these are pretty costly in Indian context. So that is the crux of the problem in treating osteoporosis in Indian context.
Yes. True.
So his deliberation now is open for discussion from the house. I think Dr. Sanjoy can add some new input, or Subbosachi is there. Yeah.
Amitabh, very nice presentation, although I just came late, so couldn't attend the whole one. The problem is, it's not that I'm trying to show that I came back from UK, but when I first came back from UK, I was just speaking to Dr. Sanjay Shah about this. I thought osteoporosis is dealt by the endocrinologist, But here my concept totally changed, because when I came to know that this is a specialty which is specific for the orthopedic doctors as well as rheumatologists. So I don't know how many patients you manage to see in your endocrinology clinic with osteoporosis. I come across rarely, only
Less
a
than
few.
what I should see, sir, no doubt. But things are getting slowly better. Problem is we are unable to bring orthopedic surgeons to our CMEs. That's the biggest failure.
No, no. If the company provides the talk, you'll find that the room is full of orthopedic surgeons. That's how it is. That's my experience as well. I was sharing with him. But I think the only odd osteoporosis patients that I see are my own diabetes patients.
Yes.
Yeah. I don't get a referral from sort of my orthopedic colleagues.
Same here.
Yeah, so it's my own diabetes patients.
Completely agree, sir. Same here for me.
Anyway, that is a team.
And other secondary causes, sir. Hyperpara and secondary causes.
Professor Nilanjan wants to.
The problem is that the orthopedic surgeons have to treat an osteoporotic fracture. They would be treating, but what they do, either they don't give any osteoporotic medications even with an established low trauma fracture. They simply don't believe in, there's a class of orthopedic surgeons who simply don't believe in giving teriparatide or denosumab or any of those agents. Sometimes they give for 2 months and 3 months. I don't know what benefits they do have for that. And then I find with patients with one orthopedic surgeon with a patient of osteopenia has given dual therapy, that is one anti-resorptive along with that a bone forming agent together, where I found there's no indication for using such agents. And I think a sequential therapy, as per the current evidence, a sequential therapy is much better than a concomitant therapy. So the problem is there, the orthopedic surgeons have come, they attend the CMEs, but it doesn't translate into practice. Now there, we have to take the cudgel, the endocrinologist, which would start screening, talking about osteoporosis. For example, a patient comes with diabetes, who is 60 years plus, 10 years postmenopausal. We have to talk about that. We have to advise a DEXA, get it done, and then things should start. Not wait till an osteoporotic fracture occurs.
Professor Sengupta, your points well taken, but I have the gut feeling that should be a osteoporosis dedicated clinic, and endocrinology should be taking the leading role. That should be done.
So it should start from teaching hospitals, sir.
Yeah, the problem is, anything happens to the bone, the patients, they take their own call, because there's no triaging system here as such. So patients will take their own call that I'm having pain in my spine, I need to see an orthopod. That's where the problem is.
So anyway, thank you very much. But in India, I feel the subclinical vitamin D deficiency has to be unleashed or uncovered. So that is our duty, and that is the teamwork. Thank you.
I think we must appreciate the scientific committee for keeping a very interesting session on the bone metabolism, and we appreciate all the speakers. Thank you very much for your insights.
Thank you, Chairperson and speakers, for such a wonderful session on clinical bone metabolism. As we are already bombarded with a lot of SEMA, so these things are going to be more common in future. So, our next session is a panel discussion. It's a 2026 vision of managing type 2 diabetes with CKD, optimizing the prevention continuum. For this, I'd like to call Chairperson Dr. Ashish Basu from Kolkata and Dr. Arinban Singh Sinha from Kolkata. I'd request the chairperson to call upon the moderators in this panelist.
Hello. Thank you, and it's still good morning to the audience. And we have a nice discussion on the panel. Interesting topic on vision for managing type 2 diabetes and CKD. We commonly face a lot of issues when the diabetic patients have renal impairments. So we have multiple specialties for discussion, starting from nephrologist, cardiologist, endocrinologist, diabetologist. Everyone is there for discussion. So with this short introduction of the topic, I'm calling up first with the moderator, Dr. Gaurav Bhaduri. Please, Dr. Bhaduri, please be on the dais. Good morning, sir. And I'm also requesting other panelists for this nice discussion. Dr. Binayak Shina, I think he does not need any introduction. Renowned endocrinologist. Binagda, please come. And Dr. Sanjay Shah, Dr. Shah, please. Welcome with my good old friends. And Dr. Dilip Kumar, renowned cardiologist, and Dr. Pratik Das. Pratik Das, come in, please. So I don't think anyone requires special introduction, but I request my co-chair, sir, please sit. Anyway. Sir, please, anything you have to say.
Pratik. Oh, so we'll move on to the very important topic, 2026 vision of managing type 2 diabetes mellitus with CKD. Management, not prevention here, optimizing the prevention continuum. So Dr. Bhaduri is there. So let us hear from Dr. Bhaduri. He will start the ball rolling.
Yeah. So first of all, a very good morning to all present over here. And what a delight is it to see such a panel in front of us while we are discussing type 2 diabetes, CKD, and the prevention continuum. So first I will set a little bit of context about the topic that we are going to discuss, because most part will be a panel discussion type discussion. So if you look at the CKD screening and diagnosis for people living with diabetes, who and when to screen. So for type 1, it's yearly starting 5 years after diagnosis. And for type 2, we all know that it should start right at diagnosis, and we should be following those patients up. And then how to screen is spot urine ACR, and we need a GFR. So these are the basic 2 parameters that you need to do for each and every patient. And what to do if you have a positive result. So you repeat and you confirm. So evaluate possible temporary or the spurious causes. You might consider using some other methods like cystatin C and creatinine to more precisely estimate the GFR. Only persistent abnormalities define CKD because it's a chronic disease, so you need a persistent abnormality. What defines the CKD diagnosis is either a persistent urine ACR of more than or equal to 30 and or a persistent eGFR of less than 60 and or other evidences of kidney damage. So this is how you define it. Now, if you look at the different trajectories of kidney function in our diabetic kidney disease patients, so you have the classical DKD. So you, do you have a pointer, please? Yeah, pointer. So you can have a look. So first we can see over here. I don't know whether it's visible over here. No. So you have number 1. Okay. But still it's not working well. So you give me this one. Yeah. Okay. No, it's not working. Fine. So anyway, you see number 1 is clearly written, the classical DKD. So what happens is you have a high ACR, and yeah, it's working now. This one. Okay, this one. So now it's working now. Yeah. So you see the classical DKD. So you have the GFR is still more than 90, but the patient's ACR starts increasing, and then there is a drop in the eGFR. So this is a classical pattern. Then you have patients where you have slightly increased your spot ACR, and then it can also regress back into the normal zone. Then there are some patients who are the rapid decliners. So there is a very rapid decline of the eGFR. So before the patient reaches a very high albuminuric state, the patient's eGFR declines very fast. And then there is a non-proteinuric or the non-albumuric DKD. So that also exists. Some of your patients' eGFR might drop, but their ACR may still remain in the normal range. So these are the varieties that you see. Now, why is a dropping GFR a problem? Because you see a lower GFR along with a rise in albuminuria independently represents worsening prognosis for all kinds of clinical outcome. So here you look at the cardiovascular mortality, and you can see as you go down the slope, so all these things, goes up drastically. Kidney failure with replacement therapy, again, a very sharp increase once you are down into the red zone. Heart failure, very similar kind of results, and with hospitalization, any cause. So no matter what indices we are talking about, whether it's a cardiovascular mortality or kidney failure with replacement or heart failure or hospitalization, once you are there in this segment, so your risk is much, much higher, right? And then there is a blind spot of CKD. So until and unless the GFR falls sharply or there is a significant rise in the urine ACR, so we cannot identify that the CKD has started developing. So this is something we also need to keep in mind. And from 2018, the credence we all know about, the canagliflozin trial, which was a renal dedicated trial, and then ADIPOSE CKD, Fidelio CKD, Figaro DKD, EMPA kidney, flow. So across different set of molecules, so the ACE ARBs we all know about, then we had the SGLT2 inhibitors, then the non-steroidal MRA, and now we also have data with flow trial from the semaglutide with the GLP-1. So coming to our panel questions. So my first question is to Dr. Binayak sir. And the topic is early CKD, low moderate risk phenotype. Are we over-treating with SGLT2 or under-preventing? So this is a short clinical vignette. A 52-year-old with type 2 diabetes, A1C 6.6 on metformin alone, CKD G2, urine ACR 35, SBP around 106, 110, on low-dose ACE inhibitors, no heart failure ASCVD, but a recurrent valvovaginal candidiasis history. So the core question is, would you still push for an SGLT2 inhibitor in 2026 purely for prevention continuum gains, or you'd reserve it for high-risk phenotypes?
Good morning, everybody. Thank you, Gaurav. So I will divide this answer into three parts. A is, we cannot forget the fact that SGLT2 inhibitor, for all the things that we talk about, is an anti-hyperglycemic agent. So it's a very good drug to manage diabetes, so why not? That's number one. Number two is, what do patients with diabetes, or particularly patients with diabetes kidney disease, die of? And the answer is very simple: heart attack or stroke. So if you look at this patient, she's not only a diabetic, she's at high risk or moderate risk of developing a heart attack or a stroke. Now, if we look at the ESC guidelines, anybody who's in the high risk or moderate risk qualifies for a SGLT2 inhibitor. Thirdly, her kidney failure has started, and as you showed, it's a thing which is a continuum. The kidney function deteriorates later, but albuminuria appears early, and it has appeared already. So there is no question of not prescribing SGLT2 inhibitors in this lady. She qualifies from three aspects. Now, of course, there's this candidiasis. You have to treat it adequately. She's probably reaching menopause, so she probably needs some kind of creams to make sure that she maintains her vaginal moisture. Secondly, she also needs to have maybe a longer course of fluconazole or any kind of antifungal to get rid of this candidiasis. So we have to treat. It is not overprescribing. And today, if you look at the data of SGLT2 inhibitor prescription, I think as a country, we are doing very well. Our site data actually showed that compared to the Western world, we actually prescribe SGLT2 inhibitors much more, maybe because of the introduction of generics which came in early in our country. So there is no question of not prescribing, and it is the correct treatment for this lady.
Thank you, sir. So going to the next question is to Dr. Sanjay K. Shah, sir. So the basis is the genital infections and persistence. When is prescribing a SGLT2 inhibitor justified despite a proven renal benefit? So let me give you a clinical vignette. A 60-year-old woman, CKD G3A, urine SCR about 480, started empagliflozin 10 milligram. Over 6 months, she has 3 episodes of candidiasis and 1 UTI. She is now unwilling to continue. Now, what is your salvage plan when a patient experiences recurrent genital infection on SGLT2 inhibitor, but a significant albuminuria and you have an agent which has got a proven renal benefit? So how do you salvage in those kind of situation? My second question is, what is the threshold to stop this drug permanently? So even if the albuminuria is on an increasing trend.
Well, I must first thank EMOCON for inviting me. Thank you, Gaurav, for asking such a wonderful, difficult question. But it's true, we are facing this every single day of our clinical practice. And taking a cue from what Binayak mentioned earlier, that the evidence with respect to the benefit of an SGLT2 is so much more that perhaps we accept some of the side effects that we give. But there are times when you have to rethink. So in this person, now she's a woman. If he was a man, that's easy, okay? Because what they need is, if you're having recurrent ballonor posthitis, you just refer them to the surgeons, and that will take care of it, and then life goes on as usual. And this has happened to a couple of my patients in clinical practice. But the challenge remains in women. In women, it remains a challenge. So the issue is, first, if somebody is having basically recurrent, genitourinary tract infections, I then have to revisit the idea that is genital hygiene being maintained, okay? Is she physically and medically reasonably good in terms of, is she not anemic? That is one. Again, she's postmenopausal with an age of 60, so does she need the basically estrogen creams vaginally? That is two. And in spite of that, if she's still developing recurrent UTIs, usually while patients on SGLT2 inhibitors, I might give them a sort of dose of, or a couple of doses of fluconazole to get rid of this infections. But it seems to happen again and again. I will actually stop it for a little while. Make sure that the blood sugars are reasonably well maintained, because it is the tissue hyperglycemia which also becomes fodder for the fungus, okay? So you reduce the blood sugars with other drugs and then reinstitute the SGLT2 inhibitors. And I have seen in certain occasions that then patients perhaps tolerate the SGLT2 inhibitors better without the side effects per se. Only on the odd occasion, perhaps one patient of mine, I think still comes to see me. I might have prescribed it to more than one, but one patient of mine, I give them a weekly fluconazole and continue the SGLT2 inhibitor because of the kind of renal dysfunctions she has in terms of a fairly macroalbuminuria is what she's getting. So she's at extremely high risk of progressing to renal failure as well as for respect to cardiovascular events. So that's how I basically practice. With respect to when I perhaps will stop permanently, anybody with complicated infections, because you see, if infections like say pyelonephritis, I have 2 patients who have had pyelonephritis having almost near death experiences, okay, creatinins, the acute renal failure from infections obviously takes away the thunder which SGLT2 actually provides in trying to delay the EGFR reduction. An acute illness with pyelonephritis will suddenly result in a patient's creatinine from 1.5 straight to 4.5 or even need dialysis per se. So patients with say pyelonephritis, severe life-threatening infections or complicated infections which you cannot sort it out, obviously in those patients, I wouldn't be willing to give an SGLT2 inhibitor. That's how, these are my thoughts and what I have done in the last 10 years of me using SGLT2 inhibitors.
And one thing I want to add, nowadays some probiotic has come up and some papers are also there. They are specific for vagina. Okay, so they act on that part. So they are also coming as an adjoinder in the prevention of fungal.
Yeah, Ashish, I agree with you. I mean, you're maintaining vaginal pH.
Right.
That's what they have. Yeah.
So let's go to the third question, and the topic is heart failure phenotype plus CKD stage 4. So practical hemodynamic terms guidelines. How do you operationalize your SGLT2 inhibitor? So the clinical vignette for Sir is a 71-year-old with type 2 diabetes, CKD stage 4, heart failure with preserved ejection fraction with congestion, systolic blood pressure 98 to 104 on loop diuretic and ARP. You want SGLT2 inhibitor for heart failure and CKD benefit. Now the question is, what is your step-by-step initiation strategy in this patient? The diuretic adjustment, the monitoring schedule, and the stop rule. And the second question is, how do you sequence them? Do you reduce loop diuretic before or after starting the SGLT2 inhibitor?
So thanks. I think these are regular, day-to-day cases which we see, and it, invites some of kind of ideas to deal with them, and sometimes we miss the primary pathology which is happening. So my take on these patients, compromised GFR and patients with diabetes with HFpEF. So this is HFpEF, not HFrEF. So we have limited options on disease-modifying therapy. So we have only one SGLT2 inhibitor, sphingosine is making way. But many of these patients have reversible reasons. They have atrial fibrillation which can be controlled, they have hypertension which can be controlled, there can be some restrictive cardiomyopathy, amyloid. So I would very strongly look into reasons for HFpEF. What is the pro-BNP level? How can we see the reversibility of this entire HFpEF, etiology? Now coming to disease, the therapy from medicine part, the loop diuretic is only for symptomatic benefit. There is no point continuing loop diuretic once the patient symptoms are decongested. So for acute management, loop diuretics will come. And then since the GFR is something in the range of 24, but still we have SGLT2 inhibitors which can be given at that range. So I would like to take the drug on once the patient has decongested, it's not acutely sick. We would onboard the SGLT2 inhibitors, we would offboard the loop diuretics right after the discharge maybe. Maybe we can add here, think of adding once GFR, many times these heart failure patients, once you improve the heart failure, their GFR slightly comes better. Yeah. Creatinine starts settling down. Then there is a kind of, if the GFR goes more than 30, 35, 40, then we can definitely think of adding fenrinon as well. So this is how I'm going to, streamline my medications.
Yeah. So the point very well taken. That's why the GFR was 24 and not more than 25, because I wanted to focus on the SGLT2 inhibitors. Right?
Dilita, can I just ask you one question? Which SGLT2 inhibitor maybe you are adding this patient, and what dose?
Yes, so dose remains fixed. Dose we are not going to change 10, and then EMPA has got more evidence in this. And, low GFR, 24, 25. If we are having to take a call, it has to be EMPA.
So moving to the next question to Dr. Pratik Das. So confidence and the surrogate endpoint dilemma, do you act on urine ACR alone for upfront combination? So the clinical vignette is an outpatient with type 2 diabetes, CKD, eGFR 44, urine ACR 900 on maximal ACE inhibitors, no heart failure. Confidence shows that the starting finerenone plus empagliflozin or SGLT2 inhibitors together reduces urine ACR more than either alone at 180 days with an albuminuria endpoint and manageable safety. Now, the question is, simultaneous initiation as a standard of care. Would you advocate for simultaneous initiation as standard of care before definitive hard outcomes data on the combination, or you insist on stepwise escalation? That's the first question. Second is, would you prioritize combination only for very high risk CKD categories, or is it for all?
So the kidney is the only organ probably where the function is being assessed by the surrogate markers. You assess urine albumin, a protein in the urine to assess the kidney function, or you assess a chemical called creatinine, which kidney doesn't handle. We use to make a calculation and estimate the GFR. So this indirect measurement of the kidney function always has got some fallacies whenever you're using in a clinical practice or maybe in research purposes. So this patient is having a proteinuria, that means he is a leaky filtration, and that doesn't mean the kidney is only at fault. At the same time, whole endothelial system in the body is at fault. And adequately he has been given a ACE inhibitor, RAS inhibitions in the highest dose, because all the trials which has been shown the benefit of the drugs have all received this is in the highest dose. Now that he is having or she is having a persistent albuminuria in spite of that, and your question is whether we have to add these two drugs based on the studies of the confidence trial, is it together or is it sequential way? So definitely the proteinuria is persisting. They need an additional drug to reduce proteinuria, and to reduce the proteinuria is basically due to increased interglomerular pressure. So you have to give something which reduces interglomerular pressure. So, and the SGLT2 inhibitor probably definitely a choice for these patients. And even then, recent studies shows that, confidence study, that you can combine it with the finerenone because they have also very good effect in terms of the proteinuria. But the problem is that in the confidence study is a very it is designed in a very poorer way compared to the other studies we have. There are only 800 patients. They have been continued only for 180 days. This observation is only for 30 days. So they have shown, yes, definitely you can use it in combination. There will be reduction of the proteinuria. They didn't mention about any benefit in terms of reduction, benefit in terms of slowing the reduction of the GFR or rising of the creatinine or kidney endpoints, because the follow-up is only 30 days.
So I understand this, sir, but the question is, in your practice, if this case comes to you, would you combine them together or would you go sequentially?
Yes. So this patient is not of a very high risk, as you have told. So in my practice or our practice, we add it in a sequential way, because the data for the combination at the same time to accept and permissive AKI, that is not for this patient. Okay. So they require a patient, they require both the drugs probably, and we will add the SGLT2 instantly. We can wait for some time, and because cost is an important issue for such patients. So we can use it in the finerenone.
Okay. So for very high risk patients, you would probably may think of co-initiation, but for vast majority, you will go for a sequential.
Yes, if there is a follow-up study of this confidence, a longer follow-up, and they give more hard evidences, then we may be.
Okay. Okay. Point well noted, sir. So we move on again back to Dr. Pratik Das. Sir. So the expected eGFR dip versus true AKI. So the clinical vignette is that there is a patient CKD stage 3B with urine SCR 700, ARB was up titrated and empagliflozin started the same week. 2 weeks later, the creatinine is up 28%. Potassium is 5.2. BP is 104/68. Patients report mild dizziness. Now what you do? You continue both. You hold one, and if you hold one agent, which one would you hold? Or you add just the diuretics and the fluids in this patient, or you investigate for the intrinsic AKI reason, or you do a combination of any of the above.
So this patient has developed all four, because low GFR, this is a hyperkalemia, this is a hypotension symptomatic, and probably might not have any additional urinary abnormalities. So my take on this withdrawing of drug is not very important, a very difficult decision to take. You can withdraw any drug at any point of time due to any side effect. Problem is the reinitiation. As everybody were talking about the robust data which suggests that there is evidence that it is definitely a kidney protector and the mortality benefit is there. So we have to continue it. So before withdrawing the drug, we take one by one in cases. If you take the hyperkalemia, this is a no indication of withdrawing drug of anything. Secondly, if you take the loss of GFR, this happens within first 7 days of time. So it is, there is a concept is called the permissive AKI. We can accept AKIs because these things will be adjusted in next few months of time. It can be stabilized. But in the same time, you have to look for the other things, especially whether the patient is getting diuretic or not, taking other NSAIDs or not, whether the patient is dehydrated or not, sick or not. These things needs to be taken care of. Thirdly, this is a low blood pressure. That is a, you have told, is a significantly low blood pressure. In that situation, additional take is that this patient might have a lower value compared to the renal autonomy. Because if you go below less than 65 of mean arterial pressure, in this renal perfusion gets damaged and you can develop an AKI, that is acute tubular necrosis. That things needs to be taken care of. You have to look after vigorously whether the other factors are there or not. You have to stabilize to keep above 65 mean arterial pressure for these patients. And until and unless there is a rapid worsening of the kidney functions, there is development of the active urinary sediment or any other thing which suggests any other diseases other than this diabetic kidney disease, in those situations, we can take these patients for a biopsy and further kidney follow-up.
So you want to continue both as of now in terms of the kidney protection, right?
Yes, but blood pressure needs to be taken care of.
Okay.
And hydration, aggressive diuretic therapy, NSAIDs treatment, diarrhea, vomiting, these things needs to be taken care of.
Okay.
Pratik, that's for that blood pressure, do you want to think the RAS inhibitor maybe step down, may not be off, but reduce the dose maybe?
Yes, we have to keep the mean arterial blood pressure more than 65. So as the RAS inhibitors are more potent antihypertensive compared to the others.
So may step down the dose, may not be stopping it.
Yeah. So got it. So moving on to Dr. Sanjay K. Sasar, the clinical vignetis, a 63-year-old CKD stage 3B, urine SCR 1200. After ACE inhibitor plus SGLT2 inhibitor, urine SCR drops to 820. About 32% reduction. Blood pressure is now 110/70. So do you treat that as target achieved and stop escalating, or do you push for further urine ACR lowering with agents like finerenone, GLP, or a tighter BP control given the residual risk? And the second question is, at what point of time do you judge the urine ACR response for a success or maybe a failure by 3 months, 6 months, or 12 months?
Right, okay. Thanks, Gaurav, for this question too. Albuminuria as a treat to target metric. Do you manage urinary albumin creatinine ratio like LDL cholesterol? I think to start with, I think both urinary albumin creatinine ratio and LDL cholesterol should be proactively treated. Okay, treating both these really has transformed the outcomes for our patients. For LDL cholesterol, it's cardiovascular. For urinary albumin creatinine ratio, it is both cardiovascular as well as renal. Okay, so that's the important bit. So I would basically target that. Now, with respect to targets, okay, the urinary albumin creatinine ratio of my patient has come down, which basically means that it has actually has shown effectiveness. It is stated that should at least reduce it by more than 30% to be considered as an effective drug or a molecule. Now, your target actually is if you can achieve remission in terms of urinary albumin creatinine ratio below normal. So it has not yet achieved that target. It basically means there's a residual risk. Now, for a reduction of 30%, you perhaps reduce your cardiovascular risk by about 14% or something. But that residual risk needs to be addressed. And the residual risk with respect to albumin creatinine ratio is twofold. One is renal, the other one is basically cardiac. So what drugs you can perhaps add to address these two? Now, you have given us a choice, and I think that's what we are in clinical practice. We can use finerenone, we can use GLP-1 receptor agonist, and obviously improve blood pressure control as well in this patient. I do not know if the blood pressure, it is reasonably well controlled. So
well controlled, yes. So do you want to go in for a further tighter control? Probably no, right?
Yeah, either have a GLP-1 receptor agonist or a finerenone.
Right.
For all you know, you will have to basically use both these.
Both these.
Okay, and taking a cue from what Dr. Pratik Das mentioned earlier, sequentially, so you're already on board an SGLT2 inhibitor, you will add on basically finerenone. I did not used to use that much of GLP-1 receptor agonists in the past, largely because of value for money. But the cost,
Right.
not a lot of patients would be able to take it. But since we now have generic versions of GLP-1 receptor agonists, I think I perhaps would then push to using a GLP-1 receptor agonist, largely because not only will it give you the benefit in terms of renal outcomes, what the flow trial showed, but more importantly, the cardiovascular benefit, because this patient has very high risk for a cardiovascular event.
Right. So point absolutely well noted. I think it's very important for the audience to also understand this. So coming to Dr. Dilip Kumar sir, the clinical vignette is a 66-year-old with type 2 diabetes CKD stage 3A, urine SCR about 260, obesity, prior stroke, but no symptomatic heart failure. So in 2026, do you initiate both SGLT2 inhibitor and GLP-1 very early, or do you still sequence one first and then the other? And what is the role of finerenone if the urine SCR rises despite the RAS and the SGLT2 inhibitors? Would you want to start that too?
So, first of all, this patient will go to any of, Dr. Binayak sir, Pratikda, all of you except me.
Right.
This patient doesn't have heart failure symptoms.
Right.
Ejection fraction is also normal. There is no indication. But since the question is posed to me, I will be giving answers. So this patient is high risk. This patient had a stroke, as well as we are looking at long-term kidney protection, as well as cardiovascular endpoints, which should not be adverse. So obviously, this patient requires SGLT2 inhibitors. This patient also requires GLP analogs because in trials we have seen the stroke protection was the biggest, one of the achievements which were, there with GLP receptor analogs. Third is the patient also requires finerenone because the patient's albuminuria is, happening. So we had 4 pillars of therapy. Now we are looking at 5th, 6th, 7th. We are looking at vericiguat. We are looking at cardiac rehab. We are looking at other drugs. But for kidney friends, this is also now 4 pillars: SGLT2 inhibitors, RAS blockers, GLP analogs, finerenone. I would like to put these patients to on all of them, because this is already high risk patient, already had a stroke.
Right.
And we cardiologists believe in rapid sequencing, not simultaneous, not very delayed. It has to be rapidly sequenced, one by one, 4 to 6 weeks. If everything is there on board, this is how I'm going to treat this patient.
Yeah, so point again noted, sir. So it's an early aggressive therapy that we need to go ahead. So the next question is to Dr. Binayak Sinha, sir. The residual albuminuria on RAS plus SGLT2 inhibitor. So the clinical vignette is a 58-year-old with type 2 diabetes CKD stage 3B, urine HCR about 650, despite maximally tolerated ACE inhibitors and empagliflozin, potassium 4.7, BMI 34, prior MI, and a HbA1c of 7.4. So what is your sequencing logic in 2026? Add finerenone for residual albumin risk, or add the semaglutide given the flow kidney outcomes, or dual add? And would cost push you to a different strategy?
So let me start by saying that I differ with Dr. Sanjay Shah on using more GLP-1 receptor agonists now. If you look at the licensing of GLP-1 RA, the generic versions, the licensing is only for glycemic control, not for anything else, till now. Okay, they will keep applying for it. Okay, there is only thing is glycemic control. Some of them have a licensing for weight reduction, not all of them. Okay, so we have to be careful about choosing generics. And I always feel that if you're looking at a sick patient, put a family member in that person's place and think whether you would want to put a person like that on a generic GLP-1 RA, which has not been able to provide that kind of impressive data to us yet, or would you prefer to prescribe a GLP-1 RA which has robust evidence backing it? Okay, so that is number one. Number two, this patient, again, I will come back to the central point of what I had said earlier. What does a kidney patient die of? A heart attack, heart failure, or stroke? So the priority out here would be a GLP-1 RA as a first line, if the cost is a constraint, because finerenone also is a very expensive drug. and then efinerinone, because first save a life, then save the kidney. But if cost was not a constraint, I would go totally with what Dr. Dilip Kumar is saying. No point wasting time, start all of them at the same time. The evidence is so robust.
Thank you. So,
can I just say something which Binayak mentioned? I think I take his point, but I think what looks like a duck, what makes a quacking sound, actually is a duck. Okay, so if the GLP-1 receptor agonist is basically you can call it a biosimilar for that matter. If it has basically shown benefits in terms of blood sugar control, I would presume that perhaps it also has benefits in terms of cardiovascular outcomes as well. Because nobody's going to be able to do that kind of trial. That's how it is.
No, I don't want a trial. I just want to see a published paper.
okay, so coming to the last part, so we have about 9 minutes 45 seconds left, so this will be a quick fire. So the first question is to Dr. Dilip Kumar sir, finerenone versus steroidal MRA in heart failure with reduced ejection fraction plus DKT. So this is a vignette is a 60-year-old with heart failure with reduced ejection fraction, type 2 diabetes, CKD stage 3B, urine ACR raised 420, potassium 4.9, already on ARNI or ACE equivalent pathway and SGLT2 inhibitor. You want MRA benefit for heart failure and the kidney protection for DKD. So you want both in this patient. Now, the question is, do you choose finerenone DKD outcome or a steroidal MRA as per as the heart failure guideline standard?
Yeah, it's quite a paradox. We don't have evidence with finerenone in HFrEF. So in HFrEF we have only evidence with spironolactone and eplerenone. And we have overwhelming evidence in Fidelio and Figaro as far as CKD patients are concerned, so that we can reduce the progression. So this is quite a paradox. As a cardiologist, I would like to push this patient on spironolactone or maybe eplerenone, and maybe our nephro colleague, what he feels, he can, put his,
Actually, finerenone does have a little bit of phase 2 data on heart failure with reduced ejection fraction in about 1,000 patients, but in the phase 3 trial they commercially discontinued that.
Yeah, we need to have evidence,
yes.
published evidence, and still it is not in guidelines.
Yes.
There is an extrapolation that this is a safer drug with lesser side effects, with properties almost similar, more antifibrotic, more anti-inflammatory.
Right.
But still we need evidence
right.
to push
I agree with you.
Just
So we, okay.
Yes, actually this, if you see the recent KDIGO guideline, they have categorically mentioned this finerenone group of drugs should not be used when you are suspecting a high hyperaldosteronism state. The reduced ejection fraction heart failure is one of them. If there is any for other reason, maybe a chronic liver disease, it may be a dehydrated state, it may be a tumor, they have asked not to use. In those situations, steroidal MRAs are the choice.
Sir, so the clinical vignette is 67-year-old with type 2 diabetes, CKD stage 3A, on SGLT2 inhibitor, a weekly GLP-1 with basal insulin and ACE inhibitors, booked for an elective surgery requiring 48 hours of peri-operative before and after fasting risk. So when to stop the SGLT2 inhibitor and when to restart the SGLT2 inhibitor after the surgery?
So I think this is now in the guidelines as well, but I think it's a little bit of a no-brainer that we always knew in an acute stressful situation, or if there's any kind of a problem, like, this kind of a fasting or something like that, it's probably best because, this is, of course, works like a diuretic. It is causing natriuresis as well as, so I would stop it. Now the guidelines is saying you should stop it 72 hours.
48 to 72 hours.
42 to, and, start after the patient starts eating adequately. So these have now been instituted. Saying which, I think we have Sanjoyda here, I have myself here, I can see Shubir and Shoboshachi, Dr. Dilip Kumar here, Dr. Pratik Das here, you are here. What have we been doing for the last 10 years? I think we knew we should stop, but in most cases it was missed. Patients would get referred to us, would not get referred to us, and the patients would continue.
Yes.
And I think we've not had any kind of catastrophe till now.
Right.
But then you can always argue that the next one will be.
Right.
So I think it's best to stick to guidelines, 72 hours before, 72 hours after.
Thank you, sir. So
no need for ketone checks.
So the next question is to Dr. Sanjay Keshasa. This is again a quick fire. A clinical vignette. Patient is 59-year-old, CKD stage 3A, urine SCR 900, obesity is there, BMI about 33, established CAT on ACE inhibitors and statin, HbA1c is 7.1%, and the patient is already on metformin. They can only afford one of SGLT2 inhibitor, Finnerone, or a GLP-1. So which single agent is your highest value choice in 2026, and why? Would your answer change if the urine ACR were 80 instead of the 900 given over here?
Thank you, Gaurav, for asking this question. I think it's almost like a no-brainer, really. Okay, in terms of the benefit that you get, SGLT2 inhibitor stands out. Okay, that is one. So SGLT2 inhibitor, and in terms of value, in terms of cost to the patient, again, SGLT2 inhibitor stands out. And while we know that it works well in patients with albuminuria, we have now evidence both from DAPA-CKD and EMPA-KIDNey that even in normoalbuminuric patients or patients with minimal albuminuria also, you get the same kind of benefit in terms of both kidney and cardiac.
Yes, but we have that with only EMPA-KIDNey. In DAPA-CKD, that was not there. The minimum urine ACR needed to be more than 200 over there. So, but yes, in the EMPA-KIDNey arm, we have the normal albuminuria patients also getting the same kind of benefit that the albuminuria patients were getting.
Yeah, even in the EMPA-REG outcome, the same thing happened, that normal albuminuric patients also had the benefit.
Yes, but that was exploratory analysis. Absolutely. So, but EMPA-KIDNey is more robust. So the last question is to Dr. Pratik Das sir, again a quick fire. Vignette is an outpatient with type 2 diabetes, hypertension, CKD stage 3B, urine ACR 20 on maximal ACE inhibitors. So this is what exactly we were discussing previously. So would you want to start a SGLT2 inhibitor? Probably the answer is yes. But if yes, then would you choose between dapagliflozin versus empagliflozin in this given scenario, based on the fact that the DAPA-CKD has no data on patients who had normal albuminuria versus EMPA-KIDNey having the data that there is benefit to patients without any albuminuria, or we are being too much of a purist by asking this question?
So I think last comment is right, because the benefits of the SGLT2 inhibitor starts with reducing the intraglomerular pressure by afferent arterial action. That is the main action. And with that we get a less leaky urine, that is a less proteinuria. So this benefit of lowering intraglomerular pressure will be there, and that should be a class effect. As we have no data in DAPA compared to the EMPA, yes, at the point of time you can tell this EMPA can be used, but that purist attitude I don't think is acceptable. This patient requires SGLT2 inhibitors in spite of not having no proteinuria.
Thank you, sir, and thanks to the entire panel for being such patient with all these questions that I have, posted over here. And I am opening it for, a question and answer from the audience.
Finerenone in what you call patients with heart failure, isn't it? You just mentioned about that. Now, and also if there are patients who have got high aldosterone producing tumors. Now, what is exactly the reason?
So they have asked that if there is a state of hyperaldosteronism, in those situations, Finrenone might not be that effective in reducing the hyperaldosterone state. Initially, it was told that in heart failure state, it should not be used. Nowadays, above 40% ejection fraction in those situations, they have asked to use it, but below 40%, the data are not there, and the action is not that predictable. Data is also not there. In those situations, data in favor of the spironolactone or the eplerenone is much high, because yes, just you have to take care of the potassium.
Hello. In that operative case, you talked about stoppage of SGLT2 inhibitor, but this patient was also on weekly GLP-1 analog. So what time we need to stop the GLP-1 analog prior to OT? That is my question.
So now, again, I think all of us know that we've been seeing patients and not doing anything. There's an anesthesia society which has come up with this guideline that you should stop 14 days before GLP-1 RA, anesthesia society. But you know, all of us have gastroparesis, a risk of aspiration
happening. So I have talked to many surgeons regarding this, and they say that before the surgery, whatever weekly dose is there, at least skip that.
Yes.
Also, that's the general recommendation. So at least about 7 days, and the service saying some of the guidelines have come 14 days.
There is only one. I don't know of any other guideline. Maybe, you know, Ghanshyamda is there.
There is one study in Sir NEJM regarding this, recently published, regarding the risk of aspiration and after post-operative. So they are also saying that you can, if you skip one dose before the surgery, so about 7 or more days, it's good enough.
Thank you.
So I think we are done because there is no more questions. So thank you. Thanks to everyone.
I'd like to thank the moderator for moderating such a wonderful session. Congratulations,
Thank
Gaurav.
you. Thank you, sir. Thank you.
We had really a sort of academic feast or a sort of brainstorming session. Thanks to Gaurav for start the ball rolling. Okay, we declare the session closed.
Thank you, sir. Thank you.
হ্যাঁ তাড়াতাড়ি সরি সরি ইটস অলরেডি অন এখনো তো শুরু হয়নি তো কেউ একটা ইন্ট্রোডিউস করবে তো হাউ উইল দিস সেশন রান আই হ্যাভ গট নো ক্লু
এখানকার চেয়ারপারসন কে আছে এই সেশনে?
How is it going to run? I don't know what format you're. No, I know that. I will be standing, I know that. But who will be sitting there? That's what I want to know. Okay. Yeah, ask the chairperson to be kindly seated so that we can start.
What is the chairperson?
Gaurav, can we start? Or else we'll be running late, you know? No, someone has to come here. The chair has to come, isn't it? Or else I can't start. Who is the chair?
Hello.
Who is the chair? Yourself? So why don't you introduce the others and please ask them to come and take the seat
Good
on the
afternoon,
podium.
everyone. We'll be starting a very important SEMA symposium. It's going to be a 2-hour journey for something which is round the clock. And all of you will surely be using and are using the SEMA. First of all, I'd like to call the chairperson for along with me, Dr. Gaurav Bhaduri and Dr. Rupak Chatterjee to join me on stage. And we have the moderator, Dr. Sabyasachi Bandyopadhyay. Sorry, he's already here. And the panelists for this particular session is SEMA and Diabetes, Dr. Ghansham Goyal from Kolkata, Dr. Ashish Basu from Kolkata, Dr. Satrajit Roy from Asansol, Dr. Ajoy Biswas from Kolkata, and Dr. Arvind Kumar Arya from Jamshedpur. So kindly join. I'd request the moderator, Dr. Sabyasachi Bandyopadhyay sir, to start the session.
So I think we are almost near the lunchtime, isn't it? So people always fall asleep just before that. So good morning, everyone. First time when I address someone, I always say good morning, so although it's afternoon. Now, we are going to be discussing about the impact of semaglutide and its effect on diabetes control. Now, we know that Sema has been in the market for some years now, and we have all big trials happening. We have the sustains and with the steps. So we also all have the research data, and we've been using the product for some time, although not religiously, but we are using it. Now, there are two things, the two fears in our mind that deter us from using the product. One is the cost, and the second one is the side effects. Now, obviously, the side effects so far, because of the cost itself, most of the times I've started this product on patients. The patients have discontinued, so we hardly realized what the side effects were. But now the real threat comes because in the Indian market, we are flooded with the products being produced in India. So we are going to be facing a huge surge in number of use of this product. Now, obviously, some of them have got license to use in diabetes. Some of them have got license to use in obesity. The obesity part probably will be covered by my colleague, Dr. Subir Rai, after this session. So I am going to be discussing here about GLP-1 analogs and the impact on the diabetes, and in the real world, what are we experiencing in the modern era? Now, obviously, the things that really worry us are about the side effects, because at the end of the day, we always tend to give a product to do good to the patients rather than being dragged in the court of law or by the council. So we need to be protecting ourselves before we start a product. Now, the GLP-1 analogs are notorious to cause side effects. Some of them probably are the research data, we don't know. Real world evidence is not that much. So let's discuss one by one some of the side effects that we face in our day-to-day practice. So first is, I think, the GI side effects. Now, who is going to take this? Who is more prepared to take this question? Anyone? Ashiza, you want to take this question?
I can. It is the nausea, abdominal pain, vomiting, diarrhea, and constipation. These are the main GI side effects. But about the side effects, patient needs a thorough counseling before we jump and embark on prescribing the drug. Because the meal is very important. Patient would be told that don't take very high fat, greasy or spicy foods. This is number one. And sometimes these are falsely attributed to the GLP-1. It may be non-GLP-1 causes also, they also come in the fiction. So they should be excluded by a thorough history taking. And about the side effects, for the nausea we can give the antiemetic, prokinetic. For the diarrhea we can give antidiarrheal, probiotic. For the constipations, stool softener, etc. we can give. And now trial has come up. Trial has come up that if we give the flexible dose, like the 0.0625 milligram weekly into 16 weeks, vis-a-vis 0.25 milligram weekly into 8 weeks, it has been shown that these flexible dose titration, they induces less nausea and also less asthenia. So this trial has recently come up. And again, some trial have also found that along with them GIP antagonist, if are used with the GLP-1, that also some trial, these are in this trial phase, that the incidence of nausea comes down.
We'll leave aside the GIP-1 issue because today's focus is mainly on the SEMA versus the glycemic control. Now, a few queries still remain. Now, if someone is already being started on 0.25, you get the side effects, then obviously you take the measures that you've just pointed out, and if the patient can't tolerate, you stop it. Am I correct?
Yes.
The next question is people who are being elevated from 0.25 to 0.5, and if they are getting the side effects, what do you do then?
So in that case, we'll have to again de-escalate the dose and to stabilize that the minimum dose.
And if you don't find efficacy with that product, do you still want to continue with the 0.25, or do you totally forget the GLP-1 forever?
No, I told that you will have to find out whether any other causes apart from the GLP.
No, but patient was hale and hearty before being started on the dose.
If you say a patient has gallbladder disease, so you will have to abandon the drug.
Ajay, you are willing to say something?
Just two small points. We initially used to have GLP-1 analogs initiated without cover of etopride, and approximately 15 to 17% was our discontinuation rate. But subsequently, we started counseling patients and started with etopride for initial 6 weeks, maybe 3 weeks with once daily, and maybe subsequently tapering to 50. And definitely the attrition rate has gone down to around 10%. And one more thing, if you are giving injectable GLP-1 other than the oral one, the incidence is way down. And definitely the other one that we are not talking today, that causes more diarrhea. Unfortunately or fortunately, SEMA doesn't have that much of diarrhea issues. I usually do not discontinue the medicine. We usually step down if it is required, but under the cover of etopride, we once again rebuild.
Dr. Rai, you want to make some comments?
I completely agreed with Dr. Biswas that we have seen that so many patients, they are tolerable with 0.25 milligram. But when we step up, they develop the GI symptoms. In that case, we don't recommend to stop the drug. We advocate that you continue from the low dose, then see, and always use the etopride. We have also using etopride for 6 weeks.
That's for patients who have been getting some benefits. You do have some efficacy with that. Yeah. But not for people, once you are escalating those to ensure that the patient is getting the maximum benefit. So when you are trying to escalate, and if you come across the side effects, you revert back to 0.25, but you are not getting any benefits, you stop it.
Stop it.
Good.
In this, I just wanted to add one thing.
Yes.
We all know that there will be side effects with all the drugs, including semaglutide also. But before escalating the dose or before stepping it down, counseling is very important of the patient to tell that be prepared, have patience, and there are in so many cases these symptoms subside after 3-4 days or say 1 week, because we have to continue this medicine for a longer time. So counseling also plays very important role with the patients, and we have to, if we tell them from advance that you might get these symptoms, just have patience, so this works out.
I actually agree with Dr. Arya. Definitely, before you start any GLP-1 based therapy or dual agonist, you have to counsel them. First, tell them the side effects. As we all know about the GI side effects, which we are discussing, 0.25, as especially we are discussing the SEMA, 0.25 for 4 weeks and then 0.5 for 4 weeks, just like that, every 4 weeks with this. So in that situation, instead of continuing, if somebody is in very severe GI side effect, you can say that you can continue 0.25 for 8 weeks in clinical practice. And then you can, in trial settings, definitely we go that like that. But after 8 weeks, you can go for 0.5 for another like that. And second thing, you initially ask them to divide their meals in 3 meal, 3 snack system. Means initially, suppose breakfast, divide into around 8 o'clock if you are taking breakfast, 8, half and around 10 o'clock and then around 1 and 3. And around 8 and 10, like that. If you divide a small meal size, frequent meals, and then these symptoms will be mitigated. Of course, etopride or domperidone is definitely going to help in situation to mitigate the side effects.
Excellent suggestion. Anyone in the audience who would like to bring up any issues with regards to use of this? Because I don't want to wait till the end, because I don't want to drag on, so that things can be clarified now and here only. Anyone? So now, next thing that we're going to move on to is the so-called pancreatitis, which even if you see the sort of data from Sustain 6, I don't think pancreatitis was an issue, but the caveat here is there is elevated enzymes, lipase and amylase. Now, I would be asking some very, very practical points. Now, you do a baseline GLP test of amylase lipase, you start GLP-1, and then I'm coming. And suddenly after a month you see the lipase amylase has gone up. What will be your next course of action? Ghanshyamda, you answer this.
If the amylase and lipase are more than 3 times the normal value and patient is in symptomatology, means patient in pain, abdomen, vomiting, in that situation you have to do the imaging. And the best part to do the imaging for pancreas is the CT scan, not the ultrasound. So you have to remember, if it is more than 3 times and having symptomatology, then only go for the imaging, otherwise there is no need. Continue with the same treatment. What do I do in my clinical practice?
Exactly, because just elevated enzymes, you don't confer anything. It's not that the patient has pancreatitis, because most of the times what we are really scared about it, we stop the use of GLP-1 and we think that the patient has developed pancreatitis, we try to play safe. So the take-home message is that up to 3 times, that's very important. 3 times rise in the basic enzyme is fine, but then the next question is, again, when do you repeat it? Do you escalate the dose or stick to that and again repeat it after a month to see whether the enzymes have gone up further? That's the next question. If the patient is not symptomatic.
If patient is not symptomatic, continue increase escalate the dose, because it is not like that. That is 0.25. You continue and you find there is a rise of the amylase and lipase twice the normal values.
No, I'm telling 3 times rise has already occurred after initiation. You have given 4 doses. And then what will you do? Patient is asymptomatic. Will you increase the dose or will you wait for another 4 weeks to check the amylase lipase again?
Actually, again after 4 weeks we will do that.
I think we should wait with the same dose and repeat it after 4 weeks.
4 weeks, yes.
Yeah.
So that is the practical tip for everyone, you know, because most of the time what we do is we stop the product, but the fear of pancreatitis, but that is not what we should do. As Ghanshyamda just now said, that we repeat again after another 4 weeks to see whether it has plateaued, come down, or whether it is escalating. If it is going up, then is the time the alarm bell rings. Ajay, you want to say something?
Just a screen USG can help, because there will be long food gap and quite a number of patients have been found to have GB sludge. That is another thing that often come across.
I have one question. So when we have this history of pancreatitis, just imagine a patient is having 20 years of history of pancreatitis due to gallstone. Will you start the GLP or you'll wait?
It's a really very tricky question, because once somebody is in pancreatitis, we are not supposed to prescribe the GLP-1 based therapy. But the here, point is, if somebody is in gallstone disease and having pancreatitis, you remove the gallbladder, everything is clear, so still question mark. So it is better to avoid, I'll say, if the history of pancreatitis. That is my
we
my
were
approach.
discussing the same thing in a meeting last week. Ashish, your neutral opinion about this. If someone has gallstone pancreatitis, are you going to start the patient on GLP-1 analog, or are you going to play safe?
No, I will first go for removal of the gallstone.
No, that has been removed. Everything has been removed from the patient's
Again,
body except the pancreas. Pancreas is still there. So what are you going to do?
Pancreas is still there. If the enzyme is more than 3 times, then
No, the patient's enzymes are now normal.
Yeah,
but had a previous episode of pancreatitis.
I can
Not
start.
idiopathic pancreatitis, but gallstone induced
I can
pancreatitis.
start because gallstone has been already improved.
Any other?
Probably
No, probably is not.
No
Is that
definite
people
answer.
Are, people
No
are waiting
definite
for your
answer.
expert opinion. Not probably is not
Subir,
going to.
Subir, your opinion, because we are using a huge amount of GLP-1
No probable
nowadays.
here,
Yes.
because people are going to take home the message and then they can't quote you that
Yeah,
because of him
let
I'm
the
in trouble.
Subir give the opinion, what he practice. Yes, everybody knows that. No, but you have to, in the way, in this era of medico-legal issues, would you like to start it?
This is
the point I want to come out
now
from you.
the discussion here today is to ensure that everyone goes home satisfied that they can prescribe the product for diabetes control now that the price has come down. So that's why you have to be very clear, because these are things you will not get in the papers, trials. They're going to I hope they're not going to criticize me. They're going to suppress the data, you know.
We have
so,
comment from.
Yes, sir.
Yeah, Dr. Ajay Kumar from Patna. I would like to mention that there is no absolute contraindication, number one. It's a relative contraindication, so there is no question of a medico-legal issue. Two, when GLP-1 receptor agonist trials started historically, at that point of time, nobody knew that pancreatitis is a contraindication. And several hundred patients of chronic pancreatitis were included in those trials with liraglutide, exenatide, and so on and so forth. And there was no increase in the risk of pancreatitis, and therefore, if a patient deserves semaglutide, he or she should be started. Absolutely no doubt about it.
Thank you.
Ravi. Many of our patients who had a history of gallstone pancreatitis, gallbladder removed, are on DPP-4 inhibitor by mistake. And they don't have any issue. So if DPP-4 inhibitor patients are able to tolerate it, gradually we can check whether on GLP-1 analog, whether the patient is complaining. For 1 month you can give a trial. If the patient complains, then you can stop, withdraw.
DPP-4 is something different than the GLP-1 based therapy. You cannot compare that. No.
This is a Ravi. You are talking about a supraphysiological dose, and that's a physiological dose. So you can't compare.
DPP-4 increases
Sir,
GLP-1 by twice.
Here the topic of discussion is GLP-1. We are not discussing DPP-4. Okay. So let us concentrate on it, and if gallbladder is removed, then should it be continued or not? That is the point which you have raised. And very rightly it has been mentioned by Dr. Ajay Kumar that there is no absolute contraindication. So we can continue. We can continue.
So the House thinks that if someone has gallstone pancreatitis in the past, and if the pancreatic enzymes are fine, you can jolly well give this product without any hesitation.
Keep a close watch.
Yeah. Any other
Keep
questions?
a close watch.
Yeah. Any other questions from the audience? No. Now, the next thing is, now other side effects, I don't think we are too much worried about it coming to medullary carcinoma or other malignancies or gallstones. Yes, these are probabilities, but if you look into the sustained trial data, we don't put that much of emphasis on this. Ashish, you want to say something?
Yeah, but one thing is in the US is causing a lot of turbulence. That is
I'm coming. The next one I'm coming. I'm not finished that. Next one I'm coming. The bullet one. The next is retinopathy.
Yeah. That is non-ataratic anterior ischemic optic neuropathy.
Is it? Yes, that is NOION.
1 in 10,000.
Yeah. Now the question remains, Even in the sustained trial, you'll find the data shows there's an increased incidence of retinopathy compared to placebo, isn't it? So what is going to be the approach in patients who you are starting on GLP-1 analogs who already have got retinopathy, be it proliferative, be it non-proliferative? Who is going to take this question? Ajay, yes.
Anyone with retinopathy, I am scared to initiate, I will not be initiating. If I have got a clean patient who has got no documented retinopathy, my first prescription reads, please get your eyes checked, especially to look for retinopathy.
So before initiating the product,
level,
you are going to...
I am going to write the prescription of GLP-1 on my first visit with add-on follow-up advice, get your retina examined before you come on the follow-up.
Dr. Goel, please.
No. It is not required. Of course, we have done even the step trials. We were the part of the Surmount trials, Surmount 1, Surmount 2. And so it was not mandatory. And even we start with the GLP-1 based therapy, both GLP plus GIP. It is not mandatory to start with the this retina checkup. But of course, I agree with Ajay. If somebody is in proliferative retinopathy already there, in that situation, you have to ask them to go for that. Otherwise, not in the routine.
Actually, NAION is due to ischemia. It is be to better control. There is some ischemia. So what Goel has rightly pointed out, if there is ischemic evidence, right, the proliferative retinopathy, so that is the pointer of ischemia. But who has advocated strongly a thorough retina examination before embarking on GLP-1?
So your advice is to ensure that the patient has a proper retina checkup before starting the product.
Exactly.
Dr. Arya, please.
Sorry. Can you please repeat?
Yeah.
What's it?
Yeah, sir, I'm taking this question. Retina checkup is not mandatory, but when the patient having the proliferative diabetic retinopathy, in that case we have to assess is GLP-1 is absolutely required for this patient. The subjects that should be subjective. If there is proliferative retinopathy, I will not start the patient with GLP-1 analog.
The patient has very poor control. The patient needs improvement.
There are so many other drugs we will try to control with that drugs also.
Obese patient, will you not start the GLP-1 analog?
So in my opinion, I feel like, most of the diabetic patients, when they come to us, we never know whether they are having retinopathy or not. First of all, screening should be there, whether they are the first time or a 5 years or 10 years, whatever. So that once the thing is gone, you cannot save it. Even if it's 1 in 10,000, that one is important, and he can see you. So it's better to rule out just the screening part, and once you rule out, then you can start.
I very much agree with him that in all diabetic patients, as a routine case, we go for the retinopathy checkup, isn't it? So
it is not
whether the
mandated.
patient is taking GLP-1 or SEMA or any other drug, that is secondary. But we go for the routine checkup, and that we should do.
No. About the retina screening, it is recommended that once every year you have to go for a screening of retina or retina examination, just like the foot examination. So that is a separate issue. But before starting the GLP-1 therapy, is retina checkup is required or not? So it is not mandatory.
It is not mandatory. It is not mandatory.
Yeah. Subir, how you practice?
Any questions from the audience? So let's ask the audience first. Subir will be answering lots of questions in the next session. So any questions from the audience?
Hello, I have two questions, but this is more as the role of GLP-1 agonist in HbA1c reduction or maybe co-administration with insulin. Because one patient is there with multiple oral hypoglycemic agents, maybe a sulfonylurea plus metformin plus SGLT2 inhibitor, but the adequate, and maybe also a DPP4 inhibitor, but adequate blood sugar control is not there. So should we think about switching from a DPP inhibitor to GLP-1 agonist, or should we go straight forward to insulin? And the second question is, once a patient is on insulin, what is about the co-administration of GLP-1 agonist with insulin for the other added benefits?
So let's divide into two parts.
Two questions.
First question, who is going to take?
I'm going to take. First of all, sir, I am taking your second question. The patient is on insulin, patient on OHs, including DPP4. Now we are planning to start GLP-1. In that case, co-administration of insulin is recommended
but always stop the DPP-4 inhibitors?
Yeah, because DPP-4 inhibitor and GLP-1, no extra benefit with DPP-4.
Now,
It is adding
my
to the...
question was that she is not having adequate
Okay.
glycemic control with DPP-4. Now we are taking off DPP-4, whether
If there is no adequate control, there is no point in starting GLP-1 with DPP-4. So stop DPP-4. Now the GLP-1 is there and other your OAD or insulin is there, their dose reduction is necessary. Otherwise, the patient will land up in hypoglycemia.
Okay,
I'm giving you answer. You see, GLP-1 is a very potent agent. It causes a A1C reduction up to the tune of 2.8 percentage of A1C. If somebody is doing poor control, patient is already on insulin, you off the DPP-4, you are starting with a GLP-based therapy. So always remember that there is a risk of hypoglycemia in combination with insulin and sulfonylurea. Rest others continue. So once you are starting the GLP-1, you can de-escalate the dose of insulin and of the sulfonylurea. You have to remember, this is the precaution you have to always remember. That is very important. Otherwise, you can start very well, and a lot of patients are on GLP-1 plus insulin, definitely.
And probably you can change your premix to basal and continue with it.
Dr. Adia,
Makes it a safer one.
Sir, as such also, we are keeping double caution on a patient who is on insulin and sulfonylurea, because there is always chance of hypoglycemia. So patient having taking both insulin and sulfonylurea, we have to be very cautious and adjust the dose accordingly.
I will take his first question, which was regarding like uncontrolled patient. What to do next, whether start insulin or just GLP-1. This particular question pertains to our population. Once we start the insulin, patient is more reluctant not to start. If the patient is obese, then we can always offer them. If they're having more complications, it's better to start insulin along with GLP-1. And make sure you need to de-escalate the dose as said by...
You carry on, nobody.
So we need to be making sure that we de-escalate sulfonylureas along with insulin. So there is no risk of hypoglycemia. I have seen like patient coming off all the OADs once started on GLPs.
I think the take-home message is that if you are not achieving control, put on GLP-1 analogs. If you are not achieving control, go on insulin. But be very careful when you are using with sulfonylureas insulin and GLP-1 analogs, because you may get hypoglycemia. Now, one thing, Ashish, that you mentioned that probably we need to discuss a bit, which is a very interesting topic. Why the combination of GLP-1 analogs with DPP-4 inhibitors are not allowed, or is it something that you follow, or what's the reason why you can't use it? Because one is preventing degradation of your endogenous GLP-1 and the other one is an exogenous GLP-1, which is a different molecule. So what is the pathophysiology in not continuing with both?
Sir, once you are blasting with a supraphysiological dose of GLP-1 from the outside, I don't think there will be any advantage of adding that pittance through the physiological way. It is the same way that we keep on
If
seeing.
someone was already on Ajay, on DPP-4 inhibitor, what are you going to do?
Sir, unfortunately come across prescriptions where glimepiride is combined with repaglinide, even till days. You are mimicking the same thing.
Actually, GLP-1 that we are using, it produces supraphysiological more or less stimulation. So there is no extra benefit with the DPP-4. So that is one, and that it is also adding to the cost. So it is recommended, there is recommendation that don't use, there is no extra benefit, only the cost will increase.
It's recommendation, but not contraindication.
No, but no extra benefit.
Here I can add like that.
No extra benefit. So how you are putting the
DPP-4 inhibitors increase the GLP level by the twice of normal, while the GLP-1 based therapy increase the GLP level by more than 5 times supraphysiological as we are taking. So once it is increased by supraphysiological, why will start with the DPP-4, which we have to withdraw?
Already on it, I just mentioned.
Yes.
Dr. Kumar, I would like to get your opinion about it. এই ওইটা কাজ করছে না মাইকটা।
Yeah, I will rephrase this question. We use GLP-1 receptor agonist, which stimulates insulin secretion in a glucose-dependent manner and suppresses glucagon in a glucose-dependent manner. DPP-4 inhibitor in situations of hypoglycemia increases glucagon. It's not the question of, I agree with all of you, that it's supraphysiological dose, so it is actually naive to use DPP-4 inhibitor with a GLP-1 receptor agonist. But looking at that property, number one, and number two, the fact that GLP-1 receptor agonist has been combined with GIP receptor agonist. Initially, we were told that GIP has absolutely nothing to do with this, and now we are getting extra benefit because of the GIP. In that context, now can we rethink on this, that a GLP-1 receptor agonist and DPP-4 inhibitor can be used together? We don't have any data, but this is a food for thought.
Any other comments? Ravi? Shubhi, do you have any practical experience about using both?
Well, I mean, none of the trials have got patients having DPP-4 inhibitors. They're all excluded. Okay.
That's obviously because they're competitor, isn't it? They won't do this.
Basically, we rightly for our assumption, what Dr. Ajay is trying to say is it's probably logical. But as Nashabda said, that when you are using the supraphysiological dose or support, when you are actually riding escalator, why do you want to climb the stairs? Just be the elevation.
Okay. Next topic of discussion will be the dosing. Now, in the real world, you want to add from the previous one? Not close as
Regarding the side effect, one side effect we usually ignore, that is the exacerbations of the psychiatric symptoms in the patient, those who are having comorbid psychiatric illness. Because I have seen 2 or 3 patients, those who are using the psychiatric medicine, they came to us for the obesity management. We have used even one patient with diabetes also. And we have seen that when we are step upping the dose, in that time there is aggravations of the psychiatric symptoms.
No, we will not discuss that because that's in the next topic of discussion, because anything to do with weight and sema, next one.
No,
you just said that higher doses reducing weight, so that's why we are not going to discuss
what he have told that about the psychiatric symptom. So in the patients who is already on psychiatric medication and all that, in that, before starting this GLP-1 based therapy, I think it is better to do a PHQ-9 questionnaires, the patient health questionnaire, and if there is positive, means more than 5, then you can have a psychiatric consultation, then you can start with that. That's the message. Because in all the clinical trials, in all the patients whom we start with the GLP-1 based therapy or GLP-GIP or even triple agonist, in that situation, we have to do each and every patient PHQ-9 questionnaire.
Okay. Ashita, do you want to add anything?
Yeah, some patients have history of medullary thyroid carcinoma in the family, or the patient might have that medullary thyroid carcinoma or meant to. I think those patients should be exempted.
Yeah, I think if you have already got an established history, then don't give it.
Yeah, and again, some patient may have some hypersensitivity reaction.
It's basically to avoid it. Don't dig your own grave, isn't it? Yeah. The second point that I'm going to discuss, we are discussing about side effects. We just finished. I don't think we have too much of time left because there's a session and after that there is lunch. Now the question remains is about the dosing. Now in the real world, what dose you people are happy to give to achieve reasonable control? Ajay, question for you, please.
If the patient is not been on any GLP-1 prior, we start with 0.25, escalate to 0.5. Earlier it was a different scenario because of the financial reason many of our patients used to do there, and almost 50% of our diabetic patient I am talking about, not talking about the obesity patients, say 50% of our patient used to be there. Maybe 30%.
So with even a dose of 0.25, you're achieving the target.
To start with 0.5 as a.
Now 0.25 you are starting with, but what I'm saying is, what's your day-to-day sort of experience with regards
0.5.
0.5. That is the ceiling that you're achieving.
Predominantly is to use.
Ashita?
Regarding the dosing, that is the weekly. If a patient suppose misses one dose, that lies some questionnaire. The patient has missed the dose.
So we can, at most, we can wait till 5 days. Now it is recommended.
No, I'm not telling that. I'm telling
3
that
days.
average what dose you are using in your day-to-day clinical practice. 0.5. Dr. Arya, any thoughts?
I agree. We are achieving our target with 0.5, but we initiate with 0.25 and then we escalate.
When you don't achieve the adequate results with 0.5, what do you do?
Average dose is 1 milligram generally. It's a 1 milligram, not the 0.5 in most of our cases, because they are already on all these problems and having not adequate control. So average dose is 1 milligram for diabetes.
So for the glycemic side, the achievements, you start with 0.25, and I think after 1 milligram, if you are not getting any good impact, better to stop it and not give any more. Questions for the panel, I think.
What is your take on oral semaglutide? Because now few generic versions are also coming. This is number one question. And the number two question is, one person is already on maybe 14 milligram oral semaglutide. Now we want to change him to the injectable one. So what dose we will be starting from?
Yeah. So 14 milligram of oral semaglutide is equivalent to 1 milligram of subcutaneous or injectable semaglutide. So you have to shift from 14 to 1 milligram subcut weekly is the dose.
So we can shift directly to 1 milligram dose.
Yes, you are not supposed to go for 0.25 for 4 weeks, then 0.5 for 4 weeks, and then go for 1 milligram per week. No, you can shift directly the day he have taken the last dose. Next week, 1 milligram subcutaneously per week you can start.
And Dr. Gali, which group of patients are you going to do it? Patients who are already on 14, you are switching to 1 milligram. Which group of patients are you going to do? The non-responders?
Those having side effects.
No,
those
one
having
is,
side effects
one
or
is,
tolerance.
no, one is, I tell you, patients, they want convenience because every day you are supposed to take empty stomach. 30 minutes you are not supposed to eat, and around 100 ml or 120 ml of water, not more than that, and they are hypothyroid also, so they want convenience. So some patients feel, Doctor, I want to convert it to once weekly, so I will find. So in that
Basically, it
situation,
is compliance.
compliance issue is very
Compliance
important.
issue is there. So
But how
that
you rate the
benefits.
effectiveness, the comparison to oral? If she's a compliant patient, then whether we will be continuing with the oral one, or whether we should switch over to the injectable one.
No. If patient is happy with the 14 milligram oral, we can continue with that. If patient want to switch for the convenience part, then you can switch to 1 milligram subcut weekly.
Any other questions?
And if we are starting a semaglutide now that generic oral varieties are available, should we start with an oral one, or should we start with
So there is no generic oral because SNAC doesn't have an alternative, and SNAC has got still the patent active.
Few companies are coming.
Sir, it is not a question of generic or the brand.
Cost factor is
data
always
is
there.
same for both, and we start with the oral.
You discuss with the patient about the pros and cons. It is the patient compliance that ultimately counts. If patient opts for oral, go for oral, and the 14 milligram, the patient then says,
Okay.
no, I will take injection, you go for injection.
I think we are about to finish the session now. Regarding the generic brands, I don't think we are going to discuss it now because they have just come to the market. Maybe next time after 6 months we are going to discuss about them. So with this, I think we have to wrap up the session. We are on time. So thanks to our excellent panelists. Okay.
Thank to moderator for excellent moderation. Give a big hand to Sabyasachi and whole team. Thank you.
Thank you, everyone. Thank you, Chairperson and the moderator, for moderating such a beautiful session on SEMA and diabetes. Our next topic will be SEMA and obesity. For this, moderator will be Dr. Subir Rai. He'll be moderating this session for this. And the panelists are Dr. Soumitra Ghosh from Kolkata, Dr. Anirban Sinha from Kolkata, Dr. Ravi Kant Saraugi from Kolkata, Dr. Supriya Datta from Kolkata, and Dr. Payodhi Dhar from Kolkata. Kindly join on the stage and another session, another grilling session on diabetes sorry, obesity and SEMA. Let's start it.
Can I start?
Yeah.
Right.
Dr. Subera.
Yeah. Uh, Good afternoon. The next session is semaglutide and obesity. Obesity is like elephant in the room. It's been staring us for a long, long time. We knew it was the mother of most of the metabolic disorders, but we could not fight it properly because we did not have any weapon to fight it with. With the advent of semaglutide and tirzepatide, the actual battle began. But very soon we saw the whole water is getting murky with a bit of vested interest. I'm sorry to say that. So we are having obesity clinic, obesity camp, obesity workshop, obesity CME, obesity conference, obesity certification course, and obesity specialist. Some of them are commercially motivated. So the battle which should have been the scientific battle has largely becoming commercial battle. So in this juncture, for the clinicians like us, we are facing it very difficult and challenging to choose our weapon carefully, logically, rationally, and ethically. So in the next half an hour, I'm going to ask a few very pertinent questions from a very star-studded panelist. Some of the questions will be a bit of repetition of the last prolonged session, but again, there is nothing called repetition in science, so you can always have different views from the different point of views. Right, so the ball starts now. I'll start my questions with Professor Soumitra Ghosh. Professor Ghosh, like all of us, you've been having patients with obesity, people with obesity every day in your clinic, okay? It's a huge problem. So what are the parameters that you use to call a patient you've got obesity? And how do you choose some of them, or probably all of them, for anti-obesity medication? Because not all patients actually qualify for anti-obesity medication. So how do you qualify? What is your message to the physicians? Pick up your patients properly, because that's the first thing.
So it's a very good question, because as you highlighted, that obesity has become a very rampant, epidemic almost in every country. So with this paramount rise in this number, so everyone is thinking that if I go to the doctor's clinic, doctor is starting some treatment for this, because there is a huge noise in the market and there is a commercial, push also to all these things. So it's a big question when actually to call a person obese. So these ideas have refined over these decades, because initially this age-old practice was to classify them with the basis of this BMI. Because BMI is a crude criteria, because they cannot differentiate between the muscle mass, the adipose mass, and the water content, the bone mass, etc. So it's a actually crude parameter, but they can at least screening tool, as a screening tool, that they're good, because most of these people, they actually identify this obesity by just a visual inspection. So it's not an inspection diagnosis. So as this concept came that the muscle mass, this adipose mass, and this bone mass, water content should be differentiated, and obesity is actually defined as an excess adipose tissue which causes some dysfunction in the organs and the tissues. So we'll have to classify, we'll have to identify this adipose tissue that is in excess, that is distributed in different parts of the organs and the tissues, and that is causing the dysfunction to these organs and tissues. So three things must be defined. So this concept came that if we can differentiate this adipose tissue by some way, so distribution in the clinic, it is very important to identify at least this, as a crude clinical criteria, this, waist circumference. And the waist circumference and the height ratio, that is also a very good clinical bedside clinic, in the clinic criteria. That is good, but the most important, which is to be practiced whenever it is possible, is the body composition analysis, because body composition analysis has become a very available tool. It is very easy, it can be done within minutes, particularly the BIA, if it is not DEXA. And these, with the advent of these newer machines, these BIA, bioelectrical impedance machines, they are giving excellent data. They are comparable with DEXA. And that can guide you enormously to selecting those people who are distributed differently, because this vector analysis of this BIA can ideally give you some idea how much of this adipose tissue is distributed subcutaneously and how much it is in the organs. Because subcutaneous adipose tissue is not going to create any trouble, unless some mechanical troubles. But the cardiometabolic problems.
Can I stop you there? Because it's not possible for us to have all those fancy gadgets in a clinic. Okay. No. So normally, what you do in your day-to-day clinical practice, which parameter do you normally use or most frequently use?
Definitely,
is it the BMI or the
body weight and the height? The BMI automatically comes. But in clinic, we often, very importantly, is that the vital parameter is the measuring of this waist circumference.
So for Indian people, I believe that rather than BMI, waist circumference or
that should be an
ratio
absolute.
Probably the better way.
Clinical inside clinic.
Who do you offer anti-obesity medication? When do you offer anti-obesity medication?
Anti-obesity medication should be only offered, because it is not this. Only this anthropometric criteria. When it is causing organ or the tissue dysfunction, because the staging is important. Edmonton obesity staging system that has to be applied. Whenever it is causing some dysfunction to the organs, so some complications, it is absolutely a complication-centric approach. Whenever there is, so in other diseases, we do not actually give all these medications to everyone whether come to the clinic. So there is some risk factor assessment when there is some subclinical risk factors are only present. When there is the obvious comorbidities are present, some end organ disease and this end stage disease, which should classify in the stage 1, 2, 3, 4. So whenever there is obvious comorbidities are present, then it is an absolute indication of this giving therapies. As per these 2025 ESI criteria, we should start thinking of these giving these therapies, particularly this, energetic way of giving this, treating those patients. Whenever this BMI to some extent is more than 27 and some comorbidities are there, and those comorbidities are not simple. They are high risk comorbidities like this diabetes, hypertension, dyslipidemia, fatty liver disease, which is called this MASLD, obstructive sleep apnea, PCOS. These kind of things should be there, and this cardiometabolic other complications are there. Then only we should think it is at least stage 2. And these stage 3 and 4, these are these other things.
I believe you have given your message loud and clear. So a patient who is severely obese or the patient who is moderately obese with having comorbidity related to obesity, they qualify for it. But the thing is, it's written in all guidelines that anti-obesity medications are adjunct to lifestyle modification. Without lifestyle modification, they don't work properly. So our advice regarding structured lifestyle modification should go hand in hand with anti-obesity medication. Otherwise, many patients, they think that, well, I'm having such expensive medicine, what the hell? Why should I do exercise and watch my diet? So diet and exercise is the first thing, along with anti-obesity medication. Professor Ghosh, thank you so much.
Thank you.
My next question is to Dr. Ravi. Ravi, not all patients with obesity are diabetic, and not all diabetic patients are obese. So, how do you decide which patient is suitable for tirzepatide and which patient is suitable for semaglutide? Because these are the front-running two agents till we get the others.
So, 50% of our patients attending our obesity or diabetic clinic are obese patients are diabetic. Okay, and that's what nowadays we commonly use diabesity. And regarding your second part, that whom you decide to give semaglutide or whom you decide to give tirzepatide. So basically, we all know that combined action of GLP-1 and GIP-1 receptor agonist has a more effect on, basically, is the more important the therapeutic goal. What goal you want to achieve, the body weight, how much weight, what weight loss you want to achieve. If the patient is morbidly obese, like BMI around more than 40, 45, so we need to give this patient tirzepatide. But if the patient is only mildly obese, like BMI around 30, 35, So we can start with semaglutide, and if the goal is not achieved, we can switch over to tirzepatide.
Is it the fact that you may start with semaglutide and you end up changing to tirzepatide? I mean, this is a very, very subjective way of looking at things, because even if somebody is taking Mounjaro, suppose, that is tirzepatide, you don't necessarily have to go to the highest dose.
Yeah.
And if you achieve that, your achievement
The
is
maximum
that.
tolerated dose.
I mean, do you look at any other parameters which sway your decision? Like this patient has got cardiovascular problems, so he's
based
more
on the
for
rightly said. So based on the basically semaglutide has more clinical evidence right now, and based on SUSTAIN trial, the Pioneer trial, and the SELECT trial, semaglutide has slightly aid, but trials are also ongoing with tirzepatide also.
Right.
So let the time come, but till now semaglutide has strong evidence in cardiovascular benefit, weekly therapy, and regarding other use of other agents like sulfonylurea, insulin, we don't have that much cardiovascular benefit.
So far, I mean, if you look at the evidence is heavily in favor of semaglutide.
Yeah, that's true.
Okay, when you look at only obesity management, probably Mounjaro has still got an edge over it. But if you look at the evidence of addressing other comorbidities like cardiovascular, like renal, like fatty liver disease or muscle, sleep apnea, all of them have got heavily tilted towards semaglutide. So if a patient has got all those or some of them or a bunch of them, I would rather not think about giving semaglutide, because the evidence will be supporting me. Well, I mean, tirzepatide is coming up with newer evidence, but so far the evidence is heavily in favor of semaglutide addressing all those comorbidities. Thank you very much, Ravi. Next question is to Anirban. Anirban, when you use semaglutide for weight management, okay, how do you counsel the patient about the quantum, duration, sustainability? Because these are the basic three questions. Dr. Babu, কতদিন ধরে নিতে হবে? ডাক্তার বাবু বন্ধ করে দিলে কি ফিরে আসবে? ওটা কি আর কমানো যাবে না? So how do you address these questions? Do you always have to go for the highest dose, or you titrate, individualize, and how do you do that? What do you look at it? I mean, I understand that this is a very new molecule. It's been there in our disposal for the last 6 months only. So how are you managing these questions?
First, for a patient to initiate on semaglutide or any GLP-1 or GLP-12 or whatever it is, first we need to discuss with the patient in details regarding the benefits and the potential concerns and the side effects. So benefits can be discussed on the weight reduction, as well as patient on diabetes, if it is even non-diabetic, there are glycemic reduction and metabolic benefits beyond that. That is to be discussed along with, like as Ravida has kindly pointed out, the cardiovascular benefit. Beyond the cardiovascular benefit, in the STRIDE trial, there are peripheral vascular disease also gets improved. So as the MASH events or the hepatic fatty liver disease or the MAFLs are improved. There are data on neurocognition improvement. There are data on around OSA, obstructive sleep apnea, around 17 events reduction per in the gross in the meta-analysis. So there are many other add-on benefits, including, interestingly, there is a few data on smoking cessation. So these are very peculiar and add-on benefits because it handles the neurotransmitters as well. But again, regarding the duration of the treatment, we need to discuss with the patient regarding it. Officially, it is lifelong, because in the SUSTAIN 5, there are data on if you withdraw the drug, at most, but still after the 2 years, there are 20% weight loss is there, what you have achieved, but 80% is gained back. So you gain back the weight, that is another point, but I try to convince the patient that if you go on diet and exercise and maintain a good lifestyle, I think the weight gain back is not that significant, even if you had to stop because of the financial reason. Otherwise, officially it is to be continued, till now it is throughout life.
Right. So basically, you tell your patients to continue as long as they can, as long as they can afford, as long as they do not face any major side effects, which I will come to later on. And regarding this sustainability, is as long as you take the medicine, you maintain your weight loss. It will reach a plateau after a year or two, because it's not a fact that they'll keep on losing weight. I mean, many patients who are taking SGLT2 inhibitor after losing 4 kilo, they come panicking that I'm losing weight too fast. Do I lose weight? Is the weight loss continue? The thing is, we do not have any data apart from the trial data, how much weight they will gain back. Because if you look at
there is a stoppage trial on the semaglutide.
Yes, so we have got 4 years data at the most. We have got the switching off data is coming back mostly.
Yes, that is it. 80% comes back, but still there are 20% less.
So exactly. Just I tell them that once you lose weight, once you surviving eating less, you will feel extra energetic to continue your exercise.
Yeah, that is the point.
Once you get rewarded, you feel like pushing harder. Probably that way take them forward. But this is a very tough question to answer, that how much weight will I gain back after spending 2 lakhs in the first year? Yes, Ravi.
For the first month, we get the metabolic benefit, and after that we start reducing it. So but that need to be explained to the patient also.
Exactly.
And regarding the maximum dose, you asked, most of the patient goes up to 1.7 and 2.4 is hardly needed for the weight loss in my patients till now. But again, most of the patient cannot tolerate it. That is the most concern.
The first third month, the weight usually reduces. That's visible.
Exactly. And many times we have seen that the patient hasn't lost much weight in the first 2 doses. The 0.25 didn't work, 0.5
It never works. It is not meant for working. The official trial doses started from 0.5.
Exactly.
0.5 to 1 to 2.7. That's a trial.
Till few weeks back, it was very difficult to keep them motivated because of the price.
Right.
Now the price has come down, so it is easier for them to keep taking it.
Again, just to mention that till now the generics are not approved for the weight loss.
Yes.
And regarding the conversion, maybe you asked once. What is that?
Coming to my next question to Supriya, it's been kind of going to be a repetition of the answers. How do you screen a patient for the suitability of semaglutide? That's number 1 question. How do you counsel them to to minimize the side effects? And third question is, how do they tackle with the missed dose? Because if you look at the papers, the missed dose for anti-diabetic dose and missed dose regime for anti-obesity is slightly different, not exactly the same. And third, very, very difficult question is, if somebody, a lady who is 22-year-old, obesity, comes to you and asks for this, how are you going to continue it? What are the things you tell the patient? Because the patient might get married and just think about pregnancy. So how do you overcome the hurdles?
So good afternoon. Shubir, you have bombarded me with questions in one breath.
You can answer.
In one breath. Your initial part was already answered by Professor Ghosh. We have to screen patients for suitability and eligibility, because as you said rightly, we are bombarded with so many generic versions and people are confused. I mean, our community is confused which and what to prescribe. So first and foremost, not all patients are eligible for GLP-1. That's the first thing which everybody should, an RA or the incretins, whatever. So it's not like the anti-diabetes which came over the last decade, like the SGLT2 and the DPP4. So the criteria is the BMI for all practical purposes, rest aside the methodology for screening for obesity, both clinical and technical. So BMI, sir has already announced there is a different global and Indian, so with or without comorbidity. So that is the BMI criteria, and eligibility, we know per the definition that patients with obesity, without complication, with complication. Now suitability means we have to screen patients for absolute contraindication, that is the boxed warning for semaglutide, any personal or family history of MTC, medullary thyroid carcinoma. That is one, or it's a part of the component that is meant to. So this is one strict absolute contraindication.
Absolutely.
Apart from that, there are some relative contraindications which were discussed in lengths and breadths in the last session on diabetes and SEMA. So still our patients are not health literate. So Western indications, Western guidelines may not be applicable to our set of patients, because first of all, we are very much at a loss to counsel and explain, and we don't have so much time also. But for this molecule, we have to think about. So thinking about the history, pancreatitis, gallstones and all, those are relative contraindications. So we have to screen, and also about the retina, which was also discussed in the previous session about that NION and proliferative diabetic retinopathy, as you all know, rapid reduction of glucose. But we are talking about obesity, but still the same applies. Now, coming to your second question about how to tolerate the minimize the GI side effects, because you know whether oral had more, but injectable from a practice has less GI side effects. But nonetheless, it's a GLP-1 RA, so it will have a baggage of 60-70% have that, at least on the initial dose as well as escalation. So it's the simple formula of go low and go slow. I mean, take frequent meals, at not the 5-6 meals which we, 3-4 major meals we have. It may be divided into 5-6 meals, and then water. Don't take before meal enough of water and after meal also. And apart from that, you can have some home remedies also. Ginger is one, up to, I saw in the studies, 15 milligram. You can have ginger water, ginger tea, and avoid greasy food. And also, these are the main things which we can tell. And there was a discussion by Dr. Ojoy about the prokinetic, but I wonder, it may help in the initial stage, but because it is contraindicating, one is slowing the gastric emptying. The main purpose is efficacy. So if we slow, I don't think etopride or a prokinetic will be of use, but maybe initially we can give to our patients, because it is very distressing after we start. And coming to your
the last question.
It was, missed dose in the indications for Ozempic. No, it's the third question.
The last but one question.
For pregnancy, I'm sorry, for the missed dose, the ideal thing for Ozempic and this Wegovy is a bit different. It's written that for Ozempic, 5 days lag you can be given, and for this Wegovy, at least 2 days. It should not be within 2 days, and if you cannot take on consecutive days. So you miss that dose, give it for the next week. And if you miss for 2 weeks, go to your doctor again, because it may be restarted. And the last question about the pregnancy, if you are planning a 22-year-old, so in the pre-pregnancy counseling, the patient is already on a GLP-1 receptor analog, at least 2 months gap. And one more of the, 2 months. 2 months.
Yeah.
It's 2 months. Right. Yeah. So many questions. Hopefully I've answered. I haven't missed anything.
So what Dr. Datto told us, that the best way forward is to tell the patient eat small amount of food at one point of time, avoid hot, avoid spicy, avoid greasy food. Don't gulp liters of water along with your food, because you'll feel pukey, because semaglutide side effects are mostly upper GI, whereas the TJ side effect is mostly lower GI. And then some home remedy, you may tell the patient, try. Pregnancy, Supriya has told us that the patient has to stay away from it for at least 6 weeks. It's basically 6 to 8 weeks. The half-life is 7 days, so 4 half-life will wash out the molecule from the system, and then in a couple of weeks more probably put the patient in a safer state. Right.
Also, one more thing about operation. That is also an important part, anesthesia. So 1 week.
I'll just ask this question as well. Yesterday I got a referral from the PAC, a patient who's been on semaglutide, whether we should continue it. And another PAC referral I got is for obesity management before surgery. It's a very funny thing happening actually. So when somebody is going for surgery, So, Anirban, can you please tell us what do you suggest, when to stop it?
Again, the guideline talks about 2 weeks. Only one guidelines talk about it, the anesthesia guideline. But again, rationally, I ask them to stop the last dose. That's good enough.
Right. Okay, that's great. Good. My last question is...
Planned surgery.
Yes.
But only thing they are concerned about is the eructation and the anesthetic.
Exactly.
So, but planned anesthetic is high grade consent is taken if the emergency surgery. So it is already accepted.
Right. The last question is to Dr. Poydidar because we are running out of time.
Sure, sir.
Just today I saw in Times of India a slimming company is offering diet, their specialized diet and Ozempic. It's a 3 months, 6 months, 9 months, and 12 months package with kind of money return policy thing if it doesn't work. So we are kind of deluged with all kind of commercially motivated campaign is happening in social media. People are advising each other which one to take, which one not to take. So the doctors are confused. So what is your message to our colleagues? How to go about it? How to pick your medication logically, rationally, and ethically? What do you suggest? What's your take-home message for them?
Right, sir. Very important question it is because in the 7th of April we have celebrated World Health Day. And this year's WHO guideline, depending on this kind of misleading infodemics, is that health for all and science first, before commerce. So the message is very clear. What the guideline says is primordial. That's last. And there is no scope of this kind of infodemics. And the newer initiatives are coming up. As far as I am concerned, I am aware that Government of India is coming up with some initiative very soon to work against infodemics in non-communicable diseases. Because in this year, that is a very important part of India's budget. So that is also coming up. So I hope that this kind of misleading things will go away. At the same time, we should understand that balance between creating awareness and creating infodemic. So awareness should be there, and what should be done and what should not be done, it should always be on the basis of already set, proven, trial-tested guidelines and nothing else.
Thank you very much. Last parting message from the chairperson.
I have a comment. Most of the time what happens, we just think it's an anti-obesity drug, and people come to us without doing anything. First of all, we should make sure that the patient is started on lifestyle modification, because this is the part which he is to continue through whole of his life. It's not a substitute. Exactly. It's just an additive. It will just push him. And that's what these companies are doing, the marketing, the commerce which you talked about. So we need to counsel them that lifestyle modification is the only thing that will be continued to their life. If you're not continuing the drug, suppose you stop the drug, obviously you'll get the weight back.
Absolutely. I would love to add 2 points just when you discussed. One is to increase protein intake. That's very important when we are taking it. And have the resistance exercise, because muscle loss is also a factor. I have seen that in my patients. Yeah.
Absolutely. Completely agree with you. Thank you very much, esteemed panelists. I believe we have run out of time. So thank you very much. You had a very live discussion. Just one question can be allowed from the floor if you want to ask. Otherwise, we'll call it a day. I believe they have had enough of discussion regarding semaglutide. So thank you very much, panelists. It was wonderful.
Can I comment one?
Yes, Professor Ghosh.
As highlighted, the lifestyle modification must be continued for 6 months, then only semaglutide can be initiated. That is a myth. If there is a criteria, we can take the consent. We should make the patient should be agreeing to these lifestyle changes. And if there is some staging is so, we can actually, we should not wait. But patient's readiness to change, that is also
it should go along with the medicine. Lifestyle modification must go along with the medicine. Yep.
Because we're running short of time, we'll stop.
Thank you very much. Thank you so much.
Thank you for moderating such a beautiful session on SEMA and obesity, and thank you to all the chairpersons. We will have a group photograph. For the next session on SEMA and CV health, I'd like to call moderator Dr. Suvro Banerjee. The panelists are Dr. Arjit Ghosh, Dr. Anindam Pandey, Dr. Sorry? Okay. Dr. Ankan Pathak, Dr. Sunil, I think Lahila, sorry if I'm pronouncing it wrong, Dr. Shilanjan Roy. We are making the arrangements, then we'll start the session.
Probably wouldn't have mattered actually. Just two slides. And,
No issue.
yeah, sure, not a problem. Yeah. So could I request the panelists to be on the dais, please, because we are running out of time, I think. We're already late by half an hour, and it's best to start. Your chairs are ready. Don't wait for them, just grab them. Anyway, whatever. This slide can be seen over there as well. It's not going to obstruct. So let us start if you are ready. I think. No, that's all right. আবার চেঞ্জ করতে গেলে দেরি হয়ে যাবে আবার দেরি হয়ে যাবে Okay. So are we good to go? Okay, great. So good afternoon. Of late, cardiologists are becoming a bit more interested in three comorbidities and three drugs. And these comorbidities are diabetes, chronic kidney disease, and obesity. And we have three drugs, SGLT2 inhibitors, the incretins, and the MRA, that's phenylaron. And today, what we are going to do will probably restrict into two of these drugs, just because we don't have that much of time. And you have already heard a lot of discussion in the last 2 days about the guidelines and the different sort of how you actually and when to prescribe, what are the indications for prescribing incretin therapy. And let's put this into practice. And so what I have actually two hypothetical case scenarios, and we can discuss what we should be doing from a cardiologist's point of view. So my panelists, are you ready? You must have gone through those slides already. But then I'll just read it out quickly. It's a 68-year-old man who is asymptomatic and was seen for follow-up because he had history of hypertension, diabetes, and an NSTMI, for which he had a PCI2 LAD 4 years ago. He's on ecosprin, atorvastatin, metformin, and ramipril. BMI was 28, blood pressure 140/70, and no signs of heart failure. Creatinine is 1.6, and our estimated GFR is 44. Electrolytes are normal, fasting blood sugar 174, and PP 228, HbA1c 8, and thyroid liver function test normal, and lipid profile LDL 75, triglyceride 218, HDL 32, ACR 130, and NT-proBNP at 350. ECG shows Q waves in V1 to V3, narrow QRS complex, but left anterior hemiblock. X-ray is normal. And the echo shows EF of 55% with concentric LVH, LA diameter 3.9, which is slightly on the upper side, but still within normal. E by E prime 10, again, not grossly abnormal. And TR velocity 2.8. So with this, before we go to the question, I will just go for a vote quickly. So we'll start with Orijit there. So what, just tell me, what would be your next choice? Is it SGLT2 inhibitor, semaglutide, or tirzepatide?
My next choice should be SGLT2 inhibitors.
Okay. Dr. Pandey?
Are we allowed to gather more information like albuminuria or nothing?
Albuminuria is there, given there, 130.
Okay, and are we allowed to give two medicine together?
That will come later because the first question says next. Whether to come two or, I know, that we'll discuss
So
later. If
then
it's one.
I'll go for SGLT2 inhibitor.
Okay. Dr. Leela?
Thank you and good afternoon, everybody. The choice is, of course, SGLT2 if I had to give the first medicine.
Right. Dr. Shilanjan?
For me also, first choice will be SGLT2.
And Dr. Ankon?
Sir, SGLT2 is...
Good. So all 5 of the cardiologists believe an SGLT2 inhibitor should be started here as the first choice. So let's start now in a different way. Again, going back to Dr. Ghosh, Orijit Ghosh. So why do you think SGLT2 inhibitor should be the drug of first choice here?
What we are getting from this slide is the patient is having an established coronary artery disease documented with 2 stents in the left anterior descending coronary artery. We have telltale evidences of HFpEF, and we have a high NT-proBNP 350. We have some echocardiographic features which might be fitting some of the major or minor criteria, echocardiographic criteria of HFpEF. So if we put all the scoring systems together, we will definitely land up diagnosing these patients as a HFpEF patient. So the primary intention will be to decrease the chances of heart failure events in these patients, which the patient is quite prone to. So that is the reason behind that I am much more keen in adding SGLT2 inhibitors to my patient. And the BMI also is to be taken into consideration because first, I will ask my patient to do all sort of lifestyle modifications so that the BMI can be brought down. If this is not possible, then we have to think of something else.
Okay, just regarding your comment, NT-proBNP is high. Now this patient has a creatinine of 1.6 and also a BMI of 28. So how do you give an allowance for the level of NT-proBNP here? What should be the threshold in this case?
So, so far as the correction for BMI is concerned, one thing we should be keeping in mind that more obese the patient, the chances of him to have an increased NT-proBNP might be less. And so in the various trials that we find in patients who are having heart failure along with obesity, the cutoff points for patients who are obese or overweight is low for NT-proBNP. And that is why even in the most heavy patients, the hefty patients, the cutoff is 125. So in that respect, my patient is having a clear-cut hike in the NT-proBNP level, despite this obesity paradox. And yes, regarding the creatinine, first we used to think that it got to be adjusted with the level of creatinine, but a frank rise of NT-proBNP, even on the top of a raised creatinine, should be a matter of concern.
Dr. Arindam, do you agree with this, or how you are going to?
Yeah, I completely agree. I would add one more point about the NT-proBNP. The patient is in sinus rhythm. Had it been atrial fibrillation, the value would have been changed. Now, in the randomized control trial, though we know many factors which change the level of NT-proBNP, but they did not actually took those considerations. Rather, they made a very clear-cut inclusion and exclusion criteria. In presence of atrial fibrillation, in absence of atrial fibrillation, the cutoff was given. So on that regard, this NT-proBNP value of 350 is definitely high for this patient. We should take it in account, and ejection fraction is 55%. So clearly the patient is having heart failure with preserved ejection fraction. Though the symptomatic classification as per the history, it is NYHA class 1.
Dr. Leela, do you think this patient has heart failure? Because we are saying it's a heart failure with preserved ejection fraction. What does it meet all the criteria for heart failure with
So
preserved
coming
ejection
to your point, yes, the patient seems to be in heart failure, preserved ejection fraction, because NT-proBNP is raised, and though the ejection fraction is 55, so he qualifies for heart failure, preserved ejection fraction. But one important point of SGLT2 here, which is important apart from what he said that it has been to be used in heart failure, preserved ejection fraction, and the patient being diabetic here, the kidney protection is also important, and the creatinines are high. So we need to target that part also, that the creatinine would also be taken care, and decline in GFR with time would get, the progress would be slowed, and at the same time there will be the microalbuminuria which the patient has may improve with time. So SGLT2 is of course the first choice, and the patient is definitely in heart failure, preserved ejection fraction, because this NT-proBNP, apart from being slightly on the higher body weight, 28 is by definition, I think that this is high NT-proBNP, and he is in heart failure.
Okay. Yes, Dr. Roy, your comments.
I will slightly differ from my other experts regarding a frank diagnosis or a very easy diagnosis of HFpEF. Because this patient, in first place, he is not fulfilling the basic criteria of symptom. He is not having any symptoms of heart failure. So at max, we can tell he is having stage B heart failure or pre-symptomatic heart failure. Either way, he cannot be labeled as a stage C heart failure. So it is an incidentally detected echocardiographic few diastolic parameters which is elevated, a single NT-proBNP value without any symptoms of heart failure. We cannot, by definition, define the patient as HFpEF. Stage B heart failure is okay. Either way, SGLT2 inhibitor will have to be on board, because this patient is having diabetes, and irrespective of the glycemic status, high cardiovascular risk, established CVD, SGLT2 inhibitor should be there. So we'll add on SGLT2 inhibitor, not with an idea that this patient is having HFpEF, definitely at risk of developing HFpEF in the future, or symptomatic heart failure in future. But my rationale of adding SGLT2 inhibitor will be patient having diabetes, glycemic control, CKD, high risk of development of future HFpEF.
Okay, so Dr. Ankon, now what the panelists so far have said, like they have disagreed a bit. So what do you think on the, they have agreed on what we should use, they have disagreed whether heart failure exists or not. So what are the criteria to establish a patient has heart failure with preserved ejection fraction? What are the things you must look into?
So the first thing that I would look into is the HFpEF score here. So if I really go into the scoring criteria, I see that the patient is aged more than 65, the patient is hypertensive, the filling pressures are on the higher side, there is no atrial fibrillation, but then if I go to the score, it will probably be in the range of intermediate risk of heart failure, between 6 to 9, between 2 to 6. So, but again, if we correlate it with a higher NT-proBNP, maybe that might lead us to a diagnosis of heart failure. But again, as sir said, I think stage B heart failure would be the correct.
So the patient doesn't have any symptoms of signs of heart failure and no history that he had prevo.
So if the patient is not having any symptom, what is in the first place the reason for doing HFpEF scoring system? No point in doing the scoring proactively with a patient who is not having any symptom or asymptomatic.
Okay,
Absolutely
we
correct.
don't disagree on this point. What Shilanjan has said is quite correct. At least symptomatically, he is not in heart failure.
Yeah.
Okay, fine.
So going back to Dr. Ghosh now, so why wouldn't you start semaglutide here? I mean, if you start semaglutide here, will you be wrong, and why? Or why not?
Not exactly. I don't be wrong, because nowadays, I am not an endocrinologist, and I am not a very frequent user of this molecule. But still, if we go by the standard international practicing guidelines, a patient of atherosclerotic cardiovascular disease in any ways is a candidate, if he is a diabetic, is a candidate for this GLP-1 analogs. So there is no denial of the fact. And yes, if I am to use semaglutide even as an anti-diabetic agent, that does not hold me from doing it, because it is supported by the various guidelines. So it is quite okay for using semaglutide. But if I have to use it, the first drug, I have to use it, it should always be an SGLT2.
So he mentioned about some evidences, latest evidence. So what evidence do we have, Dr. Pandey, regarding semaglutide?
So first of all, I did not mention about GLP-1 analog because of the criteria.
You mentioned I can only choose one. Had it been my own actual patient, I would have given both SGLT2 inhibitor and GLP-1. If you see the diabetic guideline, how to treat diabetes, after metformin, next medicine which comes, if there is atherosclerotic cardiovascular disease, GLP-1 analog comes first, oblique SGLT2 inhibitor. His HbA1c is 8. He's already on metformin at a good dose of 1000. So I feel I have enough option of adding both. Why I am saying so? Because this patient, SGLT2 inhibitor should be coming first. We all agree. Plus minus heart failure, albuminuria. So that there is clear-cut microalbuminuria 150. So that will be taken care of in a better way by SGLT2 inhibitor. We do not have more adequate data in favor of GLP-1 analog. So here SGLT2 inhibitor actually scores over GLP-1 analog. Second thing, 1.6 creatinine, if we calculate the eGFR, though the BMI is on the higher side, but he will be having some form of CKD. So CKD progression actually can be halted in a better way with SGLT2 inhibitor compared to GLP-1 analog. Though GLP-1 analog are completely safe in CKD patient, but the progression is better halted by SGLT2 inhibitor. But to be very honest, I have more confidence on GLP-1 analog because of their property to tackle the ASCVD. These are the molecules, they have clearly shown to reduce the inflammatory marker, CRP, in a better way. And all the trials of GLP-1 analog, they have clearly shown that event reduction actually is better with GLP-1 analog. There is some difference among different types of SGLT2 inhibitor. IMPA have some benefit, DAPA plus minus benefit, but irrespective of that, GLP-1 analog, they have clear-cut idea. Yeah. And another thing, ASCVD is also ischemic stroke. So ischemic stroke, there is always a confusion about SGLT2 inhibitor. This particular gentleman is also a very high-risk candidate for future ischemic CVA. So that actually compel us to use GLP-1 analog in preference to SGLT2 inhibitor. So had it been my patient, so, yeah, I would have added both the molecule
Dr.
together.
Leela, would you agree with him that you will add both? And if you agree, then how do you add them? Actually, do you start them all together or you start in sequence?
So I agree, and I go one step forward, that I would add even Finrinon from very beginning, because I'm worried about the renal health. Because the patient is not a symptomatic heart failure.
Yeah, intentionally you have kept the Finrinon aside, okay, as I've said.
So I agree in that case that yes, the SGLT2 and semaglutide in this patient can be given together, or like we can start semaglutide and motivate him to get an anti-diabetic in the form of GLP-1, because the cost is an issue. You need to tell about the side effects, and the patient has to be mentally prepared to take it for a longer time. And we say that it should be on board, and you can come and think about it and come to us. Now the choice of SGLT2 is important here, that I would start with the empagliflozin because he has a atherosclerotic background, and of course semaglutide will be the GLP-1. So I would motivate. So you can go by any of the injectable, and because the patient is diabetic, so the injectable and oral are same, because the orals are to be used as.
But the patient is also overweight.
That is anti-obese. So I would tell him that you require a semaglutide maybe in the next sitting or in the next. You come prepared mentally, and then we can start.
Okay, Dr. Roy, why not tirzepatide?
Incretin mimetics as a group can be considered, but as of now, present date, semaglutide has got much robust data in terms of ASCVD risk reduction, 3P MACE and 5P MACE reduction, much robust RCT data as well as real world data.
So do you think that SURPASS OT trial does influence the decision?
Not so much, because SURPASS CVOT is basically a CV safety trial to assess the safety and non-inferiority in comparison to dulaglutide. So it was done with dulaglutide, tirzepatide versus dulaglutide. But if you look at semaglutide, they have got dedicated CVOT trials in the form of SELECT trial, which is an extremely well-designed trial incorporating more than 5,000, nearly 17,000 patients followed up for nearly 7 years, more than 5 years. So beautifully designed trial, even in non-diabetic individuals, obese with ASCVD, 20% MACE reduction. We have got SOUL trial with oral semaglutide, 14% MACE reduction in more than 50 years. Dedicated CV outcome trials. So definitely, and RCT, if you go by RWE, real world data, we have got steer and score data, which is showing, semaglutide clearly scoring even over tirzepatide. If you look at the steer data, which was published last year in ESC, head to head, tirzepatide, semaglutide, same patient population like that of the SELECT trial, that is non-diabetic, obese, established ASCVD, semaglutide given an additional 28 to 30% MACE reduction on top of, in 3P MACE reduction 29% and nearly 22% MACE reduction in 5P MACE head to head with tirzepatide. So it is an, exceptionally good value, good results that we have got semaglutide. So definitely my choice will be semaglutide. I will preferably if the patient is okay with injectable semaglutide, because this patient is obese also. And there is no indication of oral semaglutide as an anti-obesity medication. It can be best given as an anti-diabetic with some cardiovascular benefit. But when I am targeting obesity, when I am targeting a component of possible HFpEF, and I am targeting ASCVD, my choice will be clearly injectable Ozempic or Wegovy.
Sir, I have one comment.
Yeah.
Actually, the SELECT trial is a very robust trial from cardiovascular point of view. So, the PI was asked why were diabetic patients at all excluded. So, what he answered was that it would have been unethical not giving an obese patient with established atherosclerotic cardiovascular disease GLP analog. And that is why there is no doubt about it that GLP-1 analog is a... Now the question is whether even without diabetes we are going to use this drug, and that is supported by the SELECT trial.
I have few more points to add. As Shilanjan very nicely mentioned, ideally we should be going ahead with injectable. I should also try to focus that the SOUL trial, the oral semaglutide, the kidney outcome data is not that robust compared to injectable. This is number one. And number two, we have only evidence with injectable semaglutide in heart failure with preserved ejection fraction. We do not have any evidence with the oral molecule. So in this particular case, if I really want to use, I would be very sure to use injectable.
Right. So this question actually was meant for Dr. Pathak. So when would you use an injectable and when will you use an oral semaglutide?
So again, so injectable semaglutide has really more robust data as far as CVOT trials are concerned. So if I really have to use a drug for reducing CVOTs, I will always prefer an injectable rather than an oral semaglutide. And the other thing about, sir, whether to start SGLT2 and semaglutide at the same time, maybe we can wait for 1 to 2 weeks after starting SGLT2, because SGLT2 leads to a little bit of volume reduction. And again, if the patient starts vomiting when he's on semaglutide, maybe that can lead to a volume depleted state for a few days. So maybe a weekly gap between the two, maybe start SGLT2 inhibitors and then wait for 2 to 3 weeks and then start an injectable semaglutide.
Okay. We'll just quickly move on to the next scenario. And this is actually, it's not moving. Why is it not moving? Oops. Can we just go to the, could you help us here? It's not moving to the next slide. Excuse me. Excuse me, it's the next, it's not moving. The next slide is not moving. Why is it's not moving? Okay, yeah, got it, yeah. Thank you. So quickly, we don't have much time left, but things that have changed. This patient is short of breath on exertion, has mild pain in legs on walking. BMI is 33 now, and EGFR naturally has gone up because the creatine remains the same. And NT-proBNP is 950, has LVH with, with all features of heart failure, diastolic dysfunction, I would say, and an ankle brachial ratio less than 0.9. So this, are you going to do anything differently? So here, Dr. Ghosh.
So now I think Shilanjan will have no reservation regarding diagnosing patient as a HFpEF, and probably this is what was going to happen with the patient. And anticipating this, the drugs could have been given. No, I am not going to do anything else. Now he is having telltale evidences of HFpEF, so my treatment remains the same. And we have enough data regarding the usage of semaglutide in this group of patients in heart failure. We have the STEP diabetes subgroup study. These are all sister studies for that matter, STEP-HF without diabetes and with diabetes, which have all shown the same results, though these are not outcome trials.
Correct. So, Dr. Pandey, do you think here is a case for starting both of them together?
So, as there are many physicians who are present in the audience, first medicine I'll prescribe here is not an anti-diabetic medicine. I'll give diuretic.
Correct.
The patient is having a clear-cut florid heart failure. The patient has gained weight. So, first thing is loop diuretic. Everybody should be very clear about that. It has a class 1 indication, even in heart failure with preserved ejection fraction. And after stabilization,
just because of lack of time, we are just keeping
no problem, no problem. Now again, it's same. We can use both of them because both of them have fantastic, data. Injectable. Here again, I'd like to emphasize that injectable semaglutide actually is far superior compared to injectable tirzepatide in terms of heart failure, preserved ejection fraction associated with obesity. The data of tirzepatide is not very good. So again, our choice is very simple, SGLT2 inhibitor plus injectable semaglutide, and I do agree with Dr. Ankon that first SGLT2 inhibitor, 2 to 3 weeks of gap, followed by injectable semaglutide. It's a very good rational way.
Okay, Dr. Leela, but do you think there is no evidence for tirzepatide here in patients with heart failure?
So, we have 3 important trials. The STEP heart failure trial to prove because he is in heart failure, preserved ejection fraction. We have the FLOW trial because he has renal impairment and that is important. And we have the STRIDE trial because he has got a peripheral vascular disease. So I think I would go with semaglutide and injectable from very beginning, and maybe along with SGLT2 or maybe just a week later of SGLT2 that I would start the semaglutide because that's important. We have more evidences with semaglutide.
Dr. Rai, anything else to add? Microphone.
Again, emphasized by Arindam, the pragmatic way to initiate these molecules will be in this particular patient, start with a low dose of loop diuretic and SGLT2 inhibitor straight away, reassess the renal function. After 15 days, how the patient is doing, expected that the EGFR will go down to a bit, reassess it after another 52 weeks, maybe after 1 month, try to reduce the dose of loop diuretics, maybe withdraw loop diuretics from your prescription, continue with the SGLT2 inhibitor. If the EGFR is stable, patient is maintaining a stable EGFR without any evidence of AKI, then it's the right time to...
What percent of EGFR reduction will you...
up to 25 to 30%, I am very happy with to continue with SGLT2 inhibitor safely. Further decline, continuous decline, I have to stop and reassess for other causes.
So, Dr. Pathak, anything
then
else to add?
Then I will reassess in the maybe after 1 month I will start GLP-1 because either way GLP-1 is going to act slowly, not as fast as that of an SGLT.
So, last word from Dr. Pathak.
So, my point is if we remove the atherosclerotic part from this, if we have truly an obesity driven heart failure with preserved ejection fraction phenotype, can we then use tirzepatide in over the injectable semaglutide?
If it is a purely obesity driven or obesity phenotype driven heart failure where inflammation is the predominant cause and obesity is driving the heart failure, underlying pathophysiology by inflammation and fluid overload, definitely why not tirzepatide? If the patient BMI was 35 maybe, patient was not having ACVD,
I think we have to stop here. We are already far beyond our stipulated time and we can carry on the discussion sometime later. So thank you very much for all the panelists for the excellent discussion, and so we will just finish here.
Thank you to our moderator. Thank you to our moderator, Dr. Subro Banerjee, who moderated it well. Thank you.
As we are running short of time, I take the privilege of calling upon my panelists. I am Dr. Soumyabrata Roy Choudhury, who is supposed to moderate the next session, which is going to be a very interesting session, but without interested people. So could I call upon my esteemed panelists and the thin audience which is there, if you could please join your hands together for Dr. Debraj Ash, please. Is he here? Illa. Illa. Okay. So, Dr. Obro Choudhury, Kolkata, please. Obro, have you put in your slides? Yeah, okay. Thank you. Dr. Mohsin Aslam, yeah, please. Dr. Aparna Chatterjee, yes, Aparna. And Dr. Orgo is already there. Huh? Okay. Your name, please? Okay. Okay, you're the chairperson. So, would you, there, Arakta chair lag, because Dr. Josh would be coming? I don't know. No. He won't be coming. Okay, fine. So, could you, if you have the microphones, please introduce yourselves to the audience.
Good afternoon, everyone. I am Dr. Obro Choudhury. I am a rheumatologist practicing in Kolkata.
Good afternoon, everyone. I am Dr. Aparna Chatterjee. I am presently second year DM resident in RG Medical College and Hospital in Department of Pulmonary Medicine.
Good afternoon, everyone. I am Dr. Orgo Samanto, consultant gastroenterologist, SSKM, Kolkata.
Yes, sir.
Good afternoon all. I am Dr. Mohsin Aslam. I am a consultant at Asian Institute of Gastroenterology, Hyderabad.
Myself, metabolic physician, Dr. Hitesh from Ghaziabad.
Okay, thank you. So today we are supposed to talk about semaglutide and other organoprotective roles. I had put in more questions for respiratory medicine, expecting Dr. Josh to be here. And well, IPL is going on, and if you have to look at the molecule of semaglutide, no person better than Ravi Shastri could describe it. He came in as a left-arm spinner, then became a top order batsman and all-rounder, then entered into broadcasting and commentary, and now he's ended up as the coaching and lead of the Indian team. Similarly, semaglutide came in as a molecule for diabetes, then it went into obesity, and it proved all the benefits for diabetes for the heart, kidney, and now it's entering into the liver, the MASH benefits, and now we are going to discuss about other systems also, the pulmonary, the rheumatological benefits, etc. So, to Dr. To one of our two physicians friends, in which patient profiles do you preferentially initiate semaglutide? Early type 2 diabetes versus advanced? Mics are not working?
I will definitely start in early type 2 diabetes mellitus because last 2-3 days we have seen so much data about role of semaglutide in preventing microvascular complications, in reducing inflammation. So if you start early, and it will also help in reducing the inflammation, and it is shown CV benefits, renal benefits, its benefits on liver. So definitely I will start in early diabetes, and yes, even in advanced diabetes, the patient needs for better glycemic control, I will start in advanced diabetes. It's like both the patient, but early diabetes, yes. And even the guidelines now recommend to start this in early diabetes with established ASCVD risk or those who are having ASCVD, irrespective of whether the patient is on other OHS or not.
Well, next to other physician for obesity, at what threshold of semaglutide do you start? Overweight versus obese, BMI cutoffs in Indian population?
When we talk about the overweight versus obese, and especially the BMI cutoff, as the World Obesity Federation is coming, like BMI is no more the
exact parameter to define obesity. So we should have that body composition analysis if possible. And for the Indian population, the BMI is 23 is normal, after 25 is up overweight, and after that 31 is obese. So in Indian patient, we have to be very careful with when we categorize them as overweight or obese. And we need to start as soon as possible after initiating lifestyle modification.
Thank you. To our gastroenterologist friend, Dr. Shamanto. Yeah. What's your approach to use of semaglutide? Let's forget the pre-diabetes part of it. In NFLD or NASH, now renamed as MASLD or MASH.
Yes, sir. So, for our MSLD patients, those patients who are obese with diabetes and who are having advanced to moderate to advanced fibrosis, that's F2, F3 fibrosis, in those patients group, the studies have shown a definitive benefit in MASH. So, in those select group of patients, we are using at present.
Not in steatosis?
Steatosis also, sir. So, MASH benefit is there, and not in cirrhotics. Those who have gone to the stage of
F4
cirrhosis,
is not indicated. F4 is not indicated. Yes. That's all. How does, to Aparna please, how does semaglutide induced weight loss influence outcomes in obesity-related lung disease? Is there any evidence of benefit in COPD patients with metabolic syndrome?
Well, sir, so in case of OSA or obstructive sleep apnea, as its name suggests, it is associated with the obesity. And in the OHS, 90% of patients of OHS, they present with daytime hypercapnia and they are associated with the OSA. So definitely semaglutide, though it is approved, but it causes the weight reduction as well as it also reduces the obesity associated systemic inflammation. So it has definitely benefit in case of OHS and OSA. And in case of asthma, I must mention that obesity and asthma is a very bad combination because obesity leads to aggravation of asthma, and poorly controlled asthma ultimately causes the patient's reduction of the physical exercise that leads to obesity. So this is a double-edged.
So the vicious cycle needs to be broken.
This is a vicious cycle and double-edged sword. Bad combination. So semaglutide actually it actually reduces the inflammatory markers as well as causes the weight loss. So it also helps associated with the other supportive therapies, inhaled corticosteroid. It helps in the better management of asthma. Number one. Number two is there evidence of benefit in COPD associated metabolic syndrome?
Let me interrupt you.
Yes,
Let
sir.
me go to your previous A.
Yes, sir.
So, patient with diabetes, obesity and asthma, and patient with only obesity and asthma, your choice of agent. With only obesity and asthma, diabetes, obesity and asthma, will your choice in both cases be the same?
Sir, no. Definitely in case of if it is associated with type 2 diabetes mellitus, then along with the other management, we will think about the semaglutide because it also helps in the reduction of the HbA1c, better glycemic control. But sir, in case of obesity and asthma, along with the lifestyle modification, dietary management, inhaled corticosteroid, if that is not managed, then only I will think about the anti-obesity medication after proper counseling of the patient.
Okay.
And in case of COPD with metabolic syndrome, sir, as it is associated in most of the cases with dyslipidemia, hypertension, type 2 diabetes, so after optimization of the management of COPD, we can think about the semaglutide if it is needed.
I think this question has already been dealt with in this hall with Dr. Ajay Kumar standing up there and telling that in the trials with liraglutide and semaglutide, pancreatitis patient was included, and so I'm skipping this question, it has been decided. So, going to Abro, he has put in a few slides of his own. We practice in very near location, both of us in Lake Town, but this is first time we physically met. So, this is a digital world. So, does semaglutide have direct anti-inflammatory or immunomodulatory effects? Any role in reducing CRP or cytokine burden in chronic inflammatory diseases?
If you're asking can we compare semaglutide with methotrexate or TNFi, the answer is no. The semaglutide has all the immune cells, they have GLP-1 receptors, and semaglutide has action on them. And it has been shown that there is reduction in the cytokine levels as well. but whether it is the reduction due to the reduction in the visceral adipose tissue mass, that is yet to be answered. So till now, what the experimental data shows that there is some effect on the immune cells, but then as of now, we cannot replace them with the methotrexate or other immunomodulatory drugs. What is believed that the improvement in the rheumatologic diseases is mostly due to the inflammatory burden, which is due to the reduction of the visceral adipose tissue, the systemic inflammation. And most of the trials of semaglutide have actually shown that there is 30 to 40% reduction in the CRP, which is again not due to direct effect on the immune cells, but it is an indirect effect on the reduction in the systemic inflammation.
Thank you. To Dr. Mohsin, how do you initiate and titrate semaglutide to minimize GI side effects? Your strategy. And I'll go to our gastroenterologist friend then.
So I start with the very lowest dose, that is 0.25 mg, observe for 4 weeks. If the patient has no side effects like nausea, I'll uptitrate it to 0.5. In case the patient has severe symptoms, then I'll ask the patient to initially make it once in 15 days. Then once the patient gets used to, again I'll go to 0.25 mg every week. No symptoms, then I'll uptitrate to 0.5 and slowly 1 mg and 1 at 2.4.
Yeah. Dr. Orgo.
Yeah. So to minimize the GI side effect, so it is start low, go slow. So because in studies it has shown that a rapid increase had been found to be the strongest predictor of vomiting or GI side effects. So in similar fashion, like Dr. Mohsin said, I start at the lowest dose and then gradually increase.
That he mentioned that he gives it 15 days apart.
So
Is
that
it?
usually I don't do that.
Because that is nowhere there.
I've seen an endocrinologist, he practices like 0.125. The patient is having a lot of acidity issues, and if he's not able to tolerate, then 0.125 can be tried for 2 weeks, and then we can titrate to 0.25 and henceforth. That is one of those strategies people are approaching. It's not written in the guidelines, and it's not advisable.
We have a publication with liraglutide where we started with
Minimal.
0.2 and then we went up, but then all these different pens coming in, you need to be very conversant with how many clicks. Because the 0.25 pen goes to the next dose, it has got 150 clicks in all. 0.5 has got 150 clicks in all. But the 1 milligram pen onwards has got 300 clicks. So you have to be very careful about which pen you are using and how many clicks to give. So the 0.5 pen at 19 clicks will deliver you 0.125. So going to my gastroenterology friend again, how do you counsel regarding nausea, vomiting, dehydration risk, rapid glycemic improvement and retinopathy worsening we'll set apart because that has been already talked about. Yes.
So what we tell them that
your patients are with liver disease, they already have a bit of nausea, etc.
Yes.
So it will be more difficult for you to counsel. So what is your strategy?
So what we did is firstly we stratify the patients. So whether they have any pre-existing risk factor like functional dyspepsia or pre-existing gastroparesis. So in those patients we tell them previously that there is going to be the symptoms. So and we also tell them to give small frequent meals. So that will be one preventive measures. Then for the dehydration risk, to take water, adequate water intake. And another thing is that to avoid fatty meals.
Do you use any prokinetics or anything like that?
So in symptomatic cases we use, but the response is unlikely to have benefit.
To my Dr. Mohsin, please. Patients on insulin or sulfonylurea, you cannot withdraw the insulin or sulfonylurea. Do you reduce the dose? How do you initiate these patients on semaglutide?
It depends whether I'm using for weight management whose sugars are under control or I'm adding as an add-on for better sugar control. So if the patient is having good control, I'll reduce the dose of insulin and sulfonylureas. But if the sugars are not under control, I'll start with semaglutide, uptitrate the dose. Once the sugar level starts coming down or if he experiences mild hypoglycemia, then I start reducing the dose of medicines.
So you do prescribe regular SMBG monitoring for the patient. Yeah. Question 2, we have to go a little bit fast. Can semaglutide reduce apnea, hypopnea index in obstructive sleep apnea independent of CPAP?
Sir, there are some articles showing that as the semaglutide causes direct and indirect effect on the obesity, it reduces inflammation as well as it reduces the weight. So it is supposed to reduce the AHI, but there is proven by tirzepatide in surmount OSA trial, which was published in New England Journal of Medicine in 2024. It has proven that it reduces the AHI properly. And the second question is, sir, in case of...
No second question. We are skipping a few
Okay,
questions.
okay,
Okay.
sir.
Obro, effect on bone mineral density with rapid weight loss. What do you expect?
There is mild reduction in the hip BMD, but clinically it does not translate into the fracture. So improvement of the resistance exercise, adequate protein intake, that's all we would advise. And regarding sarcopenia, again same, resistance exercise and adequate protein intake. That is
So, Dr. Samanto, risk of gallstones or cholecystitis with rapid weight loss is well known. Using how to use? Do you at all use in patients with chronic pancreatitis? History of chronic pancreatitis.
So in patients of chronic pancreatitis, you have to be very careful, very cautious there. And the risk of gallstone is there because of the radical saturation, but we just be cautious in those cases, nothing.
Okay.
For chronic pancreatitis, we'll avoid this.
Yeah.
It's better to avoid. Why to take risk?
Yeah. Going to Aparna. What is the risk of aspiration pneumonitis due to delayed gastric emptying? Somebody has come in with a semaglutide. You need to intubate. The impact of the drug is still there. Maybe 2 days ago they have taken. So what is the risk of aspiration pneumonitis? Have you experienced it due to delayed gastric emptying? And any precautions you take before doing a bronchoscopy or other sedation procedures?
Okay, sir. Regarding aspiration, so previously the thought was, there are old school of thought that it increases the aspiration chance. But in case of aspiration, if we consider the drug only, is in high dose, in escalating phase of the dose, and in case of oral dose of the semaglutide compared to the weekly injection, it increases chance of aspiration, as well as said before any procedure, the anesthetic drug also increases the chance of aspiration. So previously in 2023, when the American Society of Anesthesiologists guideline was published, they told that drug to be drug to be paused in case of weekly, 1 week before the procedure, in case of daily at the day of procedure. But sir, thought has totally changed after 24-25. Now the British England Journal of Anesthesia and the other after multidisciplinary discussion, society recommends that there is no need of withholding the drug in case of low risk patients who have low possibility of GI complication. But in case of high possibility of GI complication, definitely sir, the measure should be taken, and we should individualize the cases before doing the procedure.
Okay. To Dr. Samanto, how clinically significant is delayed gastric emptying with semaglutide? Second question we'll skip for the interest of time.
So semaglutide definitely causes delayed gastric emptying, but the response is in the initial period of the treatment, and it is also transient. So the satiety and delayed emptying, it is in the first few.
To Obro, use in patients on chronic steroids and any concerns in autoimmune disease flares?
It helps in mitigating the adverse effects of chronic steroids like weight gain, increase in hyperglycemia. And regarding autoimmune disease, as of now, there is no interaction with any of the DMARDs or biologics that we use. So there is no problem in using both of them together.
Any observed improvement in FEV1 by FVC or symptom scores in obese asthmatics? I think
Yes.
you've answered this.
Yes, sir. Yes, sir.
We have
Because it causes the system. It actually sir, reduces the systemic inflammatory cascade nuclear factor kappa beta and the type 2 cytokines which play pivotal role in case of asthma pathogenesis. So definitely it reduces airway inflammation, and there are not enough studies till date. We need to do the studies. It is supposed to reduce the FEV1 and FVC definitely, sir. If we compare the pre-procedure and the post-procedure spirometry comparison.
Dr. Samanto, role in NfALD MASH, histological improvement versus biochemical only. Does semaglutide reduce fibrosis progression?
So
As per the data available till now, because
Yeah.
Essence is not completed, we cannot comment definitely on it. Yes.
So the latest Essence trial, sir, so that showed definitely there is a histological improvement in the ballooning, steatosis, it has improved. The progression fibrosis, it's the evidence is not consistent. We need more data. Some studies have shown that it has halted the progression of the fibrosis, but sir, we need.
You have two molecules, resmetirom and semaglutide. They are available free to your patient. F3, which one would you choose and why?
Sir, semaglutide.
Yes. Patient cannot afford. The trial doesn't permit you to give two.
Then
It has
I'll get
got two.
semaglutide, sir.
Huh?
I'll get semaglutide.
Okay, thank you. Why? Both of you?
Sir, resmetirom, first of all, it's not available in India. We have to procure it.
I said trial, both are available with you. You can
both
give only
available.
one drug.
Both should be available. I think then I'll prefer resmetirom, sir.
Okay, so the house is divided. Bro, impact on osteoarthritis symptoms via weight reduction versus direct effect. Can it delay need for joint replacement?
Well, it definitely causes weight loss and it can delay need for joint replacement. But some preliminary evidence has shown that it has effect on chondrocytes also. But that is not clear. Right now, the effect is mainly because of the weight reduction.
Any evidence in psoriatic arthritis? You are in the slog over. You have to take every ball. Come on.
So, yes, psoriatic arthritis is believed to be a metabolic disease nowadays in comparison to rheumatoid arthritis, and there is data not on semaglutide, but a recent publication on tirzepatide that ixekizumab, which is used in psoriatic arthritis, if used in combination with tirzepatide, it has caused increased lowering of disease activity when combined with the biologics alone, and there is no interaction with the DMARDs of biologics.
Should semaglutide be considered a systemic anti-inflammatory metabolic drug?
Well, if a patient has metabolic syndrome, obesity, then yes, but in our diseases like rheumatoid arthritis or autoimmune diseases, no.
Aparna, who are the ideal candidates beyond diabetes whom you would put on semaglutide in your unit?
Sir, if
Obese
I consider,
asthmatics is
yes,
one.
If I consider, sir, my domain, there is proven in case of OSA patients with obesity, but that is also proven by the tirzepatide in SURMOUNT OSA trial. Semaglutide is yet to be proven, sir.
What are your three most, to the two physicians, three must give counseling points before starting semaglutide?
First of all, I'll tell them lifestyle modification, diet and exercise are more important along with the injection. Second thing, this is not some wonder drug that you can take it for few months. Once you lose your weight, it's a drug of the chronic disorder, so you have to take it as like you're taking for diabetes medicine.
It is like spectacles. Once it goes up, you shouldn't take it out.
And the third thing is, again, don't try to overeat. Even if you feel full at 4 to 5 bites, stop it there, and again, after 1 to 2 hours, you can again continue meals, but don't try to overeat.
You?
Along with his points, the most important point is protein intake should be increased. Resistance exercise should be included. And make sure that lifestyle becomes a discipline rather than just an additive effect. And the ones, even if you're coming off the drug, the lifestyle should be continued because the weight loss or the things will be coming back.
Any questions from the audience?
Any questions?
Any questions?
There is a mic behind. Behind you there is a mic.
Oh, mic.
Important cardiovascular trials that we have, all have shown to decrease the HSCRP at least, and there will be a substantial, and it might not be very useful from Dr. Raichaudhuri's point of view.
No, I'm a Dr. Raichaudhuri. He is Dr. Chaudhuri.
He is Dr. Chaudhuri. So it might not be very important.
Rai deyar odhikatta amar.
Rai deyar odhikatta amar. তো যেটা বলার সেটা হচ্ছে গিয়ে যে আমাদের কার্ডিওলজির তরফ থেকে কিন্তু it has definitely shown to be very beneficial, and the decrease is quite significant. That might be very useful from rheumatological point of view.
Ajada, any questions? Comments? Yes.
Let us not confuse between HSCRP and CRP. For rheumatoid, we measure the CRP, not the HSCRP. That macro level, it doesn't work that way. Well, weight reduction may help for osteoarthritis just because of the weight reduction itself. But the muscle weakness may deteriorate if the patient is not adequately motivated. But one thing before the initiation, I think it is prudent to ensure that we have taken adequate history of eye, whether the patient have undergone eye examination. It would be medico-legally safer to get your eyes examined by a qualified ophthalmologist, including retinal examination. And second thing, probably it is prudent to note down any history of thyroid ailments, especially the thyroid surgery in the family.
Since I am the moderator, I am asking you a question. In
Sorry,
your
sir.
patient with obesity and
Yes.
not with diabetes, do you still examine the eye?
We should. Whenever I am writing a GLP-1, I am writing it a practice.
Fundus exam.
Because examination of the eye, just to save my subsequent follow-ups.
I think
Okay.
we'll close the session, sir.
Yes. Before closing, let's look what obliques did. After, give my slide up, please. Sure, yeah. After listening to all the experts, obliques decides on taking semaglutide. And then, what he does is he runs to catch a boar, physical activity. He takes the boar, but we advise him to take the boar's 1 or 2 hourly gap in small pieces, not all at a time. And then he does resistance training. And this is what he becomes. Thank you so very much for your kind attention.
Thank you. We'll
And
be
thanks.
closing the
A good, big round of applause to all our panelists, please. Let's give it on the mic so that it appears louder.
Thank you,
you so
everyone.
much.
We'll be closing the SEMA symposium, and the next sessions will be taking place in the another hall, metabolic milieu, and we'll be closing the session here. Thank you, everyone, for being. We will have a group photograph, sir.